Hello.
Hello, ma'am. Your voice is audible. We are
Good morning, Rima ma'am.
Yeah,
We'll be
hi.
just starting in few minutes.
Sure, Hetty. No problem.
Yeah, we just are waiting for everybody to join in.
Sure.
Yes, ma'am. Thank you.
Yeah.
Good morning. I'm not able to.
Hello. Hello, Rucha.
Headphone नाके दो ना.
Hello.
Good morning, Dr. Patel.
Good morning, Rucha. Wonderful meeting.
I can't
Finally,
hear you though.
here.
One
Good
second.
morning.
Some problem is there still. Hello.
Hello. Can you hear me?
Yeah, Dr. Patel. Good morning.
Yes. So I had some parking problem in the meeting.
You have some parking problem.
In the meeting, my car was not getting parked. That's why I'm late by 10 minutes.
I know. That's why we are all running late. We'll all use the same excuse of yours.
But we are enjoying the meeting. Yesterday's sessions were awesome, wonderful.
Great.
We
Thank
would
you
like
so much.
to listen to them again and again and discuss as you rightly
Yeah,
said.
in fact, I think some of the sessions will have to all regroup and do it like a journal club.
Correct.
The
Absolutely.
DAPA HF and Dr. Akshay Desai, and today again we'll have what is CV.
Yes.
Exactly, who's the PI. So I think that will be a
In the morning, we had discussion with Dr. Mahadev Desai also. He was also of the same opinion that we should have some local discussion about
Yes,
the
it's like
inputs
a
that we have
post-ADA,
got from.
post
Yes.
CMC.
Yes.
Best of CMC. I like that. Let's do that. And then we'll do one session per week so we can actually learn, Yeah.
Correct.
So, Hardik, can we start without further ado? We are 10 minutes behind and we don't want to be very late for the day. But
Everyone is here. Sunil, Ramesh, and Dr. Rima.
Yeah, I'm here, but I'm not able to start my video.
Okay, that's fine. I've seen you.
Yes. But
Good
morning. Sunil here.
Yeah, same here. I'm not able to start my video.
Yeah.
so good morning,
Hello,
everybody.
everyone. This
Rucha,
is
it
Good
was
Rima.
a
morning,
very
Yeah.
Rima. How
excellent
are
Good
you?
morning. Good
Yeah.
morning, Rucha. Good.
Thank you, Ramesh, and for all your comments and deliberations and everything. We made
I
Ramesh
enjoyed thoroughly, and it was
yesterday.
excellent.
Thank you. Good discussion in CVOT, Ramesh. Good. I liked your equipoise, the glycemic equipoise question. You got Shashank rolling with that
Yeah,
question.
thanks.
Correct.
Yeah.
I
Did
missed
you
that,
come-
Sanjay, who is
Ramesh,
the winner
because
of today's?
Sorry.
Yeah, you are in other hall. I knew, with Dr.
yes.
Sameer.
So we had simultaneous sessions, so we could not attend.
You are batchmates, Sanjay. You are with
No.
Sameer Kapadia.
Samir Dhani was 1 year senior and Samir Kapadia was 1 year junior.
Tamaro bole.
Right
Okay,
from
okay.
our
So that is the way you are sandwiched, eh?
Right from our school days.
Sanjeev
then
Pathak is the
college,
sandwich,
then-
chutney. He's the butter. He's the good part in the sandwich. I wanted to say this that they are
नहीं,
the
नहीं,
bread.
नहीं.
Bread कौन खाता है? हम तो butter के लिए
but-
sandwich
but
खाते हैं.
you
cheese
use
के
the
लिए.
you use the word appropriately, chutney.
Chutney नहीं.
But
Chutney.
by the way, Sanjeev, who is the winner today? Whom should we give the prize today?
Listen, the
well-
contestants are also there, so I'll just.
I think we'll have to
I've sent
listen
a
to
grading
them.
judging
Yes,
rubric.
yes.
Because I have gone through the abstracts.
Yes.
Sanjeev bhai, we are listening your conversation.
Let's
Shailesh
see.
is already
Shailesh bhai,
there.
it's an
No
honor.
nepotism.
Rucha madam, good morning. Koel
Good
sahib,
morning.
Good morning, good morning,
Madam,
Shailesh
all
bhai.
of you.
It's
Dr.
our
Priyanka
honor to be
has
the
not
judge
joined.
in
Yeah,
a
we can't
meeting
judge
where
Shailesh bhai, yeah?
Shailesh bhai,
Shailesh bhai, pardon
so we'll
us.
try to be as unbiased as possible.
No, no. All of you are very good and neutral, as we are very clear.
Nobody's.
So can we start our video now?
Rucha madam, permission આપો.
नहीं, you cannot start. Host has disabled it.
હા, અત્યારે અમારા મત-
Give me a minute. I'm just calling to find out.
Oh,
They were
that's
having
fine,
some
that's
trouble.
fine.
Give me 2
We are
minutes.
absolutely free.
Thank you.
17 જણા ચાલુ થયા છે
શેમાં? अच्छा.
આ પાર્ટિસિપન્ટ્સ ની અંદર
ઓકે
નીચે.
ઓકે હા બરાબર 14 મારામાં 14 બતાવે છે. પેનલિસ્ટ 14.
હા તો બધા
અને
panelists
attendees
જ છે આમાં.
બરાબર.
Everybody
ત્રણ
is
બીજા.
a panelist. Yeah.
અચ્છા
બીજા 3 તો એ લોકોના પેલા કોમ્યુનિકેશન વાળા
જી.
પાર્ટિસિપન્ટ્સ નથી બતાવતા આમાં.
સંજીવે તરત પોતાની જાતને રોકી.
અરે સમીર ઇઝ હિયર.
હા, તે પેલી ગુજરાતીની ભૂલ પકડે ને,
હા
તે પકડીને પછી તરત રોકી લીધી તારી જાતને.
શેમાં?
But Sanjeev is known for that, Samir bhai.
17 જણની વાત હતી ને.
હા ના એટલે આમાં પાર્ટિસિપન્ટ્સ એક્ચ્યુઅલ કેટલા છે that we can't make out.
No, because it's a Facebook live.
Bansi
No?
has-
Facebook live.
Bansi sent me that more than 12,000 people have registered. Right?
We have reached
Great.
registrations of 12,000.
હા, રજીસ્ટ્રેશન 12,000 છે.
And at a time 2,000 જણા હતા.
2 થી 3,000 હતા દરેક
હા,
room.
that's very
એક
good.
વખત 4,000 બી હતા કંઈક ને,
Almost
એક
5,000.
લેક્ચરમાં.
It's a grand
5,000.
success.
Yeah, very good.
Yes, definitely.
આ તો હજી વધારે સારું થાત જો લોગિનમાં શરૂઆતમાં તકલીફ ના પડી હોત ને. અનફોર્ચ્યુનેટલી ટેકનોલોજીમાં હજી many times things
થઈ જાય. These are the things which are beyond our control. So,
હું ને સુનિલ હમણાં જ વાત કરતા હતા કે ટેકનોલોજી ઇઝ સપોઝ ટુ મેક અવર લાઈફ ઇઝીયર
yes.
ક્રિએટ લેસ પ્રોબ્લેમ્સ, પણ એવું થતું નથી હોતું એક્ઝેક્ટલી.
This has to be developed overnight. Nobody expected this much flow on this technology in last 3-4 months. All of them have developed it to a new level.
We are in the learning curve.
And we must be thankful to Hardik
Good morning,
because
all.
he has
Now
taken
delegates
up
can
this.
hear you, so we will restrict your personal conversations. We are going live.
Yes. Okay,
So-
fine.
But sometimes the delegates like to also hear us that we are
Yeah.
all, you know, on the
It is
same
like
page.
it is like Gavaskar and Harbhajan Singh.
So let us start with-
Eavesdropping is always
Yes, sir.
Yes. Let us start with praying for all the COVID sufferers as well as the Amitabh Bachchan family.
Yes.
And
Rucha,
Give us
can
one
you
more
give
minute.
us
I'm
2
just
minutes
making
now?
sure all the contestants have arrived, and then I'm just seeing one person is not there, so I'll just make sure the link has been sent to everybody. We had a small technical glitch with yesterday's link that we sent not working, so apologies for that. Just give us one more minute to get started.
okay.
Background change.
But I think Sanjeev bhai, carrying forward that discussion, that technology has definitely made life easy. And whatever the glitches are, but being on a venue on a Sunday morning, it's very painful. Sunday early morning.
Yes.
And with technology, you can communicate in the comfort of your home and enjoying your Sunday.
Yes. And enjoying home tea in spite of
Home
Radisson.
tea. But that time,
Otherwise, this time we
Radisson
used
tea.
to enjoy Radisson blue tea.
Radisson blue tea. Yes. But that time we do miss, na?
Yes.
Blue tea.
Yes.
Hmm. So you started full-fledged OPD, Sanjeev bhai?
No, 12 to 5. 1 to 5 rather.
Okay. Because of late, this western side is picking up now. Cold.
Yes. How is Vadodara, Shailesh bhai?
Every day the cases on the rise, sir.
Okay. Here in Ahmedabad, the numbers are going down, but actually the cases are on rise because we see more and more. Yes. I don't know how it is happening because the private laboratories themselves are telling that they had 100 tests today positive, the other is telling 50 were positive. And the
Exactly.
total number is just 150 in Ahmedabad. That is surprising. We hope that it is true, but I'm afraid it is not.
We lost one pediatrician and we lost one physician.
Oh, yes.
Yeah, I saw on Facebook.
Ahmedabad
Yes,
also,
very
we
sad.
lost one pediatrician, young one, 56 years of age, and
Two-
no comorbidity.
One orthopedic
And
surgeon.
Dr. Manoj Vithlani's cousin.
Yes.
Hmm.
Another is in ECMO and another is in Corona Storm. Two are again fighting.
So let us not talk about that.
And let's pray for them and let's hope for the best.
Yes. I think we should do whatever we can do for the society. This is the time for us to educate the people. Rather than just treating them, we should do all our efforts to educate them, prevent, that means stressing the importance of social distancing, which
Good
is not
morning,
happening.
everybody. I'm going to interrupt and we are ready to get started. So I don't know where is the introductory slide, Hardik, not this one. There should be one more slide before this. It says research presentation. I've got a nice quote on it. Yes. So I just want to welcome all of you. Good morning. We are starting our day 2 of the conclave with this research presentation. As a lot of you are aware, we had a nice plenary talk last night by Dr. Ralph DeFronzo, who's not only been my professor and my mentor. I lived in Texas for 5 to 6 years just to train under him and never regretted that decision, being from big cities like Mumbai, Chicago, California, LA. But the decision to move to a smaller town where he practices sort of is something that people were wondering. But he taught me how to do research the right way. And this is a quote that he used to say to us very often, that when it's new, it isn't so, but when it's proven, it isn't new. So people may not respect you, but you need to always keep on trying to foster the research spirit. So even though this is not such a big conclave such as the ADA or the ACC, I'm very happy to say we had almost 18 presentations submitted in a short span that we just gave 2 weeks for research. Out of this, we have selected about 10 for oral presentations. One person is not going to be presenting. So out of the 11, we have 10 presentations for the judges. The judges will be grading you on your presentation skills, on the validity of your hypothesis, on your scientific data, which is already seen in your abstracts, and hence you are selected here today. So without further wasting any time, I welcome warmly all my 4 judges. Dr. Sunil Thanvi is a senior cardiologist at Zydus Hospital. So we have one from each specialty. He's also professor of cardiology at PS Medical College, Karamsad. I'm always keeping Ramesh you for last because your home team, Apollo. Dr. Sanjeev Pathak is a senior diabetologist. He's also the director of the Vijay Ratna Diabetes Center. Dr. Reema Rao, she's president of Indian Dietetic Association Gujarat chapter. She's known to all of us. She's always been very supportive of all our efforts. And she's also an associate professor of food and nutrition at Sadhguru College, Rajkot. And of course, I say the best for last is Dr. Ramesh Goyal. He's my partner in crime, head of department endocrine at Apollo Hospitals and a senior consultant in Ahmedabad as well. So I will hand it over now. I think our first contestant today is, or presenter today. Let's not say contestant because research we are all here to learn, even though we've kind of made it a little competitive. Is Dr. Sailesh Trivedi. He will speak on the clinical implications for the variations in BMI in the clinical trial population with obstructive sleep apnea and narcolepsy. It's evaluated for excessive sleepiness with solarium fetol, a rapid review. Over to you, Dr. Sailesh Trivedi, to share your screen and get this rolling. So with all your good wishes, we start the second day with your presentation.
Thank you, madam. So, shall I start?
Yes, yes, sir.
एक minute. Let me share. That, sir, seen?
We- Yes, yes, your slides are visible.
Okay. Good morning,
We are-
everyone. This is
morning,
a rapid.
sir.
This is a rapid review where we are going to have clinical implications for the variations in BMI in the clinical trial populations with OSA and narcolepsy, which were evaluated for excessive sleepiness with solriamfetol. As you know all, solriamfetol is a dopamine and norepinephrine reuptake inhibitor, which is indicated to improve wakefulness in adult patients with excessive daytime sleepiness, which is a feature of narcolepsy and obstructive sleep apnea both. US FDA approved on March 22 solriamfetol in 2019 and European Union in 2020. Here, in the pre-marketing studies, there was a very clear observation that there is decrease in the body weight as an adverse effect, and which was less than 2% incidence, but it was greater than placebo, both in the case of narcolepsy and OSA patients. Objective, we are very clear that we hypothesize that the baseline body mass index, that is BMI, be an independent predictive marker for the decrease in the body weight in narcolepsy and OSA. We selected the RCTs as per the PRISMA guidelines from the Cochrane Library and PubMed, and we saw that duplication of the studies were excluded from subgroup and post hoc analysis. There were total 8 clinical trials were identified, of which 4 were unique studies, and that included BMI as a baseline demographic parameter, which included our synthesis. The BMI ranged from 18 to 45 kg per square meter across the entire dose group. The mean BMI was 32 kg per square meter. Results: the patient in the obstructive sleep apnea group had a higher BMI, 33 kg per square meter, which was 19.1% greater than the patients with narcolepsy, that was 28 kg. So BMI was quite high in OSA group. And here we evaluated 4 phase 3 trials, 3 for 12 weeks and 1 open label trial by Mr. Malhotra and others from India. They did trial for almost 50 weeks. It was an open label trial. This is 4 good studies which we have selected to highlight and to come to our conclusion. The 60 patients, those who were studied for 12 weeks for obstructive sleep apnea by Strollo and others, their BMI was 33.3. Similarly, 303 patients for OSA, they were studied for 12 weeks and by Schweitzer and others. And here also BMI was 33.4. But in narcolepsy, the patients who had numbers were 143. The study was for 12 weeks. BMI was 28.05. It was done by Thorpe et al. Malhotra, as I said in the earlier slide, it was a study which was an open label study, 50 weeks, narcolepsy and OSA both were included. And the number of patients were 458. BMI was 31.7. So the studies are very clearly suggestive of that the narcolepsy patients had BMI on the lower side, OSA on the higher side. This is the mean BMI. This graph shows mean BMI of 32 of 962 patients. Total number of patients were 964. Discussion is, I want to say, OSA patients, they are usually more obese, and baseline BMI, it appears to be an important determinant for the appropriate patient selection to initiate and predict the decrease in the body weight. Well, as you know, solriamfetol is basically a dual reuptake inhibition property. It has a dual reuptake inhibition properties of norepinephrine and dopamine, which distinguishes it from the amphetamine stimulants, which otherwise would have caused the release of monoamines, but this is blocked, which may have long-term outcomes for excessive sleepiness in patients with narcolepsy and OS. Conclusion: as I mentioned, periodic body weight monitoring would add to the emerging clinical evidences, especially for the varied dose of sodium pentothal with correlation with energy homeostasis, especially for a drug which is a wide range from 75 to 300 milligram. Here I must clarify that with the doses which I have mentioned is from the publications of these trials. FDA has recommended 75 to 150 milligram for OSA and for sleep apnea. So BMI is an important parameter, needs to be considered for even it could be, we don't know what is the cause of higher loss of body weight, whether it was a side effect or whether it was an intrinsic effect of the drug. This is what my conclusion is. Thank you, everyone.
So with
Well-
knock on time,
We have questions.
Again, I'll just take 30 seconds. As our organizers have chosen the slide, I was really prompted that I must also use the same. By coincidence, it is the same. When it is new, it is not so. When it is proven, it is not new. And it is a very catchy, and probably it may be the slide of a decade by Dr. Di Franzo. Thank you, everyone.
We have about 2 minutes for questions. So all the speakers are allotted 6 minutes and we allow 1 minute for questions, but Dr. Trivedi has finished in 5.5 minutes. So any questions from the judges, please? Please unmute yourself and ask.
Yeah, what was the maximum weight loss? So less than 2% is not very impressive, Salisbury, but what was the maximum weight loss in the
3.8
analysis?
The variation was 3.8 to 6.8 kg.
Okay, and percentage wise?
Sir, it varied. It varied, but basically we were concerned with the BMI, and BMI was quite reduction. It was 19% reduction, and the weight loss was it was in pre-marketing studies. But ultimately, when it came to the FDA level, they have not considered this point. So we want to highlight that
Okay.
BMI must be considered, or it could be considered in the future. We don't know what could be the effect. Is it really the side effect which is responsible for anorexia or loss of appetite, or is it because of the intrinsic effect of the drug? So BMI has not been considered in the leaflet or the insert of the drug in the USA.
Okay. Okay. So was there any change in the waist circumference? Because then it would attribute to reduction of the central obesity.
Okay. That parameter, honestly, was not discussed. Not.
Correct. But do you think that this may be due to improvement in the sleep apnea that patients might have lost weight? Or due to the direct effect of the drug?
I personally feel, if as per the scientific literature and given the detailed observations of the drug by US FDA,
Okay.
it is basically the side effect probably, which I think is responsible. It is the central effect on the hypothalamus, and plus there is a nausea and loss of appetite. Both the things are important, which could be the fact rather than, intrinsic effect of the drug.
Great.
This is
we
Sunil,
done
Dr.
with
Rima.
questions?
I just have one question for Sharishbhai. I mean, this study was powered to study only the weight loss component, the BMI loss component, or were you also looking at the clinical improvement in these patients? What was the primary endpoint that you were looking for when you did this research?
Clinical improvement was definitely observed in all the studies. They were quite awake, and the patients, those who were given in the early morning, before they end up the sleep, before 9 hours, the drug was given in all these studies, and the wakefulness was quite impressive, and they could walk without any, the studies showed less than 10% of the observations what they observed, means 10% of the patients they used to get in spite of this excessive sleepiness. But when they exceeded the dose of 150 milligram, the beneficial effects were less and the side effects were pronounced. So the FDA curtailed the dose from 300 milligram to 150 milligram.
No, my question was the primary endpoint of the research was a reduction in BMI, or was it the clinical improvement in patients for OSA? That is what because the dose modification in your patients was based on the weight loss that was happening, or was it based on the clinical improvement of OSA that the patient were getting?
Sir, our objective was very clearly. We were concentrating only on BMI. BMI was not touched in any of the parameters. That's why we wanted to concentrate on a new hypothesis that where does BMI stand in this study? All this, whether the improvement occurred, that was because of the intrinsic property of the drug. But BMI was not evaluated in all these studies as an independent parameter, and that's why we conducted eight trials together, and we brought out a point that BMI needs to be given an importance, and it could be one of the predictor for the future outcome also.
So, can we would now want Dr. Sailesh sir to conclude. We are, if the questions are over, can we move to the next contestant?
Even if the questions are not over, we'll move next to the session.
Yes.
Please invite the next speaker. Thank you, Dr. Trivedi.
Our next speaker is Dr. Batul, and his topic of presentation is the HSCRP and vitamin B12 levels among young adults, implications for CVD.
Just a minute. May I interrupt, Rucha? Sure. The evaluation. Hello.
Yes.
The evaluation sheet, I think we should give out of 10 marks for presentation, 10 marks for content, and 10 marks for the originality and the implications to the practice. Is that okay?
Sure. Absolutely, sir.
Huh? Okay. So out of 10, we give evaluation marks to every candidate. So out of 30, we'll make the total. Yes, personally, sir. I don't have number of Dr. Rima.
No, just send it to me.
What you can do is you can make group of 4 of us.
Yes, sir.
So that we can discuss. Thank you so much. Go ahead.
Good morning, everyone.
Good morning.
Dr. Batul, you will have 6 minutes. You can start.
Yes, ma'am. My research topic is HSCRP and vitamin B12 among the young adults, implications for CVD. We all know CVDs are the world's most common cause of death. Estimated 17.9 million people die each year, year, and this count is still on. The link between inflammation and cardiovascular disease appears to firmly established. Among several biomarkers, HSCRP contributes to the identification of people at risk of developing CVD and is the common pathway for major complications of atherosclerosis, stroke, and ischemic heart disease. Also, vitamin B12 deficiency leads to hyperhomocysteine, which is associated with arterial endothelial dysfunction and is considered as an independent risk factor for CVD. Hence, the aim of our study was to assess the HSCRP levels and vitamin B12 with the cardiovascular risk factors among Northeastern youth studying at Maharaja Sahyajirao University of Baroda. All the Northeast students who gave consent were part of our study. In total, 168 subjects, 94 males and 74 females. These subjects were then evaluated for anthropometric and cardiovascular risk factors, and blood samples were collected for assessing HSCRP and vitamin B12 levels. The results revealed that out of the 8 Northeast states, majority of the subjects belonged to Assam and Manipur, and their mean age was 20 years. The overall prevalence of underweight, overweight, and obesity was 7.7%, 16.7%, and 18.5% respectively, according to the Asia Pacific criteria. Hence, there was a dual burden of malnutrition. With respect to HSCRP and vitamin B12 status, 14.9% of the total subjects had high HSCRP levels, and despite the subjects being non-vegetarian, 24.4% of the subjects were vitamin B12 deficient. The mean values of HSCRP were found to be significantly increased across BMI and waist circumference. The mean values of different variables of risk factors with respect to high and normal levels of hsCRP were compared. Trends were observed in females that the mean values of BMI, body fat, DPB, insulin, HOMA-IR, TG, VLDL, AIP, TG by HDL ratio, TC by HDL ratio were significantly higher in subjects with high hsCRP levels than subjects with normal level of hsCRP. ApoA and ApoB ratio was significantly lower in subjects with high hsCRP levels. Also, odds ratio value at 95% confidence interval for various risk factor analysis using hsCRP as the indicator was done. HOMA-IR, non-HDL, and LDL by HDL ratio were found significant. Similarly, with respect to vitamin B12, it was observed that in males, the values of hsCRP was found to be significantly high in subjects with deficiency of vitamin B12, and odds ratio with respect to 95% CI limit was observed significant in waist circumference, that is 3.29 times in case of females. Thus, to conclude, BMI has an influence on hsCRP levels. The presence of high hsCRP levels and coexistence of vitamin B12 deficiency indicates a higher risk of cardiovascular morbidity and in the study population. These observations call for an intensive strategies to our development of CVDs in adulthood. Thank you.
Thank you so much, Dr. Batul. Can we now have the judges? Any question and answers from each of the judges?
Yeah. So, Batul,
Yes, ma'am.
why did you select this particular population?
Ma'am, basically, it was because they have migrated from the northeast states and their food pattern and everything was really different from the Gujarat. So, and they were here studying in our college. So, we focused on them.
Okay. But do you have any history, or did you have any known history that they have any your interest in this vitamin B12 and CBD? So does the literature support this? That is my question. Why did you select this particular group of patients, samples? Because they were easily available, or you have any history support to the literature?
As such, they were also actually both. They were also available. Plus, the literature also supported that they had quite a higher risk of the other metabolic syndromes. Things.
Okay. Okay. Fine. Thank you.
Any other questions? Dr.
Yes,
Sunil
please,
has a question.
yeah, just have a question. Hypothesis of vitamin B12 and CVD risk factors. Where did the hypothesis come from? Because we know vitamin B12 and homocysteine do have an association, but vitamin B12 and hsCRP association is still not, so robust in literature anywhere. They could be just association, a random association, not necessarily a causative or effective association. So I think your conclusions need to be very guarded, and you cannot come out saying that just because of the vitamin B12 deficiency, therefore the hsCRP levels are high, or therefore the patient is at higher risk. You should also have looked at the other traditional risk factors, family histories, history of premature CAD. You should have gone into the whole lipid profile and all the other risk factors that could have contributed to this. But I think interesting hypothesis, and maybe we could look at it. Thank you.
Thank you so much, Dr. Batul.
Yes, I think it's an interesting hypothesis, and maybe having therapeutic implications if it is true.
Yes.
We can move on.
Yes. So our next speaker is Dr. Sampada Agniotri from Barodra. The topic is cardiometabolic risk factors among overweight and obese college-going youth. Can you share your slide, Dr. Sampada? We can't hear you. We still can't hear you.
Vandana Lokar.
Yes, now we can hear you.
Hello. Hello.
Yes.
Am I audible?
Yes, you're audible now.
Okay. Good morning, all the dignitaries present. I'm Sampada Agnihotri from Department of Foods and Nutrition and the Maharaja Sayajirao University of Baroda. My topic is cardiometabolic risk factors among overweight and obese college-going youth. So to give the background of this study, as we know that nutrition transition describes global alteration in the body composition, food system, and physical activity pattern. Since last 2 decades, globalization contributing to nutrition transition. It is attributed basically to food systems, which resulted in an increased availability of foodstuffs marketed on global levels, that is such as vegetable oil, sugars, refined flours, but also the multiplication of places of sales of processed foods and even ultra transformed foods. To these places, youth adults are more attracted as to make their busy lifestyle easy. Thus, nutrition transition leading to a higher prevalence of overweight and obesity, which is one of the leading contributors of cardiometabolic diseases. So the main objective of the study is that we want to study the cardiometabolic risk factors present among the overweight and obese student studying at the Department of Foods and Nutrition, the Maharaja Sayajirao University of Baroda. The methodology we used to start the study was we did the anthropometric scanning of 168 students, where we identified 71 overweight obese students. Out of 71 overweight obese students, 51 students who gave their consent to participate in the study were enrolled in the study. Further, we took the data pertaining to anthropometric, biophysical, and biochemical parameters. So the results of this study is revealed that the mean age of the students were around 20 years. The anthropometric data depicted that almost around 76.4% of students had central obesity, and thus indicating that these young adults would be at a higher risk of suffering the comorbidities of obesity with their advancing age. The blood pressure status of overweight obese revealed that half of the students were in the prehypertensive stage. The lipid status of the students revealed that the prevalence of high triglyceride levels was 31.37%, and the low HDL cholesterol level was found to be 37.2%, and it was found that slightly elevated levels of the atherogenic index of plasma among 80.39% students. The glycemic status of the overweight obese revealed that there is only one student who found to be at a higher side of FBS and insulin levels, but rest of within the range of the glycemic status. The inflammatory markers, that is HSCRP, was elevated among 29.41% students. So this is the gist of the study, that the cardiometabolic risk factors among overweight and obese students, that almost 76% were having abdominal obesity. Half of the students were in their prehypertensive stage. 31% students are were having high triglyceride levels. Almost 31% students were having low HDL cholesterols, and the FBS insulin were almost found to be within the range. So to conclude the results, it indicates that it indicates the clustering of cardiometabolic risk factors among the youth. So there is a need felt to identify the high-risk individuals by conducting simple screening, followed by the intensive lifestyle modification, and we should more focusing on healthy diet and to aware them more about healthy diet practices and physical activity to prevent the development of cardiovascular diseases in future. Thank you.
Thank you, Dr. Sampada. Can we have questions from our judges?
Yeah, so that was a very interesting observation. My question is, the blood pressure was measured only once, or it was repeated after some time?
Sir, it was measured only once, and we found that almost half of the students were lying in the pre-hypertensive stage.
And was there any control group for all these parameters?
Sir, no, there was no control group in the
Fine. It was a nice presentation.
Thank you, sir.
So that means we are sitting on a volcano, our young generation. We have a dietitian, Dr. Rima, with us. So would you like to ask anything?
No, I think it was a good study because, it's quite shocking to know that our students who are so young, they are in the pre-hypertensive stage. But yes, I would have liked if they had measured the blood pressure over a period of time rather than once. Because, just checking somebody's blood pressure, I'm sure anybody will get a little, you have to measure it at different times and in different positions to get a more balanced this thing.
Right, ma'am.
Sampada, how did you measure atherogenic index? Which formula you use?
Sir, it is total cholesterol by triglyceride. We also did the cholesterol level estimation, total cholesterol.
Okay.
So, sir, we found that most of the subjects were having slightly elevated. They're most of not beyond the ranges, but they're almost on the verge of beyond the range. So it is a grave situation, we can say so.
So total cholesterol upon triglyceride, or not triglyceride upon HDL?
Sorry, sir. Total cholesterol upon HDL. My mistake, sir. Sorry.
Okay. Go ahead. Any other questions?
Should we move to the next speaker? Okay. Thank you so much, Dr. Sampada.
Thank you, ma'am.
Our next speaker is Dr. Vibhakar Vajrajani from Rajkot, and their topic is Trends of Below Knee Amputation and Evaluation of Risk Factors, 3-year study in type 2 diabetes. Dr. Vibhakar, are you with us?
So before he starts, in our biodata, we are going to write that Dr. Shailesh Trivedi and Dr. Vibhakar Vajrajani, and we were judges in their presentations.
Video chalu karwanu.
Is it correct, Ramesh?
Yeah.
Yes.
Yes.
Absolutely.
So that would be included in our
Yeah.
CV.
Am I audible?
I'll write in the first line.
Yes, sir, you're audible.
Hello.
Yes, sir, you're audible. We can't see you, but you're audible.
Now can you see me?
No, sir.
Not yet. Just a minute.
Excited to see you.
Yeah. Start video. Okay.
Yes, sir.
Yeah.
Now.
Perfect, sir. Yes.
Okay.
Yes.
Fine. Yeah.
So, sir, you can share your screen with us, and you have 6 minutes.
Yeah. Please. Not an issue. Yeah. My slides are visible to you?
No,
Hello?
not yet. Not
yet. Just a minute. There is a screen share. Yeah, I share the screen.
But we are happy to see you.
Oh, so kind of you. Yeah. Now, is it okay?
Yes, it has started.
Yes, sir. Now we can. Yes.
Okay. Fine. So, good morning, everybody. As such, we are reaching good noon time, but we are so happy to meet today. The presentation is Trends of Below Knee Amputation and Evaluation of Risk Factors, my 3-year study in type 2 diabetes. slide, next slide. Just a minute. Yeah. See, the rising prevalence of type 2 diabetes mellitus with huge burden of metabolic foot amputation is a challenge to our limited healthcare resources. Friends, we know I conducted a retrospective hospital-based study from January 2017 till December 2019 for T2 diabetic patients who had undergone a non-traumatic below knee amputation and to evaluate the outcomes and the associated risk factors. We analyzed a total of 75 patients with diabetes. Out of them, 12 died in due course. These 75 patients underwent amputation at our center during last 3 years' time. The mean age of the patients who expired was 63 years. It was less than those who were alive, 64 years. But the p-value was not significant. It was 0.87. The mean HbA1c at last follow-up of the patients who expired was 11%, as compared to that in the patients who were surviving was 9.5%. Here also, there was some significance that we could derive at, but the p-value was still not that significant to conclude that it is absolutely a reason for amputation and the consequences. This is a diagrammatic representation of the results, 63 patients, and on the right side, that is a violin graph which is suggestive of mean age and the standard deviation and extreme age groups of the patient. Here, this chart is suggestive of the patients who expired. Again, there is marginal difference. We cannot see any difference in 63 years age group, a mean age group who expired, and 64 age group which are still alive. This is a significant, there is in this graph, we can see some significant change in HbA1c levels of those who expired and in those who are surviving. Total 63 patients were alive, 50 males and 30 females. Out of that, 37 patients were active users of tobacco, including smoking, with 35% had no usage of tobacco ever. And 5% of patients were taking tobacco, but they had already quitted. 64% of patients had no any other comorbidity, excluding hypertension or peripheral vascular disease, because diabetes is many a times associated with some sort of hypertension and peripheral vascular disease. So we have not included, we have excluded that from this comorbidity section. 62% of patients had PVD, 17% of patients had CKD, 40% had anemia, 40% had systemic hypertension, and 33% patients had ischemic heart disease. 22% patients were actively using prosthesis. We were very much behind the patients to use prosthesis because that adds to their quality of life and longer duration of life. But 9 were not the users of prosthesis, and so many were recently operated, so they had not started using the prosthesis. In 40% of the patient, the other limb was normal with no signs of vasculopathy. 2 patients previously had below knee amputations already. So we did below knee amputation of opposite limb in 2 patients, and 15 patients had amputation of some of the toes in the past. We did not find tobacco usage as a predictive risk factor for amputation. This is number 1 discussion. There was high prevalence of PVD. Of course, we have seen high prevalence of PVD, hypertension, and anemia in patients who underwent below knee amputation. Amputation in the past 3 years was apparently a high risk. Any patient who had undergone some minor amputation of the foot had high risk of impending amputation in diabetes, in diabetic T2 diabetes. Poor glycemic control appears to increase the risk of mortality in T2DM who have undergone below knee amputation. To conclude, an early adequate glycemic control could decrease the probability of development of microvascular complications and mitigate the disease burden of amputation in limited resource settings. Friends, thank you very much. It is said by Ralph DiFronzo that when it is new, it is not so. When it is proven, it is not new. Thank you very much. Okay.
Sir's quote is getting famous.
Yes. Everyone is quoting. Everyone is mentioning.
Yeah.
Yes, a wonderful
So,
presentation,
any
Dr.
question?
Vachrajani.
Yeah, thank you,
But
Phatak sir.
two very interesting but some peculiar findings, that whether they continue tobacco or not and whether they control their blood sugar or not later on does not make difference on the mortality.
Yeah, exactly.
So this
that is
is
what
at
we
variance compared to what we believe. So
Yeah.
your discussion or your arguments for that.
Yeah, exactly. See, what we observed was there was definite correlation between smoking, tobacco, and amputations, but there was no significant difference in the number of patients getting amputated as far as only tobacco consumption is concerned, because the correlation says that if there is diabetes, uncontrolled diabetes, HbA1c is very high, and then the patients are consuming tobacco, then they are at higher risk of getting amputated.
Yes, and again, in the findings, you mentioned the difference of 1.5% between the two groups, patients who died and patients who did not die.
Yeah.
But how did not it reach the statistical significant value?
Yeah, see, 63 and 64 is not a statistical significant value as far as a study of this sort of number of patients is concerned. That's why we have not.
No, I am asking about HbA1c.
HbA1c. Please repeat the question, sir.
In the people who died, the HbA1c was 11. In the people who did not die, it was 9.5.
Right.
But in the statistical analysis, you mentioned that it did not reach statistical significance.
See, the statisticians, see, there is another science. Statisticians, they say that if the p-value is less than 0.05,
correct,
then it is significant. Here it is showed that it is 0.08. And that's why it is marginally significant, not that much, means not as per the p-value segment.
Probably the number of patients who died were only 12, and that's why it did not meet the statistical value.
Yeah, it is possible.
Okay. Ramesh,
do
you have any question?
Yeah, so one question from my side. We have data on
the
mortality of the patients who died, the cause of death. Was it
cause
like
of death? That is very important.
Because of infection? I mean, do we have any data on that?
Pardon? See the trend. See, we are not exactly focused on the study at present on only mortality. It is the trend, in general trend of the below knee amputation patients. That is what at present is our aim at present. But what we observed was in our patients, series of patients, around 12% of patients had septicemia associated with the surgery, that is we had to do is amputation. Rest of them had dry gangrene and requiring amputation. That is number one, right? So that we have analyzed, but in a short description today, in a short presentation today, we have not emphasized on the mortality and cardiovascular complications. Absolutely. Thanks.
Ramesh, any other thing? One reassuring point is that within 3 years, only 20% of the people died. The literature says that at 5 years, 50% died.
Yeah, but our statistics, we are still, I have got another, it is ongoing project at present with me. And there are 150 plus patients who are at present under our clinical data. And we have even 11 years patients, they are surviving since 11 years. Also, we have got so many patients. So we are trying to improve and we are trying to educate the mass after amputation to maintain good health.
Vipakar bhai, one question from my side.
Yeah, Rima Ben?
Why do you think the patients were anemic? I mean, what was the background of the patients? Why were they anemic?
Yeah, anemic. Yeah. See, you know that there are 40% of patients had associated CKD as well. So this is number one, because all renal patients have anemia. This is number one. Number two was from a very lower socioeconomic condition they were coming. That was number three. And number four was a septicemia infection for a very long time.
Yeah.
Is another responsible factor, because ours is a tertiary care center. They come from various places after taking treatment for 1 month, 2 months. They are borderline septicemic, not treated properly. They come to us. So we find that they are anemic. So all these are the factors which are responsible for associated anemia.
Thank you. Thank you.
Yeah, Dr. Vivakar, this smoking and tobacco use, which is considered as a very strong risk factor, did not have any relevance in your study.
Yeah, in this study.
So that was very surprising.
Yeah, that is very surprising. There is definitely peripheral vascular disease associated, no doubt. See, I have showed the statistics that there are 40% of patients had peripheral vascular disease, but they were treated conservatively. Conservative treatment, amputations were done, but they did not land up into below-knee amputations in my study patients.
Okay.
So I think it would practically mean that tobacco and smoking actually are causative to peripheral vascular disease, but once the damage is done, it is done.
Then diabetes adds to the problem. See, not only tobacco and alcohol and the smoking, the diabetic, uncontrolled diabetes and other comorbidities, they added to the cause for amputations.
But I think the strongest risk factor was the previous amputation.
Yeah.
Yes.
See, 3 years, if there is a history of any minor surgery, minor amputation in last 3 years, it was the strongest evidence or incidence that they are likely to go for major amputations.
May I interrupt?
Yes, we are running out of time.
Yes, little bit.
Yes.
Thank you so much, Dr. Vibhakar. That was a really interesting study.
Thank you so much.
We will move on to our next speaker, Dr. Devanshi Gandhi from Vadodara. Her topic is Eat Right India Movement as a Strategy in the Prevention of Diabetes and Cardiometabolic Risk Factors.
Good afternoon, everyone. Am I audible?
Yes.
Okay. So just to introduce my topic, we know every year 41 million people are killed due to non-communicable diseases, which is equivalent to 71% of all the deaths occurring globally. And CVDs have been reported as being the largest leading cause of death. The recently published report by the National Health Profile states that diet-related diseases like diabetes, hypertension, and obesity are rising rapidly in India, and the disease burden is passing from communicable to non-communicable diseases. Diet and exercise habits in youth are most influenced by behaviors which decrease the likelihood of optimal health and increase the possibility of overweight, obesity, and these unhealthy habits can eventually increase the risk of developing diabetes and cardiovascular diseases in the future. Also, information about healthy food habits and eating behaviors and awareness about the same among young adults is very important for planning nutrition education programs for the promotion of good health and well-being. FSSAI has launched the Eat Right India movement in 2018 with the motto to introduce a new food culture in the country which is safe and healthy for consumption. It is based on the two broad pillars of eat healthy and eat safe, and mainly focuses on engaging and enabling the citizens of India to improve their health and well-being. So the present study was based on the objective of assessment of knowledge, attitudes and practices of the students studying at the Maharaja Sayaji Rao University of Baroda, Gujarat, India, with respect to healthy eating and food safety. 125 subjects who gave their consent were enrolled in the study, and administration of online questionnaire with focus of the questions on eat healthy and eat safe pillars of the Eat Right India movement was done. The questionnaire included 15, 6 and 7 questions addressing the knowledge, attitudes and practices respectively, and data were subjected to analysis. In the knowledge section, we found that 67% of the students were unaware about the importance of healthy diet and its benefits, as they could identify just one benefit out of the 5 benefits listed. Around 1/3 of the population felt that one can consume as much sugar as one wants. However, a majority of them had proper knowledge regarding the daily recommendations of water and importance of physical activity. We also observed that around 30% of them felt that 10 to 15 teaspoons of oil can be consumed in a day, whereas 46% felt that daily recommended salt consumption is 5 to 6 tablespoons and more. We also found that a majority of them could identify certain foods as being rich in salt, sugar, and fat. However, in the food safety section, 29% of students felt that a wiping cloth will not spread microorganisms, and half of them thought that cooked food could be left at room temperature overnight, whereas 41% of them thought that the same cutting board could be utilized for cutting raw and cooked foods, which are wrong practices. In the attitude section, we found that 75% of the students had a positive attitude towards exercising regularly for 45 minutes. Also, we observed that 27% of them felt that they consumed too much of processed foods, and 58% were concerned about their daily salt consumption. Majority of students had positive attitudes towards food safety aspects. In the practice section, we observed that 50% of the students reported adding salt in the foods at the table. Certain positive practices were also reported, stating that 63% of the students felt that students read their food labels, and 60% reported that the information on the food labels affected their purchasing decisions. And in the food safety section, a majority of them were already practicing healthy food safety habits like washing hands before cooking, cleaning kitchen surfaces, and washing fruits and vegetables with water. The scores revealed that majority of the subjects received moderate scores in the knowledge and attitude section. However, 1/3 of them received poor scores in the practice section. Thus, to conclude, despite the moderate level of knowledge and attitude scores, the lower practice scores received by the subjects suggest that there is a need for the subjects to implement and practice the healthy eating and lifestyle related behaviors in their day-to-day lives. And these young college students should be a vital target group for healthy eating and food safety education, as there is a lot of scope for improvement in their knowledge levels. There is a need for sensitization and continuous reinforcement of healthy eating and food safety behaviors, which could help in prevention and management of non-communicable diseases like cardiovascular diseases, diabetes, and their associated comorbidities during adulthood. Thank you.
Thank you, Dr. Devanshi. That was very nicely concluded and on time. Can we have questions?
Devanshi, excellent presentation. Very nicely studied. But I was just thinking that did you give them any diet survey or food frequency to study their habits? Could you correlate their food habits and their knowledge and practices?
Ma'am, we were planning to do this initially in the study plan, but because of the lockdown that was imposed suddenly, we just had to switch our topic to the online KAP survey. But yes, this was in our study plan that we were going to assess and give them knowledge as well. But however, we couldn't do it because of the lockdown and time constraints.
Yes, because that would have really added value to your study. Thank you.
How did you design the questionnaires?
Yes, sir. Based on the 2 pillars which we wanted to understand, the eat healthy and eat safe, we reviewed some materials. Like for the food safety aspects, we found the WHO 5 keys to safer foods questionnaire. We took help from that. And the eat healthy related questions were taken, were seen from the FSSAI, the Eat Right India government.gov.in, the website, the quiz that they have given. So certain questions were adopted from there, and the WHO guidelines for salt, sugar, and oil. So we took help of the resources which were available on the internet. And under expert consultation, under our professor's guidance, we finalized this questionnaire.
Okay.
Any questions from Dr.
Yes,
Sunil?
good presentation.
Thank you, sir.
We still have few seconds, sir. Would you like to ask something? Okay. So thank you, Dr. Devanshi Gandhi. We will move on to our next speaker now. The next speaker is Dr. Deepak Das from Bareilly. Do we have you with us? Yes. And his topic is assessment of vitamin D level in diabetic individuals and its association with the glycemic status. So if you can share the screen with us. The topic seems very interesting, though, vitamin D and glycemic status. Dr. Deepak?
Hello.
Yes, we can hear you now.
Okay.
You can start. Yeah.
Yeah.
You have 6
Good.
minutes. Thank
Yeah,
you.
okay. Good morning, respected delegates. I am going to present on the topic assessment of vitamin D levels in diabetic individuals and its association with glycemic status. Now, starting with the introduction, diabetes mellitus is one of the largest global health challenges of the century. It is a chronic progressive metabolic disease which occurs when the body cannot effectively use the insulin it produces, or pancreas doesn't produce enough insulin, which leads to hyperglycemia. The International Diabetes Federation has estimated that globally there are 415 million people with diabetes in 2015 and is predicted to increase to 642 million by 2040. The increasing incidence of diabetes is mainly attributed to lifestyle changes, eating habits, and being physically inactive. Vitamin D plays an important functional role in maintaining the glucose homeostasis through its effect on insulin secretion and sensitivity. Vitamin D deficiency contributes significantly to the pathogenesis of diabetes by impairing insulin secretion from pancreatic beta cells and increasing insulin resistance. Beta cell dysfunction and insulin resistance are also associated with low vitamin D levels. Treatment with vitamin D has improved glycemic control and insulin sensitivity in people with diabetic individuals. That's why this study was done to assess the level of vitamin D in diabetic. Now, aim of this study is the assessment of vitamin D level in diabetic individuals and its association with glycemic status. Now, in material and methods, after obtaining the approval from the Institutional Ethical Committee, 50 diabetics and 50 healthy control subjects were selected for the study. Fasting blood sample was taken for fasting blood sugar, HbA1c, and serum vitamin D3. And blood sample for postprandial blood sugar was taken 2 hours after meal. Demographic parameters were recorded, and all the data were entered and analyzed using SPSS version 19, and for all the parametric variables, mean plus minus standard deviation was calculated. Correlation was seen between vitamin D3 levels and fasting blood sugar, postprandial blood sugar, and HbA1c level by using Pearson correlation. Now, exclusion criteria was type 1 diabetes, type 2 diabetes mellitus on insulin therapy, diabetes mellitus with other endocrinopathies, respiratory diseases, kidney diseases, hypertensive, any heart diseases, thyroid disorder, taking vitamin D supplements. Now in the results, in the demographic profile, we can see that West-Hip ratio was statistically significant in case of diabetic people. Whereas in blood sugar profile, fasting blood sugar, postprandial blood sugar, and HbA1c was statistically higher in case of diabetic, whereas serum vitamin D3 was statistically significant and was lower in case of diabetic. Now, when serum vitamin D3 level was uh, differentiated on the basis of deficient, insufficient, and sufficient level. In case of diabetic people, 50% of the diabetic have a deficient level of vitamin D3 level, whereas 46% has insufficient vitamin D3 level, whereas only 4% have the sufficient level of vitamin D3 level, and this was statistically significant. And when correlation between vitamin D3, fasting blood sugar, postprandial, and HbA1c was done by Pearson correlation, it was seen that there was a negative correlation between the serum vitamin D3, fasting blood sugar, postprandial blood sugar, and HbA1c. But the correlation between vitamin D3 and fasting blood sugar was statistically significant, whereas the correlation between serum vitamin D3, postprandial blood sugar, and HbA1c, that was not statistically significant. Now in discussion, the present study documented that diabetics have significantly high waist hip ratio. Waist hip ratio is used to indicate the abdominal fat accumulation and is more predictive than BMI. These are the indicator of obesity in diabetics. There was significant difference in fasting blood sugar, postprandial blood sugar, HbA1c, and serum vitamin D3 level between the two groups. The present study had shown that overall prevalence of vitamin D3 deficiency was 96%, with 46% have insufficient vitamin D3 level and 50% of them have severe vitamin D3 deficiency. The result of our study was almost in par with the study done by Daga et al. In north of India, in which he had quoted that 91.1% of diabetic patients have vitamin D insufficiency. Vitamin D deficiency is found to be an epidemic in spite of plenty of sunlight in Indian subcontinent. This is mainly due to darker skin pigmentation, reduced physical activity, Varda system in females, pollution, inadequate sun exposure, low consumption of vitamin D3 rich foods, absence of fortification, old age, higher latitudes, and winter season. Although we have found a significant negative correlation of both FBS and vitamin D3 deficiency, similar findings have been reported inconsistently. While an inverse association of vitamin D3 and fasting blood sugar has been observed several times in different populations, inverse association with HbA1c was not detected in younger Americans, but detected in older Germans. It has been demonstrated that vitamin D3 receptor exists in many tissue, including pancreatic beta cells, allowing vitamin D3 to potentially modulate the insulin response to elevated blood glucose. Thus, vitamin D3 influences impaired beta cell function, insulin resistance, and systemic inflammation. Now, in conclusion, use of vitamin D3 as an adjuvant to oral hypoglycemic drugs in treatment in diabetic patient as vitamin D levels being related to glycemic control in type 2 diabetes mellitus. These findings may have therapeutic implications as causes vitamin D supplementation may improve glycemic control in type 2 diabetes mellitus. Thank you.
Thank you, Dr. Deepak. Can we have questions?
What were the vitamin D levels in the control group?
Vitamin D levels in the control group was higher. Actually, it was around 27. Both were in the deficient and insufficient level, but it was statistically significant. We have seen that 50% of the diabetic have the insufficient, whereas 46% have the deficient level, whereas only 2, that is 4% of the subjects in the diabetic group have the sufficient level of vitamin D levels.
And how many of them had sufficient levels in control group?
In 5%. 5 numbers means it is 5 means 2, 4, 4, 8, 10% almost.
Okay, I agree with you, Dr. Deepak, that in our population, vitamin D deficiency is definitely much more prevalent and more so in diabetics.
Yes.
But there are contradictory reports. So how do you interpret the results of your study? Whether supplementing vitamin D routinely to our population, will it help in reducing?
Sir, actually, just I am moving forward with this study, and all the patients which I have selected for the diabetic, they were all new patient to our hospital. They came for the first time to our hospital, and they haven't supplemented with vitamin D3 as they were treating from any outside to the other hospital. That's why after the first report, we have just started supplementing with vitamin D3 level 60,000 international units per week. And after 3 months, we will see what happens to their HbA1c level, fasting blood sugar, and postprandial blood sugar level, and overall to the vitamin D3 levels. Then we can tell what will happen after supplementation of the continuous vitamin D3 level for the 3 months to any of the patient.
But doctor, there would be many confounding factors, because you must have changed the anti-diabetic medicines. You must have given diet and lifestyle advice, and simultaneously you are supplementing with vitamin D. So which variable is working to what extent? How will you decide that this is the contribution of vitamin D, this is the contribution of your medicine, this is contribution of lifestyle?
Was sunlight exposure given?
Actually, at present, it was not in their previous, how they are moving to their lifestyle. That was okay. We started giving them vitamin D3 level and lifestyle modification along with the dietary lifestyle. So now we will see after 3 months what will be the results.
Thank you, Dr. Deepak. Ramesh sir, can we move on forward?
Yeah.
Yes, sir. Okay. So thank you so much. Our next speaker is Miss Anam Golandas from Mumbai. And the topic is comparing nutritional status of hospitalized elderly patients with functional status. We can't hear you. Miss Anam? Miss Anam, please unmute yourself. Are you with us?
I'm audible to you, Hiti?
Yes, now you're audible.
Okay.
You can do a full screen and you can start.
Yes.
Slide share. Just do a slide share. If you... Yes.
Good afternoon, one and all. My today's topic for presentation is assessment of nutritional functional status of hospitalized elderly patient. So as we know, elderly patient population are more prone to nutritional deficiencies as aging may come with an accumulation of diseases and impairment. So all these factors make elderly people at risk of malnutrition and affect their nutritional status. So the aim of the study was to assess the nutritional and functional status of a hospitalized elderly patient and whether their nutritional status is affected by their functional status. So methodology, we selected 50 elderly patients admitted at hospital for their medical treatment. Then we categorize patient according to their age. All patient who aged more than 65 years and who stayed in the hospital for 1 or more days were included in the study, and patient who required like treatment in the ICU setup were excluded in the study. Then subject were classified according to this age categorization, that is young, old and oldest old. For nutritional assessment, we use mini nutritional assessment and nutritional checklist, and for functional assessment, we use Barthel index. Then that biochemical parameters, medical history, symptoms were also noted. Kappa-Suomi scale was used for their socioeconomic status. Then chi-square test was used for analysis. Then result, among total subjects, 62% were male and 38% were female. According to age categorization, 60% when belonging to young old, 28% were old and 12% when belonging to oldest old category. Majority of the patient had hypertension followed by other comorbidities like diabetes, asthma, cancer and all. Then most common symptoms observed in constipation, weight loss, chewing difficulty, which showed in figure number 1. Then biochemical parameters.
Miss Anam, your video and audio has got paused. Might be some internet issue. Just we'll wait for a few seconds.
To you, she has lost her connection.
Meanwhile,
you can, by the time she connects, you can start with the next session.
Should we start with the next speaker? Okay. Okay. If the host can please stop this view and we can move on to...
Yes, we are doing it.
Thank you. Okay. Our next speaker is Dr. Akash Prajapati from Ahmedabad, our very own city. And the topic is aim and objective type 2 diabetes persons on newer sulfonylurea with multiple OHA showed no documented hypoglycemia.
Hello.
Hello. Am I audible?
Miss Anam, we lost your connection.
Yeah, sorry, because of heavy rain, it's like internet connectivity.
If you can give us few minutes, we are starting with Dr. Akash, next speaker, and then we will take your presentation again at the end.
Okay, no problem.
Thank you.
Okay.
Yes, am I audible?
Yes.
Yes, Akash. Okay. So my topic is, good afternoon all, risk of hypoglycemia by the newer sulfonylurea in the person with type 2 diabetes. And my co-author is Dr. Vidisha Patel and respected Dr. Bansi Sabu sir from DICAT team. This is my abstract presentation. Our aim and objective is to know the hypoglycemia by the ambulatory glucose profile in the person with type 2 diabetes on the newer sulfonylurea with the multiple oral hypoglycemic agent. Inclusion criteria is person with the type 2 diabetes, multiple OADs with the newer sulfonylurea, and HbA1c criteria is less than and equal to 7.5. And exclusion criteria is type 1 diabetes, GDM, and on insulin therapy. Our materials and method is it is our prospective data at our clinic at DICAT survey. Total number of 27 patients were studied with the match our inclusion criteria. Ambulatory glucose profile of Freestyle Libre Pro was applied for 14 days on the person with type 2 diabetes with the no change of medication, and the AGP record for 14 days was observed. And our result is, in our database, the use of newer sulfonylurea with the other OAD combination, there is a no hypoglycemia in the person with type 2 diabetes. Here I present the one case example in this all of the patient. One patient, 52-year-old male, non-case of diabetes since 5 years. Her weight and BMI is absolutely under control. There is no any another comorbidities. His HbA1c was 7.2 and he is on metformin with glimepiride 1 milligram of combination before dinner and teneligliptin and metformin combination 1 in before breakfast. So we put on AGP on first day. So this is 14 days of AGP record. There is no any single hypoglycemia till 1 day to 14 days of record. We educate the patient motivationally, and we ask the patient come to our clinic every 5th day, and then after observation this graph, and there is nothing to single episode of hypoglycemia. So what is the concern for SU use in recent era? First is hypoglycemia, weight gain, increased apoptosis, aggravate the beta cell death, glycemic durability, and cardiovascular mortality. Here I show you the one paper study. The glimepiride, it is also newer sulfonylurea. It is a less hypoglycemic agent. Risk of hypoglycemia can be reduced with the individual target to determine before the using of the glimepiride. Another data is showed that the sulfonylurea is to show the anti-apoptotic action on the beta cell. The purpose of this paper is compared with the linagliptin and GLP-1 molecule, glimepiride appear to enhance the beta cell secretion and mass. The result of the first data was the demonstrating lack of the improvement of the function of the beta cell mass with the GLP-1 analog. Either DPP-4 inhibitor is the off drug, while demonstrating a remarkable increase in the functional beta cell mass with the sulfonylurea treatment. This is another paper. Also, association with between the intensification of the metformin combination with insulin and versus sulfonylurea. Also, sulfonylurea, it is a CV safe agent in the all-cause mortality among the type 2 diabetes patient. Also, the one of the base Carolina trial was also chosen. It is also CV safe drug. So sulfonylurea, it is the time-tested agent. Sulfonylurea would continue the reliable and the effective treatment as a monotherapy and the combination therapy, have an established the long-term benefit with the regards to decrease the risk of micro and macrovascular micro and macrocardiovascular diabetes related complication, and so we passed in the UKPDS data. All sulfonylurea not the same, but new sulfonylurea is more effective. Glimepiride is exhibit the lower risk of hypoglycemia and lesser adverse effect on weight also. Glimepiride does not adversely affect on the ischemic, and it is also the cardiac safe. And glimepiride is also the cost-effective, safe sulfonylurea with the good compliance. So our conclusion is judicious use of newer sulfonylurea in the person with type 2 diabetes can be useful to achieve better glycemic control with the relatively less risk of the hypoglycemia. Thank you.
Thank you so much, Dr. Akash. Can we have a few quick questions?
Yeah, Akash, that was a very quick and crisp presentation. My few questions that the patients you enrolled, they were consecutive patients, or there were some enrollment bias that the more motivated patients were enrolled and less motivated were left aside? And what was the average dose of your glimepiride? And was it only glimepiride which was used, or gliclazide also was used in your patients?
No, we are using right now the glimepiride dose. Also, we are using the gliclazide, but this AGP data is the patient is on glimepiride.
So, what was the average dose of glimepiride?
Up to 2
in 27
milligram.
patients.
Up to 2 milligram.
Okay.
0.5 to 2 milligram. Minimum dose of sulfonylurea.
And what about patients with CKD? Were they enrolled or they were excluded?
No, they are excluded. There are no another comorbidities, only type 2 diabetes patient, and there are no any comorbidity patient in the inclusion criteria.
So not a single hypoglycemic episode was seen in 27 patients?
No. It is our diet clinic data. So we are observed the patient and we ask the patient, and after 5 days of putting the AGP, then next 5 days and end of the 14 days. And we observe only data, patient motivation, diet management, and educate him. So education, it is also important role in the when we are using the sulfonylurea and also the risk of hypoglycemia.
Okay, so you want to say that it's the education part which prevented
education part is also important. Yeah.
Yeah, because it's very encouraging data that not a single hypoglycemia with sulfonylurea. So DPP-4 inhibitors are out, I think.
No, I am not telling that DPP-4 is outed.
Yeah. But I'm just joking.
He's just joking.
Good presentation, Akash. But this is at a variance to what we generally observe when HbA1c is below 7.5. And in one of the study which we did with Diacare itself, we found that hypoglycemia incidence was high in patients who were taking sulfonylureas. But this is a good study where you have documented through AGP also that hypoglycemia was not that relevant. But still, it requires further studies to say that yes, with this range of HbA1c, sulfonylurea would be safe. But good study encouraging us to use sulfonylurea without worrying too much about hypoglycemia.
Yeah.
Thank you, Dr. Akash. Can we move ahead? I would like Ms. Anam to finish her presentation. If you can share the slide with us, and then we can move on to the next speaker.
Sorry, because of the heavy rain, there is a internet problem, connection problem.
Judges, would you want her to start it again, or she can directly talk about the results?
Results.
Yes. Thank you.
Okay, so shall I start?
Yes, please.
Yeah, so
Yes,
the body
please.
composition of the subject showed that 34% subject had loss of subcutaneous fat, whereas 42% subject had lost muscle mass, and 18% had edema because of maybe they have some other comorbidities like CKD and all. Then 48% and 39% were at high risk of malnutrition as per MNA and NCL classification respectively. NCL and MNA class score was worst in age group more than 85 years, that is 72 and 88% respectively. Then here, the second graph shows the comparison of Barthel index with malnutrition assessment. Here, low Barthel index score, that is 1, was majorly observed in both MNA and NCL malnourished group, that is indicates by yellow bar, that is 63% and 54% respectively. A significant association found between nutritional status and Barthel index score 1. That means functional ability and nutritional status goes together. Then this third graph shows the socioeconomic status and nutritional assessment of the subjects. Here also a significant association found between the lower class people and they have the low in the lower class people the risk of malnutrition were high. So here we concluded that hospitalized elderly were at risk of malnutrition due to poor intake and gastrointestinal symptoms, which might affect their functional status also. Therefore, early nutritional assessment and nutritional care plan is important for this vulnerable group. Thank you. Thank you.
Thank you so much, Ms. Anam. Can we have Rima ma'am also with us if she's here? Yes, ma'am. Any questions from your side?
Yeah, Anam, sorry,
Yes.
just a sec. Somebody can start the question. I'll just come back. Yeah, here. Yeah. Okay.
Yes.
So, Anam, what kind of illnesses were there? Like because of the, even the stress level and that also matters a lot, especially with the elderly.
Yes.
So, were they having any fatal disease, or did you study that?
Ma'am, actually they got admitted because of their medical treatment only. So the
Okay.
diagnosis is majorly like Alzheimer diseases and for their cancer treatment and for their uncontrolled diabetic.
Okay.
So maybe all these factors will relate to their stress level.
Sure. Sure.
Okay. Any other questions? Okay. Ramesh sir, do you want to add on to anything? Sanjeev sir?
I think we lost the track in between, so maybe we'll give her another chance at the end.
Okay, no problem.
Yeah.
Okay. Thank you. Okay, quickly moving on to our next speaker, our very own Dr. Meeta Shah from Bombay. And she's going to talk on efficacy and safety of SGLT2 inhibitors in patients with diabetic kidney disease.
Good afternoon, everyone. Am I audible and screen visible?
Yes.
So I'm presenting our experience of using SGLT2 inhibitors in diabetic patients with CKD. We all know that diabetes is the most common cause of chronic kidney disease. Recent studies indicate a beneficial effect of SGLT2 inhibitors on the natural course of diabetes with chronic kidney disease. There is no published Indian study with use of SGLT2 inhibitor in diabetic subjects with chronic kidney disease. We already looked at the efficacy and safety of canagliflozin, that is SGLT2 inhibitor, in kidney transplant patients. However, these patients have essentially normal kidney functions. So we now look at the efficacy and safety of SGLT2 inhibitor in diabetic patients with CKD. So my aim is to study the efficacy and safety of SGLT2 inhibitor in diabetic subjects with CKD. This is an analysis of 77 patients who had type 2 diabetes with CKD, and estimated creatinine clearance was at least 30 ml per minute according to the CG formula. Those patients who had suspected acute kidney injury on chronic kidney disease, those who had risk of crisis or recurrent UTI, and those who were on fluid restriction were excluded from the study. Out of 77 patients, 41 patients were in the treatment group, SGLT2 inhibitor in the form of dapacana or empagliflozin, and 36 patients were in the non-treatment group who did not receive SGLT2 inhibitor. Other anti-diabetic agents were adjusted to achieve the good glycemic control. Similarly, doses of antihypertensive agents were adjusted to achieve good blood pressure control. In all these patients, weight, blood pressure, urine protein to creatinine ratio, creatinine and creatinine clearance were monitored at least 3 monthly, and they were followed up for at least 6 months. All continuous data are described using mean and standard deviation. Means were compared using students' pair t-test, and p-value of less than 0.05 was considered statistically significant. In both the groups, there was no much difference as regards age, sex, duration of diabetes, weight, blood pressure, proteinuria. Creatinine was slightly higher in non-SGLT2 group. This slide shows the effect of SGLT2 inhibitor on weight, blood pressure, and renal parameters. There was reduction in weight in SGLT2 inhibitor group with a statistical significant difference. Blood pressure was almost the same, no difference. Renal parameters remained the same. There was stabilization of renal parameters in SGLT2 inhibitor group. Whereas in non-SGLT2 inhibitor group, the weight remained the same. Blood pressure was the same. However, the renal parameter was different. There was more proteinuria, creatinine worsened, and creatinine clearance was less in non-SGLT2 inhibitor group. So to summarize, diabetic patients with chronic kidney disease tolerated SGLT2 inhibitors well. There was significant reduction in weight with the use of SGLT2 inhibitors. There was stabilization of proteinuria and creatinine clearance during 6 months of follow-up in SGLT2 inhibitor group, while there was worsening of proteinuria and creatinine clearance during 6 months of follow-up in non-SGLT2 inhibitor group. Thank you.
Thank you, ma'am. Can we have 1 or 2 questions from the judges?
Yes, very good presentation, Dr. Meeta. Just for curiosity, that why did you measure creatinine clearance and not EGFR?
So in Indian subjects, the creatinine clearance has better because we consider the weight in consideration.
Correct.
Indian subject that is more proven.
Okay. Because most of the studies with SGLT2 are based upon the CKD-EPI formula. Here
Yes.
you have used creatine clearance.
Yes.
So I agree with you that weight has to be taken in account, and
It's
probably that may be
more.
okay. And why was there that much gender difference between the two groups? I'm not talking about non-SGLT and SGLT, but in both the groups, males were about 80%, females were just 20%. Because that does not reflect the actual prevalence of CKD in diabetes.
Both the groups, the ratio was the same, but maybe ratio was the same in both the groups.
So this may be a chance finding, but then there is underrepresentation of females.
Female.
So a feminist may raise a question.
And regarding your baseline selection, there was a clear difference in the creatinine levels. So I think it changes the stage of the CKD.
The CKD was about the same.
CKD stage was same?
Yeah, stage 3.
Okay.
Most of them were in stage 3.
Okay.
And slightly less because in some cases, at that stage, if there was slightly less GFR, you don't want to start because you do not know whether
that's so.
Follow up very regular in 3 months or not. Or
okay, so that's what I thought, that you were defensive in giving this SGLT2 inhibitor.
But there was no major difference.
Okay.
All were in stage 3.
Okay.
Okay, very good presentation. And if Dr. Sunil or Dr. Reena has any question, otherwise we can go ahead.
Yeah, we can go ahead.
Thank you. Okay. Thank you, Dr. Meeta. We will move to our last presentation of the day, and that is by Dr. Silvia Sabatini. The effects of pioglitazone on fat distribution and metabolism in patients with NASH. Can we have you? Yes.
Yes.
She's
Hello.
here. Yes, we can hear you. Yes.
Hello. I'm Silvia Sabatini, and I'm a PhD student of the Institute of Clinical Physiology at the CNR Pisa. And my research is about the effect of pioglitazone on fat distribution and metabolism in patients with NASH. NAFLD, non-alcoholic fatty liver disease, is a complex liver disorder which is growing in prevalence worldwide, and this common form is liver steatosis, but it may progress in NASH, which is non-alcoholic steatohepatitis, or cirrhosis. NAFLD is often associated with obesity, insulin resistance, and lipid metabolic dysregulation. And currently, no drug has been approved yet for its management, and body weight loss and lifestyle intervention remain the most effective treatment for this disease. On the other hand, pioglitazone, which is known to be a treatment for insulin resistance, has been proposed also for the treatment of NASH, despite it produce body weight gain. And this is because, as we can see in this picture, pioglitazone also reduces visceral and liver fat accumulation. So the aim of this study was to evaluate and compare the effect of dietary counseling on weight loss or pioglitazone on hepatic and intra-abdominal fat accumulation, and try to investigate if the changes that we observe in liver fat are due, or at least possibly mediated by, a decrease in the visceral fat or an improvement in lipid metabolism. So we evaluate 35 patients with biopsy-proven NASH, which were assigned in double-blind to treatment with pio or placebo for 6 months. And before and after this period, they had OGTT, and their liver, subcutaneous, and visceral fat was measured by magnetic resonance. Patients were therefore grouped in three classes: those who went on PIO, subjects who had placebo and that lost more than the 3% of their body weight, and placebo subjects who did not, so they failed the dietary counseling. And then we try to separate, to discriminate these three groups. As we can see in this picture, we try to partially square discriminant analysis, and we can see that we are pretty able to distinguish the three classes. We repeat this model with different tasks, as we can see in the table below, and we measure accuracy through cross-validation, and we always achieve a very high accuracy. But just in the first three tasks, we have a significant p-value, which was measured by random permutation test. So we are able to distinguish between PIO and body weight loss, between PIO and diet fail, but we are not able to distinguish the two placebo groups. So our next question is, which are the main discriminator factors in these separations? And we can see that adipose tissue distribution, adiponectin and liver fat are the most important, but not the histological parameters. And if we look at the bar plot, we see that body weight loss and PIO are both able to reduce liver fat and to reduce liver enzyme, but just PIO, only PIO, are able to increase the adiponectin and to reduce the visceral over subcutaneous fat ratio. So to conclude, in patients with NASH, visceral and hepatic fat are tightly associated, and the action of weight loss and pioglitazone are really different and have different effect on fat distribution and metabolism. And thank you for your attention.
That was just on time. Can we have questions now?
Yes. Can we have the conclusion slide again?
Oh, yeah.
Yes, Ramesh, you can start.
Yeah, so what was the dose of pioglitazone?
Sorry, can you repeat the question, please?
What was the dose of pioglitazone?
I can answer this, Dr. Ramesh Amalia Castaldelli, and
the
dose
please.
was 45 milligrams. And actually, just for the clearness of this, these are the same patient of the initial study with Dr. Cusi, the Belfort study that was published on the New England. This is just the subgroup that did also the abdominal MRI for the measurement of the visceral fat.
Okay.
Yes. Very good presentation, Sylvia. You share the common surname with Gabriela Sabatini, we know, the famous tennis player from Argentina, right? Yes, we have been using pioglitazone, and we have also found a good beneficial effect of it on the liver fat. Unfortunately, the dose which we use is 7.5 and 15 milligram. Do you have any comments about that dose being used for improvement in the NASH?
I can answer this because it's more clinical, and Sylvia is just a PhD student. She just started. I think this is a very interesting question, and as Ken Cusi also answered yesterday, we don't have data about such as a low dose, but I really think that pioglitazone start acting in a dose response way, but is acting also at a very low dose. So it's for sure you have a beneficial effect. What we see here, especially in this slide that is still on, is that also the diet make you to change the liver fat. And if you look, there was a strong correlation. Sylvia, you can put the correlation figures. Yes. That was the changes in visceral fat were parallel in the changes in liver fat. So if you decrease weight and at the same time you add on pioglitazone, I believe you have like a synergic effect to decrease visceral fat and to decrease liver fat. We have to remember that most of the hepatic fat comes from the overflow of free fatty acids. So if you lose some fat, especially visceral fat that is going directly to the liver, you have a reduction in hepatic fat, and plus with the pioglitazone, you also have an anti-inflammatory effect. So I think it's correct. You can just use it at the 7.5. Of course, the effects will be a little less, but you will avoid all the side effects that we know they are present. And I think it's better than just not giving anything, for sure.
So very good presentation, Sylvia, and very relevant answers. I think we move ahead if there are no other questions.
Yes, thank you so much, everyone. Do we have any questions from Dr. Sunil? Can't see him. Okay, with this we would conclude, and I would like to hand it over to Dr. Rucha Mehta.
I think we asked Anam to have just 1 minute as the last, because there was some interruption. So can Anam come with the last slide only, or?
Sure. Miss Anam, are you with us? If you can show your conclusion slide to the judges, and you'd like to conclude in last few words, like in 1 minute, if you can present again.
Meanwhile, Rucha, you can.
Yeah, so I think that was very good.
I think everyone presented their points in a very good way. Just 1 or 2 suggestions to some young people, that in a webinar, your slides should not be too busy. You should take example from Dr. Meeta Shah. Her slides were just 3 or 4 sentences in every slide, and that makes it more sense, especially in the webinars.
Okay. So I would like to just say that that was excellent presentation. Anam, are you there with us? And we can give you your promised 1 minute by the judges. Is she there? I don't see her. She's having some network issues due to heavy rain.
Okay.
Anam, are you able to connect?
Yes, ma'am. Sorry for the connection loss.
So show us your last slide. And then if there are questions from the judges.
So in this figure number 2, we compare the Barthel index that is used for functional assessment with the nutritional assessment of the patient. So here we found that low Barthel index score 1, that is indicates by yellow bar, was most observed in the MNA and NCL malnourished group, that is 54% and 63% respectively. So there was a significant association found between nutritional status and Barthel index score. So here we conclude that nutritional ability and functional status goes together, as the malnourished patients are at risk of poor functional status. So therefore, early nutritional assessment and nutritional care plan is important for this vulnerable elderly people.
Okay, correct. So the early assessment at the time of admission should help improve the outcomes, right?
Yes, sir. Yes, sir.
Yes, it's a good point. Any questions, Ramesh?
No, I think the presentation was clear, and there's no doubt that nutrition plays a very important role, and it is a neglected part of the hospital practice.
Okay, great. If there are no more questions, then we can conclude this session.
Yes.
Sorry about the initial technical glitches, which has delayed us by half an hour. Thank you to all the contestants. It was lovely to see you, Dr. Meeta, Amalia. Thanks for contributing as always. And nice to have one international presentation, our first ever global cardiometabolic conclave. So keeping it in the global theme and global feel of things also. So I'm going to allow the judges 10 minutes to put together their results, and then they'll send it to us. I invite you all back at 1:15 to this conclave, where we will announce the prizes, and at 1:25 we have to start the next session. After that, I would request all the research participants to log in after that from the Zoom, not from the Zoom link, but from the delegate link, because we will have all the other faculty joining us, except of course people who know their faculty, Amalia, of course, you know, and the rest, Dr. Rima Rao and all. So thank you again, everybody. At 1:15, we'll be announcing the prizes over here in Mahatma Gandhi Hall. So look forward to seeing you, and thank you for your presentations, but do give the judges 10 minutes to get their thoughts together. Thank you.
Thank you, Rucha.
Hello. Hello.
Hi.
कोई नहीं है.
Hi, Shilpa. Love hai. We just concluded our research meeting, so research competition. So give us 5-10 minutes. We are just getting the results. Good
Come
to
back
see
in
you.
10 minutes.
Yeah, come back in 10 minutes. Yeah.
Greetings from Ahmedabad. I am Professor Ralph
This is just
DeFranco,
playing in the halls.
Chief of the Diabetes Division
There is
at
a
the
song
University of Texas Health Science Center in San Antonio, Texas.
No, these are, we are just playing these videos in all the halls.
All of you to the first Global Cardiometabolic Conclave, which will take place on July 11th and 12th. This will be a virtual meeting, and I hope that you will join myself and the organizers, Professors Sanyer Dani and Rucha Mehta, who've done a fantastic job of recruiting outstanding clinicians and clinical investigators from India and throughout the rest of the world. The focus of this cardiometabolic conclave will be on the cardiometabolic syndrome and its relevance to insulin resistance and the metabolic syndrome, which I prefer to refer to as the insulin resistance syndrome. This syndrome is very, very common in Indian people and contributes in a major way to the increased cardiovascular mortality and morbidity. With the plethora of cardiovascular outcome trials and real outcome trials that have been published in premier journals in the last 5 years, the topic of this conclave is, I think, particularly pertinent, and I look forward to joining all of you in this important conclave that will take place on July 11th and 12th. Again, you can see here in San Antonio, it is very warm, it's very sunny. This is my backyard, although I have to say I'd rather be with you in India at the present time.
Managing cardiometabolic syndrome poses increasing challenges to the physician across the globe. Come to Ahmedabad on 11th and 12th July for a great interdisciplinary meeting, the Global Cardiometabolic Conclave, and take home some valuable pearls.
Hello dear friends, I am Dr. Bansi Sabu, diabetologist based at Ahmedabad. I am currently Executive Secretary for Diabetes India, which is supporting organization for Global Cardiometabolic Conclave. This unique conclave, which is designed by Dr. Rucha and Dr. Samir Dhani, having a combination of cardiologists and eminent diabetologists and endocrinologists from all over the world. And we all will be listening at our ease from our drawing hall on this Saturday and Sunday. In this global conclave, we have star speaker like Dr. Nissan from Cleveland Clinic and Dr. Ralph DeFranco from Texas. This meeting will be unique because it is supported by World Congress of Prevention of Diabetes, Dr. Jacob, and Dr. Amalia from Italy, who is with the European Association of Insulin Resistance. They are supporting the meeting, and we are going to have more than 20,000 delegates from all across country. Once again, I congratulate Dr. Rucha and Dr. Samir Dani for organizing a wonderful meeting, Global Cardiometabolic Conclave. We all are looking forward to listen all the galaxy of speakers. Thank you.
Hello everyone. Today, in the midst of this COVID pandemic, we Indians must not lose focus of the other epidemic. Yes, I am referring to the lurking tsunami of cardiometabolic diseases. Doctors Samir Dani and Rucha Mehta have dished out an excellent academic feast to be delivered by some of the top experts in the field of cardiology and endocrinology. I, for one, am going to be glued to the laptop over the 2 days of the conference. Are you? Well, see you there.
Cardiometabolic syndrome is a clustering of metabolic and hemodynamic abnormalities. It has been recognized as a disease entity by the WHO and American Society of Endocrinology. It includes insulin resistance, impaired glucose tolerance, type 2 diabetes, hypertension, atherogenic dyslipidemia, and truncal obesity. Together in combination, this cluster of risk factors increases the risk of cardiovascular diseases. Thank you.
The concept of precision diabetes care has evolved from being a tool simply to individualize patient care to a broader group to identify clusters or subgroups of people with diabetes or at risk of diabetes. And this concept of precision diabetology will help us to prevent diabetes and to prevent the complications of diabetes and ultimately treat patients with diabetes more precisely.
Hello everyone, I am Dr. N.K. Singh, diabetologist physician at Dhanbad, Jharkhand. I congratulate Dr. Rucha and Dr. Dani for the upcoming unique event to be held on 11th and 12th of July. And I welcome you for a very exciting session on 11th of July at 4:45 to 5:25 p.m. in the Sardar Vallabhbhai Patel Hall. And that will be on the prevention of cardiometabolic syndrome with drugs by R. Guardado from the Mexico. He will present very exciting data of prevention of cardiometabolic syndrome with drugs from the prelim study. I think this is a very unique study which has shown that the combination of linagliptin, metformin and lifestyle improved significantly glucose metabolism and pancreatic beta cell function and reduced the type 2 diabetic incidence in subjects with pre-diabetes as compared to metformin and lifestyle. So come, enjoy it, tune it. Thank you.
Hello dear friends, I'm Dr. Rajiv Kovil from Mumbai. Research is about creating new knowledge, and new knowledge has to be extrapolated into clinical practice. No one better than the experts and the legends that Dr. Samir Dani and Dr. Rucha Mehta have gathered for the Global Metabolic Conclave over this weekend. So I would expect all of you all to tune in because you're going to get the legends, the global leaders speaking on their work and their research. And in this pandemic, nothing better to kill our time. See you all there.
Hello all, and welcome to the Global Cardiometabolic Conclave to be organized digitally on the 11th and 12th of July. I'm Dr. Rucha Mehta, consultant endocrinologist and diabetologist at Apollo Hospital CVHF and EGMO Clinic Ahmedabad, and I'm the co-organizing chairperson for this conclave. So what is this conclave all about? As most of you are well aware, the diabetes is increasing in India and so is cardiovascular disease. And why is this happening? What is it that is making Indians more and more prone to developing these diseases at a younger age? We have organized a scientific program that details right from pathophysiology and origins of the metabolic syndrome, insulin resistance and its correlation to coronary artery disease. And then we have carried forward and gone all the way to diagnosis, treatment, a review of complications, prevention symposium including a nutrition and lifestyle symposium, and also looking at novel biomarkers by experts in the field. We have partnered with several national and international bodies such as Diabetes India, EGIR, and WCPD. I can promise you that if you sign up for this conference, you will enjoy an academic feast and will walk away learning something that will change your practice. So if you are somebody who believes that through their practices they need to improve not just their own cardiometabolic health, but also that of their patients and of their family and the society around us, I strongly urge you to sign up for this conference. We have all been through trying times in the past 2 months, but here's a chance to get away and look at science and learn something new. I thank you very much for your attention and I look forward to seeing you digitally on the 11th and 12th of July. Thank you.
I congratulate Dr. Rucha Mehta and Dr. Samir Dani for this fantastic academic treat planned for the weekend of rainy July. Seems like perfect time to stay indoors, yet get exposed to the most updated information, know-how, clinical practices and recommendations, and hear it straight from the excellent lineup of international as well as our very own clinical experts as faculty. The burden of the disease, its nature and management are all constantly evolving and improving as more and more clinical research is enriching our field. Cardiometabolic syndrome is a medical term coined for a cluster of metabolic abnormalities, each of which is highly prevalent in India, and together they are devastating, making your participation and training at the conclave so important. I hope this motivates you to click on that link to register and plan your weekend so that you are able to enjoy and imbibe this scientific wonder from home for free. Thank you.
Hello everyone, I'm Dr. Om J. Lakhani. I work as a consultant endocrinologist at Zydus Hospital in Ahmedabad. I strongly believe that the exciting new data, some really good research, and some new medications are bringing the fields of diabetes and cardiology closer together as never seen before. The Cardiometabolic Conclave, organized by Dr. Rucha Mehta and Dr. Samir Dani, is one of its kind web conference having some of the best speakers from across the world in the field of diabetes and cardiology. I strongly urge you not to miss this conference. See you there. See you online.
Cardiometabolic syndrome. I'm Dr. Dhruvi Hasnani, a diabetologist from Ahmedabad. Prevention and reversal of cardiometabolic syndrome is possible, and we as healthcare professionals must strive to educate our patients on this. Thank you.
Good afternoon, Dr. Taylor, or rather good morning to you. Welcome. I'm Dr. Rucha Mehta. It's a great
Hello,
pleasure.
Rucha. Nice to meet you.
Nice to see you again. Yes.
That's very good. Very good to be connected like this. And so you've done a great job in pulling the conference together.
Thank you so much. I appreciate it. I would like to introduce you. I see that Shilpa Joshi, she's going to be one of the chairpersons for your session. She has joined. She's the Vice President of our Indian Dietary Association. Amalia is saying hello. She's waving to you. And also
great.
we have Dr. Samir.
Oh, yes. Hello, Amalia.
Hey, Roy. Good to see you again.
Very nice to meet up, albeit virtually.
Yes.
And we have Dr. Samir Dani, who is also our organizing chairperson. He's a cardiologist and he's heading up our Apollo CVHF.
Hello.
And I see Cheryl Salish. She's a senior dietitian. So you have a lot of fan following in India. Everybody is logging on the faculty side. But in the audience, we already have more than 1,000 people waiting to hear you.
Great.
So we had announced that we had a research presentation in the morning, but one of our judges has not yet sent in their results. So we will have to announce the results a bit later today for all the participants. I apologize. So we'll announce it just maybe after Dr. Roy Taylor's presentation, because we don't want to be late with that. Have you tested your slides, Dr. Taylor? Do you want to just go ahead and do a screen share? Because we still
yes,
have
why don't I do that?
We still have 10 minutes before we begin. So maybe it's a good time to check it.
Hardik,
we are just going to have Sir check his slides, okay? I'm just telling the events.
Yep,
people.
here we are.
Okay.
Here we are. Desktop. And full screen. So that's my first slide. Can you see that?
Yes. Very well. Very good.
Yep.
Yes.
Okay. So I'll come out of that if I can. Stop share. There we go. And back. Okay. Better just return to the first slide. There we are. Good. And back to your screen. So I think we're set from the technical point of view.
Yes.
Yes.
Perfect. Okay. We will begin in 3 more minutes with just a brief introduction and a video. And then 1:30, I shall invite the chairperson. Shilpa was really excited to meet you. So Shilpa and Zamrud, here's your chance to say hello to Dr. Taylor before we begin.
Hello, Dr. Taylor. Shilpa Joshi here.
Hello there.
Hi. My friends from Indian Dietetic Association, that's Cheryl and that's Zamrud Patel.
Hello, sir. Dr. Taylor.
Hello.
So, sir, you have a very big fan following in India. We all the time read about the direct trial and quote it all the time.
Yes, true.
Thank you.
Yeah, so we are really looking forward to hearing you in person.
Very good. Well, I'll try and make it as relevant as possible to India, of course, and some of the dietary information, I hope, will be very useful, because there's a certain simplicity that's often forgotten in the talk about what to do about diet, that terrible word.
Hello, Dr. Amarpal. Nice meeting you.
Nice to meet you.
Amalia, Shilpa saying hello to you. I think
hey, hello.
Oh, hi, Amalia.
Planning meetings now here.
And we also have Zamrud, who has joined us. She's also a senior and chief of our dietary department at Global Hospitals in Mumbai. She does a lot of work with liver and kidney transplant patients. And a very active transplant department in Mumbai they have over there.
Excellent.
And everybody agrees in all your theories.
Good afternoon, Dr.
Hi, Rucha.
Okay, who's saying hello? Hi.
Hi.
Oh, hi, Dr. Bajaj. Thank you so much for joining us.
Hello, Dr. Roy Taylor. Good to see you.
Hello, Dr. Bajaj.
Hello. And I see Dr. Anup Mishra has also joined in. I believe I don't have to acquaint you with him. He has kept himself on mute, but he's here. And Dr. Bajaj is a very senior diabetologist.
Hello, Anup.
I think he gave an excellent talk on cardiometabolic syndrome and its ramifications. Hi, Anup.
Hello.
Good morning. Good afternoon, sir. You're muted.
Anup, please unmute yourself.
Unmuted, sir.
Oh, right. First of all, let me, it's an honor to meet you, sir, Dr. Taylor. I'm aware of your excellent work, and we are in touch with several of your colleagues in the UK. So thank you for coming here, and I thank Rucha again, and welcome Shilpa, Cheryl, Dr. Amelia, and Dr. Samir Dani. Thank you.
It was actually a pleasure to be chairing this session because there are so many publications that I think phenomenal work that he has done in relation to reversal with diabetes. I went through your, I think, a lot of reviews, calorie restriction and reversal for long-term remission and type 2 diabetes. And of course, the recent one, understanding the mechanisms of reversal.
Yes, thank you. I'll try and distill it all down into just 30 minutes or so.
Yeah, I'm sure you're capable of that.
Mishra sir, we missed your talk yesterday. We were busy in an IDA meeting, but I heard so much about it on the groups.
No, thank you. This, I'm sure part of it you have already heard. So,
I echo that. That's the first thing I said when Anup joined in. There's so much praise, not only for this talk, but for all your talks. It's always such a pleasure to listen.
Yesterday that I couldn't hear it because we were in another meeting.
Yeah, you said that.
Yeah, but amongst all the current meetings, this is the meeting which is the most attended. There are several others which are going on in the country at this
That's
point.
right. Simultaneously, there's so many online meetings now, but I think this is really set a benchmark. So congratulations to Rucha and Samir.
I revealed myself so you could all see me doing the little dance. Thank you so much. That's, it's always a great honor getting those
my residents also logged in and they're praising it to the skies. Like, of course, they're choosing their sessions and they're really appreciating. Thank you, Rucha and Samir.
Thank you so much, ma'am. And I think it's 1:27. I'm going to just go ahead and we'll get started. Hardik, can we go live? So we are going to, not the video will be after in a bit. So are we live now, Hardik?
Yes, we are live. I was just trying to unmute, so by mistake I stopped sharing. Sorry for that. I'll share again.
Okay. Good afternoon, everybody, and it gives me great pleasure to invite you all back to day number 2 of the Global Cardiometabolic Conclave. We had a wonderful beginning to the first day. We had more than 3,000 to 4,000 delegates in each room. Even for the plenary talk, we had several faculty from all over the world join in, and we've been getting some amazing comments from everywhere. So it's really exciting. And we are looking forward to a second very exciting day of the Global Cardiometabolic Conclave. And I would like to just play a small welcome video for those of you who have missed our inaugural function. So if I can request the event manager to play our welcome video and welcome everybody back again for our second day of scientific sessions. that, I would like to please have the slides for our chairpersons for our first session. We will have the first plenary talks. I invite everybody to be in the Mahatma Gandhi Hall today. For our first plenary talk, our chairpersons are none other than Dr. Anup Mishra, who gave our beginning talk yesterday and started off this conclave. Dr. Anup Mishra is well known to all of us, and he really needs no introduction. He's the executive chairman at the Fortis CDOC Hospital for Diabetes and Allied Sciences. He has been a professor and teacher to most of us. He's also the director of the National Diabetes, Obesity and Cholesterol Foundation, and he's the president of Diabetes Foundation. He's based in New Delhi. Dr. Sarita Bajaj, again, especially for us women endocrinologists, she's a role model. She's a leading endocrinologist. And back in the day, when we were just all thinking about doing this, that's when she went ahead and almost pioneered the field of endocrinology in India. She's director, professor, and head of medicine at MLN Medical College, Prayagraj. And of course, we have Shilpa, who, may I use your words to let Dr. Taylor know how you described him? We have a very famous movie star in India called Shah Rukh Khan, who's a hot famous. And when she heard you were coming, she said, "Oh my God, Shah Rukh Khan is coming to India." So, so I'm sorry I had to share that story, Shilpa. She's a senior nutritionist based in Mumbai, and she's the vice president of the Indian Dietary Association. And I will now hand it over to the chairpersons to take this session forward with their blessings. Thank you very much.
Thank you, Rucha. I'm honored to be chairing this session, and we have, highly expert other chairpersons, Dr. Sarita Bajaj and Shilpa Joshi. Let me read out Dr. Rod Taylor's short biography, although his actual biography runs in several pages. Dr. Taylor qualified in medicine at the University of Edinburgh and is professor of medicine and metabolism at Newcastle University and Newcastle Hospital, NHS Trust. He founded Newcastle Magnetic Resonance Center in 2006 to develop innovative research techniques for all medical specialties. To all of us, his most significant discovery has been the role of excess fat in liver and pancreas in development of diabetes and then reversal of diabetes. His subsequent work has clarified under pathophysiology and led to practical application and several of the path-breaking studies. Professor Taylor developed the system now used throughout the United Kingdom for screening of diabetes, eye disease, with major reduction in blindness due to diabetes across UK, a laudable achievement. He has delivered several named lectures, including 2012 Banting Lecture, Diabetes UK, 2015 Harry Keane Lecture, and 2016 Samuel Gee Lecture, Royal College of Physicians of London. So welcome, Dr. Taylor, and we are keen to hear you.
Thank you very much. I'll share my screen. And here we are. Good. Could you just confirm that you can see my screen, Anup?
No, sir.
No, not yet. Not yet.
Hang on. Let's try again. Share screen.
Yes.
Yes.
Yes, sir.
Come up
Good.
now.
That's perfect.
We need the slideshow. Yeah.
Perfect. Very good.
Yeah, there we
good.
go.
Thank you very much, Anup, for that very generous introduction. And good morning, ladies and gentlemen. I'm delighted to be speaking to you today, actually from Newcastle upon Tyne. Usually when I show such a slide in a meeting, I'm talking about a distant city, but here I am. And the scene you're looking at is the River Tyne and the Newcastle quayside, especially our bridges with the Millennium Bridge in the foreground. Of course, a bridge is a means of getting from one place to another. And the same can be true of ideas. So where we started from was the widespread belief that type 2 diabetes was a lifelong disease. It was incurable. The beta cells were dying and we didn't know why. And there was a mystery about the insulin resistance, which has given rise to such confusing information overall. So when the ideas came on reflecting on the basic simplicity of this disease, if a population is given too much food, the incidence rises. If a population is relatively short of food for whatever reason, the incidence falls. So is there a simplicity here? It occurred to me in 2006 that everything could be explained by too much fat inside the organs, inside the liver and inside the pancreas. That would produce exactly what we saw. But of course, we need to formulate this as a hypothesis. And by 2008, I was able to write up this hypothesis as the twin cycle hypothesis. And the only purpose of having a hypothesis is to try and test it. You need to try and destroy your own hypothesis. And we could easily destroy this hypothesis by demonstrating that negative calorie balance, suddenly giving people less food, should reverse everything and produce normal glucose control. And if it didn't, it was wrong. So we set out with the belief that negative calorie balance in people with type 2 diabetes will, in the liver, decrease the level of fat, improve insulin action, and therefore the overnight level of blood sugar, the fasting blood sugar, would normalize, because one of the main roles of insulin in the liver is to control the constant flux of glucose that's being made by the liver. So that's a liver story. But if there's too much fat there, it would tend to go to all tissues of the body, the coronary arteries, for instance, but also the pancreas. And in the pancreas, it could decrease the ability of beta cells to produce insulin. We knew that from in vitro experiments, but now we could test it quite simply by inducing negative calorie balance. So how were we going to do this? Because I'm a physician, I live in the real world, and getting people in everyday life to reduce their calorie intake is something of a challenge. But it was quite clear that in order to get a sudden reduction, to get people to lose about 15 kilograms of weight, which I calculated we would need to do, we had to adopt a very distinct approach, and here it is. Using a liquid formula diet gets over many of the nutritional barriers to reducing calories, because this is nutritionally complete in terms of minerals, vitamins, etc. Here is breakfast, here is lunch, and here is dinner, made up in a pint of water. So there is a simplicity here which avoids the big problem of cutting back on food, which is the day-to-day burden of decisions. Can I eat this? Can I eat this? How much can I eat? It's a real challenge, and that burden is a cumulative burden, and it gets to people after a while. So for breakfast, a packet. For lunch, a packet. It's all very simple. And in addition, people could eat non-starchy vegetables, as illustrated on this plateful. That's what we did. I thought it was going to be difficult to get people to stick to the diet to achieve the 15 kilograms weight loss. But in fact, much to my surprise, this proved to be very acceptable to people, and they went for it. They achieved an average of 15 kilograms weight loss. But what happened to blood glucose? Well, starting, blood glucose was 9.2 millimole per liter fasting in this whole group. On day one, we stopped the hypoglycemic agents, metformin in the study. So that was stopped. And what happened to blood glucose was that it fell on this low-calorie diet. About 600 calories from the liquid formula diet and about 100 to 200 from the non-starchy vegetables. So here we see dramatic normalization within 7 days, exactly the same effect as one sees after bariatric surgery when eating has to be stopped because of the surgery. The mechanisms are actually identical. So here we see the first part of the hypothesis, and for the 8 weeks of the study, we saw continued normoglycemia. But we were able to detect the level of fat inside the organs. We were able to measure the insulin sensitivity of the liver and measure the ability of the pancreas to secrete insulin. So we were able to say at the end of this seminal study that cutting back on calories to lose 15 kilograms, it was 15.3 kilograms on average for the whole group of 11 people. And note, it's a small study, but the effect size is so large that forget the studies of several thousand people that you need to test a new drug. That's because the effect size is so small. Here we have an effect size that is enormous. But we were able to show that liver fat was grossly elevated at the start. In fact, it was an average of about 13.5% in this study. It rapidly fell to 2%. Liver insulin sensitivity was normal by 7 days. The liver fat pool is very labile, but the change in the pancreas was much slower. Over the 8 weeks, there was a very gradual fall in the level of fat, very gradual recovery of first phase insulin response. Now, one thing about the Counterpoint study, published in Diabetologia 2011, was that I had deliberately selected people with relatively short duration diabetes in order to be able to get the purest test of the hypothesis. Because we've known for decades that type 2 diabetes is a steadily progressive disease and beta cell function goes down over time. The UK PDS study showed that brilliantly. So we needed to broaden our focus and look at people of all durations. And we did that in our next study, the Counterbalance study. And I just want to show you one piece of information from that study. Because we included people of all durations, some people didn't respond. But here are the responses of the pancreas, the first phase insulin response, in those who did. So the ones who responded had a poor response at baseline. After losing about 15 kilograms, it was, in fact, up to normal levels. And we continued the study for 6 months, keeping weight constant, to answer one of the criticisms of the Counterpoint study, that this was just a starvation effect. It would all go back to normal. There was widespread disbelief amongst experts and doctors that this could be a real effect that would be prolonged, but the Counterbalance study demonstrated that indeed it was prolonged. 6 months of isocaloric eating. But let's look at the data on the non-responders. And here you see the very poor beta cell responses. But the point I want to make is where they started from, because the non-responders had beta cells in which the lights had gone out. They were actually beyond the point of being resurrected. So what are the clinical differences between these groups? Well, for a start, HbA1c was very modestly higher in the non-responders, but the huge difference was, as you might expect, in the duration of diabetes. Just like in DIRECT with people up to 4 years duration, people in the responder group had a mean duration of 3.8 years. Now, that bears an additional comment because we now know that people even up to 20 years duration can sometimes respond, but they're quite unusual. By 10 years, probably about half of everybody can respond, but in the first few years, the vast majority can. The non-responders had a duration of 9.8 years. So here we see the most important parameter, unscrambling the nonsense that's mentioned about the heterogeneity of cause of type 2 diabetes. That's because people of all durations are jumbled together. So let's take a very straightforward, simple view of this. We need to take into account duration when we're assessing the physiology, what's going on in that patient in front of us. Now, I had set out many years ago, in fact, decades ago, to try and discover the cause of type 2 diabetes. And indeed, we had achieved that. This is fat in the organs, the liver and the pancreas. Everything else is a minor player. But the acceptability of this low-calorie approach led us to reason that this could be something that could be so simple, it could be employed on a population level. So we set out to train practice nurses. These were nurses, sometimes dietitians if they were available, who were actually working in routine NHS practice. They had 8 hours of structured training to deliver this program. And in DIRECT, the Diabetes Remission Clinical Trial, we studied people of less than 6 years duration on oral agents or diet. But let me just emphasize, this was not a weird group of people who are highly motivated or very different. 20% of the group came from people in the lowest socioeconomic grouping. So we had a true cross-section of the ordinary folk with type 2 diabetes that you have in your clinic and I have in mine. They were randomized by practice to have the intervention, which was aiming for 15 kilograms weight loss, or to best practice according to current guidelines. Tablets in order to get blood glucose control, insulin when necessary, all the usual things. So what happened? Well, let me cut straight to the chase, because this is a diabetes remission clinical trial. What was the remission? Well, at 12 months, the remission was 46% in the intervention group. That is a non-diabetic HbA1c and off all treatment, of course. And naturally, in any clinical study, a few people in the control group hear that it's a study that involves some weight loss and go about and lose weight. And indeed, a few people actually lost up to 15 kilograms. So there is a small remission percentage. But this dotted red line is important because my colleague Mike Lean, who is a co-investigator on DIRECT with me, and I calculated that if we got 22% remission, it would be clinically effective and cost effective. So we were hoping that we would get 22% remission. We got 46% remission at 1 year. 1 year was the only time we could really model. But of course, the trial went on for 2 years. And even at 2 years, we had 36% remission in the control group. Bear in mind, this is by intention to treat. Some people dropped out at baseline even before starting, but they're included in the non-responders here. We presumed people who left the study were non-responders. So this is over 1/3 free of diabetes, off all tablets at 2 years. Really quite a huge effect. But what was driving this effect? Well, we can be quite clear. It was the amount of weight loss. If they didn't lose much weight, not much remission. If they lost over 15 kilograms, then most people would be in remission. But there's a handy bottom line here. If people lost more than 10 kilograms, about 2/3 were in remission by this intention to treat principle. We measured lots of individual physiological functions to test the twin cycle hypothesis, and these have been published in a series of papers in Cell Metabolism, 2 papers there, and most recently in Diabetes Care. And I just want to summarize everything by talking about the most important parameter, that is of beta cell function. And here we have maximal beta cell function. At the beginning, the start of the trial, beta cell function was low. We know that it's about 50% of normal. lots of studies have shown that, whether by histological study of counting active beta cells, or indeed a variety of tests. So non-diabetic controls that we studied to match our diabetic subjects after weight loss had this level of maximum insulin response. But just look what happened. Immediately after the weight loss and up to about 5 months, there was no significant change in the maximum insulin response, reflecting total beta cell mass. But gradually, up to 12 months, just look at this, it went back to essentially normal. Is there any evidence of ongoing loss of beta cell function, provided you've taken the fat away and keep it away? Well, no, there isn't. It remains absolutely steady. So we can dispel this notion of inevitable decline of beta cell function. We can actually guarantee restored beta cell mass in early type 2 diabetes. Now, that's quite enough science for one go. Let me just consider the link between Newcastle upon Tyne and India. In a square in the center of the city, there is a statue on top of this column, and it is Charles Grey. He's a local lad made good. In the 1830s, he became Prime Minister of England, and one of his finest achievements was to abolish slavery in the British Empire. Now, an Indian tea blender heard this account and decided to name his latest blend of tea after Charles Grey. Charles Grey, by then, had been given a title. He was Earl, made an Earl. And so he was Earl Grey. And this is the origin of Earl Grey tea, that delicious mixture of bergamot oil and tea. So here in Newcastle is the very symbol of a link with India. Let me try and put together all the information I've presented so far by reflecting it on what I published in 2008. Here we have the twin cycle hypothesis. What did we imagine was there, and what can we now say? Well, long-standing positive calorie balance was causing the type 2 diabetes. People were gaining a little weight year on year over decades, and that was building up liver fat. Now, we know that pre-existing insulin resistance in muscle, which is largely genetic, but also affected by exercise and overweight, if there's insulin resistance in muscle, we can't store the incoming carbohydrate as muscle glycogen. And our earlier work with magnetic resonance showed that that was an important component of keeping sugar levels down after a meal. And if it can't be stored as glycogen, there's only one pathway in the body. It has to be turned into fat, sugar turned into fat in the liver, de novo lipogenesis. But there was already information that liver fat would cause resistance to insulin in the liver. And that tendency to produce too much glucose would cause the background insulin levels to rise a bit. But the enzymes that stimulate glucose to fat are actually sensitive to insulin, not affected by insulin resistance. And so we would start a slow vicious cycle. So day by day, molecule by molecule, liver fat would build up. And eventually plasma glucose levels would start to creep up, causing more basal insulin secretion. And this vicious cycle would spin even faster. But fat doesn't just stay in the liver. It's secreted from the liver as very low density lipoprotein, the only lipoprotein that's worth knowing about, because that is the original lipoprotein. Everything else is merely the same thing that's delivered part of its payload and changes its density. So liver fat producing VLDL would normally be largely stored as subcutaneous fat. But if these stores become relatively full, they'll start getting inflamed and the fat has to go elsewhere. And this is, of course, when VLDL triglyceride will rise in blood and the fat will be delivered to all the ectopic sites, like the coronary arteries, and also the pancreas. So if islet fat goes up, we knew from beautiful in vitro studies by Roger Unger many years ago that the acute insulin response to food would start going off. The level of glucose in the blood would stay higher after eating, and that would nudge the pancreas into grudgingly produce more basal insulin. Now, this touches on a paradox of type 2 diabetes that is often confusing to medical students, that basal insulin levels are high, fasting insulin is about twice normal. But the response, the rapid response to eating, is grossly deficient. Insulin levels go up further, and these vicious cycles interact. Now, over the intervening 12 years since this was published, we've proved each of these steps, the liver fat being high, going down, the pancreas fat being high, going down, the insulin sensitivity returning to normal, and the acute insulin response returning to normal. So we can be reasonably certain that this does reflect the true etiology of type 2 diabetes, a simple disease of too much fat in the body. At one point, these cycles will break down and plasma glucose will rise rapidly. And indeed, the Whitehall study showed exactly this is what will happen. Now, quite briefly, let me just consider how simple the diet is for weight loss. To be practical, it has to be simple. It's critical as part of the diet that the spouse or partner or family or friends have to be on board to support the individual. And that discussion has to happen at the start. It's part of the diet. Diet isn't about what you eat. We all eat food. The circumstances and the attitude to eating is a critical thing. And the fact that the calorie limitation is only for 8 weeks, or in fact slightly longer in direct 12 weeks, then it means you can plan that. You can avoid your holidays, your birthdays, if you like. You can plan when to start. One interesting thing that I must emphasize is that we advised no additional exercise during the weight loss period. The message of how to lose weight as walk more and eat less is confused. You need first to reduce your weight by the calorie restriction. That's a huge effect on calorie balance. Then, when you're feeling young and like a spring chicken again, you can increase the exercise, because if people who are already no longer young and overweight start exercising, they indulge in compensatory eating, partly conscious, partly subconscious, but that renders exercise counterproductive. So in the weight loss phase, please no extra exercise. However, in the very difficult ongoing phase to maintain weight, exercise is really very important. Now, could this be used in India? Well, yes, we already know. Several studies have already shown it. And I just show one from Maharashtra of 1,000 calories a day, liquid formula diet. 50% had no diabetes at 12 weeks with appropriate fall in weight. And this is nicely published. Larger studies are underway, and indeed the standby study, which is a very large study in India, will be completed hopefully before long, and we'll learn more about the cultural context in which we need to translate the experience from the UK. So Newcastle upon Tyne, here's our new castle. It was built in 1186, so it's still there, but it's a reflection of the people of Newcastle, and that takes me on to the population. And I'd like to broaden the focus to consider the weight distribution as BMI in the UK prospective diabetes study. Now, this was recruited from the late 1970s through the 1980s largely. And just look at the distribution curve. So this curve reflects the proportion of people at each level of BMI. The median in UK PDS was 27. That might appear surprising for a Caucasian, a white European population to have diabetes. But in fact, just look at this dotted line on 25, the upper border of what's called normal. That meant that 1/3, 36%, had a BMI that was in the normal range. What's going on here? We need to try and understand this. And of course, this is highly relevant for our Indian population with type 2 diabetes and cardiovascular disease. If we move away from this smooth curve of populations, which is so seductive, to the reality, because in the consultation, you have one person in front of you. That person may be anywhere on this distribution. Each blob represents one individual, and we can see that you can stack them as a distribution curve. So we can move away from this population basis, which is useful to study global effects, back to the clinic and your consultation. Let's just park that here in line and consider what would happen if we looked at these people, say 10 years before they had developed diabetes. BMI would be about 4 units, 3 to 4 units lower. So this person used to be there, and in blue represents no diabetes. But just consider, this person used to be there, that person used to be there. So let's take some individuals. Here we have 3 people, and if each of them lose weight, they lose their diabetes. They cross a threshold, each of them at a point somewhere between here and here that differs for individuals. And that is such an important concept, so much so we need to give it a name. And this is the personal fat threshold. You have one, and I have one. Mine happens to be fairly low. But if a person has type 2 diabetes, they are too heavy for their bodies. This applies particularly in people of Indian ethnicity because the BMI setting is such that central fat that's in the visceral compartment and in the organs, spills over at a lower level just by genetics than white Europeans. So the personal fat threshold is even more important in India than it is in the UK. But let's consider cardiovascular risk. Here is a notional graph of someone developing diabetes. Their HbA1c used to be normal, it rose up over some years, and then they lost weight and came into the non-diabetic range. Here we have the upper limit of normal. And so in this state that you would regard as pre-diabetes, we know they have high lipids, high blood pressure. It is a high-risk state for cardiovascular disease. And using data from the counterbalance study, we were able to show the 10-year cardiovascular risk was 23% at baseline. These are high-risk individuals. The heart age was 71. High lipids, high blood pressure. But after reversing, they are low risk. And this is so important because the risk does not matter whether it's just in the normal range, and people might be tempted to say it's pre-diabetic. No, this is a low-risk state. And we need to understand that we're talking about post-diabetes. And to underscore that, I'd show the serious adverse events in direct and break it down. Just look at the control group, really quite unpleasantly diseased, compared with our weight loss group. Only one non-fatal MI, no other vascular events, and no weight-related cancers. So all of this information can be found on our website. All the how to do it information. A book has recently been published that gives more detail as to how to do it. But overall, I can summarize back here at the Quayside, looking again at our Millennium Bridge. And I hope you would agree with me that weight loss will normalize the liver fat and liver fat export, and relieved of the excess fat, beta cells can recover in early type 2 diabetes. And it's the personal fat threshold, your personal fat threshold, not BMI, that determines risk. And both cardiovascular risk and type 2 diabetes can be normalized by substantial weight loss. Thank you.
Thank you. Thank you, Dr. Taylor. That was really brilliant. And I'm fascinated by your concept of William of Ockham, that Ockham's razor, defending nominalism. So I think that is what you have been trying to focus on. And you've been talking about 15 kilograms of weight loss. Suppose people cannot achieve that weight loss. Then even if they maintain their weight at whatever level they are, does that also help? Some people really find it impossible. Though, of course, these were very well planned out and followed studies, and you had good support.
Thank you. Yes. The 15 kilogram figure comes from my original calculations, my original imagination that this would be needed. So that's what we actually achieved in the studies. Now, some people do need that. And in a South Indian population, in an Indian population, I think it's really important to realize that it's more sensibly expressed as a percentage. And I would say 10 to 15% of weight loss is what should be achieved. Now, the critical thing is maintaining that in the long term. And if people can achieve this weight loss, get out of type 2 diabetes, then that is by far the best thing. But then all information has to be geared to maintaining that weight loss. This is not about becoming non-obese. Now, you might notice in my slide of the personal fat threshold, the one person was still obese, but they were metabolically healthy, and that's fine. So we're not going for normal weight. We're going for relief of their problems, on the one hand, cardiovascular risk, and on the other hand, diabetes. So this 15 kilograms has to be interpreted, and it shouldn't be taken as an absolute. And especially for people in India, you'll see that this small study from Maharashtra achieved 7.5 kilograms weight loss, and that had a very reasonable response. Now, that 7.5 kilograms is probably about the 10% weight loss mark. So we can interpret it.
And I will quote from one of your articles in which you stated that the doctors and nurses try to dissuade people from losing weight if their body mass index is normal. And yet, when those people lost weight, they were able to reverse their diabetes. So that should be a very important message. Like, I think we're just going back to what you said, that what is your basal weight? And the second thing I want to know about, when we talk about the first 1,000 days of life, when we talk of Barker's hypothesis, Indian children being born with more fat, how early can we start? How early can we really think about it?
That's a very difficult question. Just as a rule of thumb, for people who are currently middle-aged, I would say you need to get back to the weight that you were in your mid-20s. But that message comes with a time expired mark, because now we have children who, large numbers of whom are obese and are going to enter adulthood already obese. This is a difficult matter. And I think that what we need to do is to try and minimize weight gain during childhood using all possible methods. We need to perhaps use waist circumference as a guide to what it should be when people are achieving early adulthood. So I would point to waist circumference as being probably the single most useful absolute measure to try and advise people about what is desirable.
Yeah, but waist circumference and body mass index in children, I mean, it varies across the percentiles. So that's I don't think we have that much data for any population. Sorry, Anu.
Yeah, a quick question, Dr. Taylor. You know, in India, we tried to do something like this. We initiated a protocol, but practically it was so difficult to do. You know, there are 5 people in a family, and one person gets 1,000 calorie or 800 or whatever it is, and rest of the people are eating a whole lot of other things. This person cheats and eats a little bit from the other plate. This is what happens. And often after 3 weeks, 4 weeks, they left the study. They said that we can't do it because I cannot eat differently in a separate room and the other people in the separate room. So how did you manage that?
There are two points. The first is that the matter of getting the person to speak to their spouse or partner, family, and get them on board as being supportive right at the beginning when they're taking the decision, should I do this or should I not? That is absolutely critical. So getting support is important. There's also a really odd phenomenon that comes out. When people are losing weight and start looking fitter and better, some of their acquaintances will try and sabotage the effect. It's unfortunate, but we're all human. And it's important to talk about this with the individual and their spouse in advance of trying to lose weight. So the mental preparedness is absolutely vital. And the second thing is to be absolutely upfront and honest with people about what we're trying to do. If they achieve the weight loss, their health gains are enormous. And it's worth quoting what the majority of my participants said to me: I feel 10 years younger. Now, if you were selling the elixir of eternal youth, you would have a lot of patients. And here you can actually promise that people will feel so much better in themselves if they achieve this. They will get rid of their diabetes. They will stop many tablets. So
you yourself said that you look like a dressed chicken, and that is what pulls people down when they're told that that's what they're looking like, and they look much better with all that chubby look around them. And I think from the very beginning, our mothers tell us that basically we are not eating to live, but living to eat. Yeah. And I think that concept continues for a long, long time. I think it's already 2:13 and we were supposed to close at 2:10. Sorry for that, Rucha.
No, actually, thank you. We have some more discussion. We have other questions. We have a lot of people who have joined in. So I was going to invite Amalia for her comments, and also Dr. Bansi Sabu is raising his hand since a while. So Dr. Bansi Sabu is the president of the...
Hello.
We can hear you, Bansi. Go ahead.
Yes. Yeah. So I'm not talking of the randomized control trial. If we see in real world data, most of our patients will not agree to stop the medicine at the time of the explanation about the reversal of the diabetes. Can we do in stages of reversal? Like some patient who is coming and at that point of time, we start the patients on GLP-1, giving them a low calorie diet instead of giving them a liquid formula diet. And over a period of time, when they stop their other medication, and slowly we reduce one by one. And we have seen in some of our patients in our clinical world that some of patients we could have stopped their medication completely or at least partially. Many of my patients are now only on metformin or only on metformin and SGLT2, and many of the medications we could stop because we had stepped down their calorie content from 2000 calorie to 1000 calorie by giving them GLP-1, and then slowly, now they are maintaining their calorie intake of around 1200. The weight loss is not 15 kg, but around 10% of the weight loss, which is roughly 8 to 7 kg. Most of these Indian patients are around 80 kg. So it had given a good result, but still, do you believe that yes, we should stop the day one all medication
and they should be all put on a liquid formula diet, which is not very practical and doable in a real clinical practice. I am not talking of a randomized controlled trial.
I would say, first of all, that it's proved to be extremely practical in the UK and also in some small studies. Now, I just emphasize that this is done in primary care. It's not an expert doing it in a research center. It's a very ordinary nurse who has been taught. The information and getting the spouse on board and explaining why this is possible is absolutely critical. But in the answer to your question, no, the time course does not matter. What matters is arriving at 10%, 12% lower than the starting weight. And doing it in the way that you suggest is entirely reasonable. Now, I'm well aware that we all work within a cultural framework, a framework of population beliefs, and it is that we need to take account of. And so your approach is entirely reasonable, but you may just want to consider that there are surprising results. If a person doesn't like their tablets and they want to stop it, and you say, you can do, just look at these graphs from the Counterpoint study, this is what happens if you do this, then they'll become believers, and then it's possible. But you see, it's all in the mental preparation. I hope this doesn't sound too weird or way out of conventional medicine. This is working with our patients to offer them choices, because the only important thing is to get the weight down, and the time course doesn't matter. It's just that in our early studies, we found that it was an easy way to get our patients on board, and it becomes self-motivating because they feel so good. So time course is fine.
Like Banshi, a lot of our patients, when they come to us initially, when the so-called shock of having developed diabetes, it hits them hard, and they themselves come and say, don't prescribe any medicine. I will bring my glucose values to normal, and they do that. They lose weight, and occasionally that happens.
That's for newly detected diabetes is
Yes.
okay. But the patients of diabetes of 5 years, 10 years, 7 years, who are on multiple oral anti-diabetic agents, and then to reverse them and to stop at the first time, rather than stopping them step by step. That was why
I think that makes sense, and you have to take a call with your patient.
Yes, that's what we are doing also.
Exactly. And you know how much somebody can achieve, the other person may not be able to do so. And like Dr. Taylor very clearly said, it is not only, it is the circumstances and the attitude to eating which are paramount. So a lot of behavioral modification, apart from the counseling, like you're saying, and a well-trained nurse can do that, or any paramedical staff whom one has.
Sarita, there is a question from Dr. Yajnik in the question box. I think that is important.
Yes, I was going to point that out. Thank you, sir. I
The
can read it
question
out.
is-
Yeah, so you can read it out,
please. I
The
can't see
question
it. I'm
is whether
sorry.
it's simplified. If insulin secretory failure is more important, or hepatic and pancreatic fat-driven insulin resistance and other factors more important for pathogenesis?
Thank you, Anup. In respect of type 2 diabetes, it's absolutely the case that it's the beta cell problem which is more important. Even in states of extreme insulin resistance, such as genetic forms of insulin resistance, the glucose tolerance can be absolutely normal because the reserve capacity of the normal beta cell is huge. Now, I didn't talk about this, but the susceptibility of the beta cell differs very much between individuals, even stretching the personal fat threshold to those people who have beta cells that don't notice fat. They're not susceptible to fat-induced damage. So that's an important point to take account of. If the beta cells fail, then blood glucose rises, and if glucose has risen significantly, the beta cells are in trouble. So there's a very clear pecking order. But as this conference is dealing with cardiometabolic risk, I just point out that the cardiometabolic risk is entirely initiated by the hepatic insulin resistance. And then, of course, it's made worse by the raised glucose as well. Thank you.
There is one more question in the chat box. It doesn't say from who it is. Would a person weighing 60 kilograms who is type 2 diabetic also benefit from 10 to 15% weight loss? It's anonymous. Apologies for that.
In general, the only way to find out is to go for it. But that person weighing 60 kilograms, if they are at 54 kilograms, they may well be back to the weight they were when they were 20. And indeed, my index patient, the very first person who in 2004, I was just beginning to generate these ideas, came to me and said, I want rid of this. She was such a person. And in fact, came down in weight, re-achieved the very low weight she was in her 20s, because that's just normal for her. She wasn't abnormally thin, it was just normal. So the answer is yes, but I have to qualify it. Diagnosis becomes important. We mustn't forget that slow onset type 1 diabetes is always a possibility. We mustn't forget that MODY is always a possibility. So diagnosis does become important because it's now very clear we identify type 2 diabetes as being this very common disease associated with fat. But we must remember the basics of medicine and just ask ourselves, could this really be?
Thank you very much, sir. So I have some questions. So actually, I'm doing a lot of work with dietary interventions. I relocated to India 5 years ago from the US. So now we are actually even doing a ketogenic Indian diet study. My question to you is certainly, along with what Dr. Bansi Sabu asked, can you comment on simply caloric restriction versus a macronutrient manipulation for reversal or remission of type 2 diabetes? And then in your study, the non-responders, you explained that the non-responders did not lose the pancreatic fat when we simply read the paper, but I'm sure there's something beyond that that you may want to share with us. So if you could talk about the non-responders.
First of all, the macronutrient composition, really a very important matter to discuss. It doesn't matter. We have to consider the metabolic physiology. Where is the food that you've eaten? Well, it's stored in various places around your body. But what is it? Well, it's what the liver has directed to be stored there. Any excess carbohydrate has been turned into fat. Any excess protein is turned into carbohydrate and then either burnt or used. Fat is going to be broken down and reassembled. It might be desaturated. The liver actually controls everything. So the food going in here bears little resemblance to what's stored. And if we just consider the difference in diet across the world, you begin to bring into focus this point, because people can have a very high carbohydrate diet, such as rural people in India subsisting on largely carbohydrate, compared with other parts of the world, largely energy from fat, and yet they look the same. So food matters. The one thing the liver cannot do is regulate the amount. Now, in terms of the low carbohydrate approach you mentioned, that's entirely valid for some people. Now, the ketogenic diet attracts a hugely enthusiastic following. The hard evidence, when it's put into a randomized controlled trial, is very poor. And that's surprising. It's a disconnect. But I think it's a disconnect because if an individual doctor portrays it very enthusiastically, they will get good results with it. Absolutely no doubt. A brilliant way to proceed. But if it's given to everybody, it's just the same as anything else. So I would make a sharp distinction. It's not the macronutrient composition. Within quite wide limits, it don't matter. But what does matter is the total amount. And your second point about non-responders, yes, even within the first 6 years of type 2 diabetes, we saw in our detailed studies of the direct cohort that we could see a difference in duration of diabetes between responders and non-responders. So yes, some people do have quite a rapid decline in irreversible beta cell function. Other people can be modified up to a long time. And that is the predominant factor driving it. Beyond that, there's a very clear other matter that if we look at these people who've had the diabetes for 24 years, I know of 2 people who had it 24 years on 2 oral agents, have stopped everything, gone back to normal. Now, they must have beta cells that possess a resilience to prolonged stress of fat. So there are 2 different factors. There's a susceptibility, there's a resilience. Now, both of those are likely to be genetically determined. And if we just reflect for a moment upon the fact that most genetic markers for type 2 diabetes are beta cell markers, then we begin to see how things might come into focus.
Thank you. And again, quoting from what you wrote, that implications for personal health and for national health economics. So what changes has it reflected in the national health in UK?
Thank you. The National Health Service in England has decided to mount a program to try and identify the most cost-effective way of rolling this out across the country. This program has been a while getting underway, and it's been interrupted by the coronavirus. It was due to have started in April. It's now due to start in September. So the National Health Service, which is very conservative in what it will start doing, is going to roll out this program. And in Scotland, where there is a separate National Health Service, they're at a similar stage, and they're about to roll out a program of doing exactly this. So the health economics are very persuasive. Now, the long-term business of keeping the weight down is difficult, and we have to accept that. And even if weight eventually migrates back upwards, even if the diabetes comes back, we might have moved people from the highly dangerous time of having diabetes in their 40s to having diabetes in their late 50s. That's a fantastic advantage. And so they'll be able to complete their working life. They won't have that heart attack that stops them working. This is a benefit, even though we shouldn't be absolute. But I'd also add the point that we're really at the beginning of this story. We know now type 2 diabetes is reversible. We know it's related to fat inside the pancreas and the liver. But there is so much yet to be worked out. The point about the best way to roll this out in an Indian population, yes, absolutely, that's yet to be discovered. All sorts of other aspects are to be discovered. But I think for the first time, we can grasp the simplicity of type 2 diabetes, which helps us take pragmatic and rational decisions for our individual patients.
Thank you. And when we talk about that fat in the pancreas, I think it's a very small amount, even 5% more. It's not like it's going to be 20 or 30. I think it's just very small, isn't it?
It is extremely small. Now, this bears a comment because the pancreas is a fatty organ, but that fat is invaginated between lobules and some extracellular fat. But what we're measuring is the fat actually as a total, excluding the invaginating fat, because we exclude that, excluding clumps of fat. It's the fat distributed within the cells, both the parenchymal cells and the endocrine cells. That is very small. We calculate that it's about half a gram of fat that we shift from the pancreas. But the intracellular environment is very susceptible to excess fat in these individuals. Taking it away seems to tip the balance and make the difference. So yes, you're absolutely right. In the pancreas, we're seeing relatively small changes in total fat. In the liver, we see huge changes. And on a healthy person with cardiometabolic syndrome will have high liver fat. And it's possible to bring that to normal. And if any bottom line is to be derived, that's a huge important bottom line for the health of the population.
Thank you. I just see that we have a very senior cardiologist, Dr. Jeevar Zakaria has joined us. So if you have any questions, and I see Amalia was there, and if she has any comments before we go on to our next session. Actually, we wanted to have a good discussion with Dr. Taylor, and there are still questions coming in. So Dr. Zakaria, if you have any questions for Dr. Taylor, if diet can reduce cardiovascular risk is what he has been discussing. You're muted, sir. If you can unmute yourself, Dr. Zakaria.
No, yes, thank you. My problem, my practice is the difficulty in achieving weight loss in our patients. However much I try as a cardiologist, maybe a diabetologist have greater success, but I think my success is abysmal. So do you have some formula for an Indian patient with overweight? What are the things which we can do to make them lose weight?
I think this comes down to communicating the potential benefits. First of all, that it is possible to move the weight, to lose the weight. Secondly, how this can be done, and perhaps simply describing the results of studies to date. And thirdly, getting them to go away and discuss that information, preferably with a written sheet of information, to discuss that with their family. This will be difficult. This is a potential huge way of achieving health and making me feel better. Those are the important steps, I think. So pointing out the benefits, pointing out how, and then discussing with family and friends.
Okay, one more question. What is your feeling about this so-called keto diet? Because many of our patients, ultimately, they are very happy, especially people who love, all this non-vegetarian food. They actually, they relish this and they have lost considerable weight. Is there any long-term effect? Is it what they are asking us? What is the long-term effect? Is it okay? But I'm losing weight and I enjoy it.
There's no long-term adverse effect. For a long time, people who are locked onto thinking about lipids said, no, you mustn't have a low carbohydrate approach because it means you'll have a high fat approach. And that would mean there's a high saturated fat intake. That would be bad. Now, there is no evidence from that. And I've been through the evidence exhaustively as part of a UK government examination of this, and I have to say that I'm stating my own opinions. I'm not stating the opinions of SACN necessarily, the Scientific Advisory Committee, but we can look at the data, and for what data we have for long-term studies, there is no signal that there is an adverse effect of having a modestly high-fat diet, but one which is isocaloric. And so the concerns that some people have raised about low carbohydrate diets are, I think, ill-placed. They're not based on our current evidence. On the other hand, I would just point out
Great, thank you so much.
The evidence is such that it is difficult for quite a high proportion of people to stick to it in the long term. But, that doesn't matter. I wouldn't suggest you should hold back from suggesting as a possible way forward. It is robust. It can work for some individuals, and there's very good results from case series. If you try and do it to everybody, you would end up with a very similar effect to advising a low-fat approach. That's what the hard evidence shows. But adverse effects, no.
Dr. Taylor, physicians who practice what they preach, what do you think about that? Like, can you set a trend? I personally believe that, but I just wanted to have your opinion.
I think I'm very fortunate in happening to be tall and thin, but I'm the same shape now as I was when I was 21. And that is largely accidental. But as the years have gone by, more and more deliberate. So yes, I mean, it is important that physicians try, but none of us should be swayed by appearances, because this obese person in front of us might actually have been morbidly obese, lost sufficient weight to lose their diabetes. They may be a happy, healthy, obese person. But we have this ridiculous BMI definition. Ridiculous that is for individuals, fine for populations. And remember that BMI, the Quetelet index, was actually derived for use in populations. It was never designed for use in individuals, but it sort of migrated. So yes, we can try and take the lead as far as we can, but I think we can be absolutely confident in saying what we say about this. And that's different because a lot of physicianly advice is perhaps a little bit woolly, and you may, but now we have some certainties, and we ought to lean on those certainties to be able to communicate most effectively.
So it's nice to know that you are maintaining. I'm sure I can't say that for most people, because I know for sure that you have to work hard to stay where you were when you were in your 20s. So
I enjoy riding my bicycle. I have an unfair advantage.
So I'm sorry to interrupt. Since our next speaker is having some trouble connecting, so I'm allowing this discussion to go longer. I have Dr. Bharat Shah and Dr. Amalia Gasadelli from Italy if they want to have some comments. And if not, we'll move on to our next activity. I would like to announce the prizes of the research contest this morning. Amalia, do you have anything to add to Dr. Taylor's talk?
Roy, just a great presentation as usual. And every time I hear it, I learn something new. And I just wanted to share with you some results that we just found. And I think they fit perfectly with your hypothesis. We actually had, we are looking at some patients that underwent bariatric surgery, and they lost about 25% of their body weight. Of course, some of them became non-obese. Some of them, they still had like a BMI of 31, 32, because of course, you know, it's they started from a very high weight, but all of them, I mean, we studied them again after 7 years, and we decided to do a magnetic resonance imaging of the liver. And actually, I was surprised to find that despite this very high weight loss, and I have to tell you that half they had diabetes, and they all stay without diabetes after 7 years. So that was an achievement. They all, you know, reverse hepatic insulin resistance because we measure with the tracers. Some of them, they still have a liver fat. So it's incredible, because I think, you know, and I want your comment on this. I think, as you said, it's probably not the total amount of fat or so on, but it's just their threshold. So they probably move to a new state that is their state, where they still have the possibility to deal with their diabetes, because I mean, they resolve diabetes, so they have a normal glucose tolerance, I mean, normal, at least non-diabetes glucose tolerance, and the meal test was very good. So, but the liver fat was there. So some of them even 20% of fat.
Yep, and I'm very pleased to hear that. That sounds great data, and look forward to the publication. You make a really important point. It's not about the absolute level. Now, we define NAFLD using absolutes because we need a threshold.
Of course,
but
yes.
One slide that often gets pruned out of my talk so that I don't go on too long is my slide showing the lineup of liver fat at baseline. And it goes from down within the normal range up as an absolutely smooth series of individual columns, one for each person. Now, you might say, those people in the normal range, you know, surely it'd be different. Well, no. When they lose weight, the liver fat goes from, say, 3.5% down to 0.5%. And so the people who are up at, what's our highest, 38%, can go down to 8%. And they're fine. It's just that the average for the whole direct population was 3%, for instance, after weight loss. But I'm talking averages here, which is our uncomfortable shorthand. If we turn it back to individuals, which we're considering now, yes, we'll find some people who've gone from very high levels down to a level at which they can cope. And in the beta cells, the same will have happened, and the fat will have gone down enough to relieve them from their metabolic problems. And coming back to the important point of this conference, the cardiology, because that's the cardiac complications carry off our patients prematurely. And so these people at 7 years after bariatric surgery clearly have not died. And that's partly because of the bariatric surgery.
Yeah, and if you can comment on this, I realized that we have like 3 phenotypes: the non-obese below 30, the obese between 30 and 40, and then the morbid obese, or those with morbid obesity, because the morbid obese, they have an extremely high fat, but usually, for example, they have normal carotid and they have a lot of problems, but not all of them, they develop diabetes and so on. So, and then we have lean, that you think that they are safe, but instead, if they have visceral fat and the high waist, as you were pointing out, they could have liver fat, even very severe liver fat, they could have diabetes. So it's like we have now 3 different phenotypes, but as you pointed out, it's probably we have to go to lose the excess fat. We do weight because it's easier to measure, but we actually probably need to lose the excess bad fat. And of course, the visceral. So, and this is independent if you are non-obese, in the middle of obesity, or extremely obese. You need to lose the fat.
Yes.
Thank you. Thank you, Amelia. Thank you, Dr. Taylor. I think I have really enjoyed it. And thank you, Rucha. Thank you so much.
Thank you, everybody. Yes, thank you.
It was a great, great session. Thank you. Thank you so much.
So thank you, Dr. Taylor. We are going to conclude this session. And before we Dr. Maurice was unable to join, but we are going to have a panel discussion on what kind of stent do diabetics need. I'm just going to utilize 2 minutes in between Dr. Dani to announce the results of our research contest and our recipe contest. So if we don't mind, can I have the events person please show us the results? And this morning we had 11 abstracts selected. We had 10 oral presenters. If we can go back to the previous slide. These were the 4 judges. We had 1 judge from every field. We had an endocrinologist, a diabetologist, a very senior nutritionist, and a cardiologist. And the prizes are based on the results that were sent to me anonymously by each judge sitting at their home in this digital era. So please go ahead and show us the next slide. For the first prize, we have Dr. Meeta Shah from Mumbai. She spoke about SGLT2 inhibitors and the efficacy and safety in patients with diabetic kidney disease. Congratulations, Dr. Meeta ma'am. Second prize, is a global cardiometabolic conclave, and thanks for making us global. The prize goes to Dr. Sylvia Sabatini. Amalia, I'm not sure she's on, so you can let your student know that she was selected for the second prize. And for the third prize, she spoke on the effects of pioglitazone and fat distribution and metabolism in patients with NASH. And for the third prize, we had a tie. We have Dr. Vibhakar Vacha-Rajani, who spoke on trends of below knee amputation and risk factors, a 3-year study in patients with type 2 diabetes. And Dr. Sampada Agnihotri from Vadodara, who spoke about cardiometabolic risk factors, which was actually very scary among young, overweight, and obese college-going youth. So we have to be aware that it's starting to affect them early. So I did not see any of the judges for this, so I announced that. For the recipe contest, next slide, please. We have both our judges, Zamrud and Cheryl. They are senior dietitians based in Mumbai. And I will let maybe Cheryl announce the first prize. And Zamrud, we have put together a recipe book. If you say that, we'll just show a brief view of it, which will be uploaded for all the professionals and everybody on our website. We are making a nice PDF book because we have such wonderful entries. So go ahead. Cheryl, you want to talk about the categories maybe for a minute?
Zamrud is going to talk about it.
Okay,
so
Zamrud, yes. Okay, absolutely. Sorry. Over to you, Zamrud. She's the chief dietitian at Global Hospitals Mumbai and a very dear friend.
Thanks, Rucha. Rucha gave me a very difficult task. She gave me such beautiful recipes and then she said, pick 3. If you ask me, they had put lovely categories. They had put for immunity, they had put for dyslipidemia, for diabetes, for low potassium, low sodium. And believe me, the good part that she did is that she didn't disclose that Cheryl was my partner to judge the recipes. So we both judged the recipes independently, but we came to the same results. So that it shows that these recipes were really good. All the recipes were beautifully done. The ingredient choice for the categories that people have used are excellent. So if we are doing with a book for this will be very good. It's a very useful thing for our patients, because most of the time in our clinics when people come, because India is very diverse when it comes to the food culture. So I think these recipes are really going to be very useful for patients and for us in our practice to deliver this to our patients. So I think, Cheryl, you can announce the winners.
Thank you so much,
Thanks.
Zamrud, and heartiest congratulations, Dr. Rucha and Dr. Sameer Dani, for this wonderful conference. I think it's one of a kind, so I'm so happy, and it's really nice that you made us a part of it. And it was wonderful judging, like Zamrud said, and we came to the same conclusion because we more or less liked the same recipes. So congratulations to all the winners. The first winner is Ms. Girija Damble from Mumbai, and her recipe was the jawar protein pockets, which was a good combination of protein, fats, and carbohydrates. So it's a very good recipe. Then the second winner is Miss G. Divya. So if you see, we have one from Mumbai, one from Bangalore, and one from Ahmedabad. So the second recipe was horse gram idli with spinach chutney. So the good part is people really were very innovative, out of the box, a lot of innovation and creativeness that we saw with all the recipes, and with a lot of health benefits. So horse gram idli with spinach chutney was the second recipe by Miss G. Divya, and the third winner is Miss Vidita Shah from Ahmedabad, who used foxtail millet and made a recipe, which is a foxtail millet surti kapuria, which is again a very innovative recipe with a good, with good ingredients. So congratulations to all the winners, and as Dr. Rucha said, this is all going to be compiled and put in a format, and it's going to be available on the website for everyone to refer. So thank you once again. And congratulations to all the winners.
So congratulations to all the winners.
Thank you. So,
Thank you.
So we'll keep moving on because we just have a short panel discussion before we move on to Dr. Per Henrik Group's talk. And I'll just announce that for the heart-to-heart video contest, we selected only one winner, and that is our Dr. Vidisha Patel from Ahmedabad. We'll also load her video later on to be used for patient education and awareness. So for the next part of the session, we are going to have a short panel discussion. Can I have the other slide, please, Hardik? So unfortunately, Dr. Marie-Claude Maurice was unable to join. So we are just going to do a 10 to 15 minute discussion. And for this session, we have three cardiologists. Dr. Jeevar Zakaria, as we already have met him, he's a senior cardiologist. And he has been the chief of cardiology of Amla Institute in Kerala. We have Dr. Prafulla Kerkar, who has been one of my go-to persons during the development of this entire conclave. And again, he has not failed us today. He's a professor and head of department of cardiology at KEM Hospital. This is where I did my medical school in Mumbai. And Dr. Sameer Dani, our very own organizing chairpersons. And I will hand it over to Dr. Sameer Dani to lead the talk further. And then I see Dr. Per Henrik Group has already joined for his talk, which we shall begin in the next 10 to 15 minutes. Thank you, sir.
Thank you, Rucha, and thank you all the panelists to join in. Dr. Marie-Claude Maurice, if she had given her talk, she would have finished 3 minutes earlier. So we can do the discussion now. Hardik, can I share my, can you unshare? And I can share my screen. I can show.
Can do now, sir.
Yeah, thank you. I can show a couple of slides. I may. Okay. So the topic of Dr. Maurice was, do diabetic patients require a specific stent or a different type of stent? The question comes from the fact that the current drug-eluting stent, though they are very good in terms of healing, in terms of inflammatory response, in terms of their clinical performance as far as is concerned, regarding subacute and acute thrombosis or restenosis, still there is a difference and there are limitations. There is, with drug-eluting stent, delayed vessel healing because of the slow endothelialization and increased inflammatory response. And these two things are increased or heightened by presence of diabetes mellitus. And because there is slow endothelialization and there is increased inflammatory response, there is a risk of acute, subacute, or late thrombosis. And many times, angiography misses out on some plaques or some lesions. And when you do not know the true extent of the disease, you see a stent edge restenosis. And this edge restenosis and thrombosis are two major problems with current DES. And these two problems are aggravated by diabetes mellitus, type 2 diabetes. And this particular work, this slide is from two papers. One is from Yang et al., Journal of Invasive Cardiology, published in 2013. And Dr. Renu Virmani published her work much earlier in 2006 in Canadian Journal of Cardiology. And this showed that in diabetic patients, coronary lesions are morphologically more complex. There is increased necrotic core volume, and there is increased inflammatory infiltrate, which can be seen in these two summarizing slides. You can see that the macrophage infiltration, T lymphocyte infiltration, and HLA-DR, if you use all three methods, you see higher amount of infiltration in the blue column, which is type 2 diabetics. Similarly, you see more necrotic volume in type 2 diabetes, as you can see from this slide. And these two slides show us that diabetic patients have more calcium in their coronary lesions compared to non-diabetic. And does it translate clinically, or as far as interventional cardiology is concerned, does it translate into increased amount of stent thrombosis or increased MACE? Yes, and this particular paper examined by Park et al. In JSCC, this was published in 2014, where they used Xience, Promus, and the Endeavor stent. Endeavor is zotarolumis eluting, and Xience and Promus are everolimus eluting stents. And you can see the solid lines, solid blue and solid red. Solid blue is everolimus eluting stents, that is Xience and Promus, and the solid red line is the zotarolumis eluting stent, Endeavor. The dotted red line is zotarolumis eluting stent in diabetic patients, and dotted blue line is everolimus eluting stents in non-diabetic patients. And you can see the difference between the two. If you see the cumulative incidence of events, and that is target lesion failure, in both EES and ZES, when they are used in diabetes, the incidence is somewhere around 4.2 and 4.5%, while when they are used in diabetic, the incidence is almost at 50% or 55%, 2.5 and 2.9%. Similarly, here, if you talk about patient-oriented composite events, again, the difference is clear. And you can see that all the four curves, especially the two curves between diabetics and non-diabetics, are diverging as the days go by. So I think it's clear that drug-eluting stents perform very well in really complex lesions today. Angioplasty has really come long way since Andreas Grunzig performed it so many years back in 1978. But we still need something more for our diabetic patients as far as interventions are concerned. So here I think I will stop sharing my screen and we'll go directly to Dr. Praful, Dr. Giver Zakaria, who are there, and Dr. Kamal Sharma has joined in. Great to see you all, and we can discuss about the need for different interventions or different approaches to interventions or different devices in diabetics.
Well, Samir, you filled in very well for another person from Paris. Remember, you also trained in Paris, and I keep asking people, for many of our cardiology audience would obviously know who Dr. Marie-Claude Morris is. For the endocrinologist, let me tell you that Marie-Claude Morris is like the pioneer of even the dual antiplatelet therapy. Good old days, ticlopidin is something that she brought into cardiology field, and we were able to implant stents that much easily. As also, she is the one who did the first ever drug-eluting trial, Cypher stent with sirolimus eluting stent. So Cypher in Hindi, we call it as Cipher. Cipher is zero. So zero restenosis, that's what we thought then, that a drug-eluting stent was a magic bullet, or like the silver bullet, which we are actually looking for in today's corona days, COVID days. We are looking for a magic bullet for corona treatment. But that's how we thought it was going to be. But as very nicely Dr. Samir Dani has pointed out, that you cannot win the battle against diabetes so easily. So in that search, how difficult it is to intervene on diabetics is pointed out very, very well. So there are, of course, I do not know much about the particular stent that Dr. Marie-Claude Morris was going to speak on. But rather than that, we must not forget that it is not just the stent. Even within the stent, we have ultra-thin struts. We have a particular kind of a drug or a particular kind of a polymer that would do good, or just to do away with the polymer, we have biodegradable polymers also. So what really causes restenosis is still, there is a lot of research in that area as far as the stent is concerned. But one can't forget a good deployment techniques with stents when it comes to stents in diabetics. And what do you say? I would invite Dr. Kamal Sharma, who's over there also. Now we saw in Dr. Samir's first slide that calcification is one of the hallmarks of diabetic patients. And in calcified arteries, we know we can't deploy them well. Could you talk something on the newer techniques that we have? Lithotripsy, for instance, intravascular lithotripsy. Do you think that helps us to deploy any particular stent better?
Yeah, Dr. Zakaria wants to speak something.
Oh, I'm sorry, Dr. Zakaria, go ahead.
No. I'm not an interventional cardiologist. I came here to learn a lot of that PCA in diabetes. Now, I just want to start the discussion rolling. Is there still a role for bare metal stent in angioplasty for diabetes? Is there still a role? That is the first question. Can you answer
Kamal
that?
wants to answer that. Dr. Kamal Sharma.
Yeah, I think two things. Good question, Dr. Gaver. I think a couple of places where people tend to use still a bare metal stent is where we used to use was when patient was to undergo immediately or some in recent events surgery, where you would wish that you can get away with an antiplatelet. But now we have third and fourth generation of drug-eluting stents where basically they are practically devoid of polymer at all. So I think we've known this from Dr. Renu and Mari's multiple studies that the problem is not the drug. Problem is the polymer that you employ. And the polymer is basically, if it does not degrade, it's like leaving crudely to put plastics behind into the coronaries, which are always going to be thrombogenic. And that's the primary reason why Cypher did not end up being Cipher, as Dr. Kelkar was pointing out, because it was a wonderful stent to have, wonderful drug platform, a good amount of strut thickening, strut they were working upon in the next generation. But what was the worst part of Cypher was that they left a lot of polymers and there was no endothelization. Coming back to Dr. Dani's presentation, fantastic slides. I think if you can just, Dr. Dani, show back those slides, I just to trigger a debate. You can see that the initial phase, and this is what Medtronic started actually marketing, the event rates were lower in Zotariolimus compared to Everolimus in the initial phase. And when you look at the late catch-up, actually the Everolimus started doing better than Zotariolimus. If you can, Dr. Dani, point out the patient-oriented composite endpoints between the two dark lines here. Yeah. So the dark lines, you can see the blue actually was doing much, much better compared to the red for quite some time, almost 300 days plus. So when the initial data came for 1 year, Medtronic was touting this data very strongly and aggressively that we are the first one to get a diabetic drug-eluting stent approval. And then the tables turned, the late catch-up happened and you can see the red worm actually crossing over the blue worm. And now then the science people started coming back. We don't have a late catch-up phenomena, which is worse in the case. I think the numbers are pretty small, but if you can have all of you, Dr. Kelkar, Dr. Dani, could tell us what's probably happening differently here. Is it just the patient profile which is different? Or I think it's the drug elution pattern, because we all know that the first generation of Medtronic, the second generation of Medtronic would have a drug elution pattern which was so grossly and vastly different from what you had for the Science platform. Dr. Kelkar, Dr. Dani?
No, but before that, Kamal, I mean, do you think that the difference between these two groups, are they statistically significant?
No, they are not.
End.
Not really.
They are not. They are not. So
They are not.
practically, on a statistical sense, both arms look the same. So when it's a small number, you would always expect some difference over a time period.
Yeah. So in one of the studies, when you look at the composite of endpoints, especially when you focus only on the late losses in terms of number, you'll reach a statistical significance. If you look at the TLR rates or the revascularization rate, you'll not reach a statistical significance. Now, to reach that statistical significance, the number of stents to be deployed would be so huge that practically no company will be interested in to, end up that kind of a trial. But when you compare with the QCA-based late losses, this again withstood the test of the time. So you had lesser late loss with the Zotarolimus-based platforms initially because the drug eluted was very quick and it finished off almost nothing was left beyond 45 days. Correct me if I'm wrong for that number of days. And that was not the case with the Science platform, when you would have a drug elution which continued for almost 90 days with almost though 90% drug eluted, but some amount of continued to be eluted for beyond up to 3 months. And that's why they claim that the later late loss was lesser in their platform, which was not the case. I'm not sure whether this actually reached up statistical significance in the same group of patients when continued over a long time. The difference was between two different subgroups, and of course, both the companies trying to, play around with that number for their own benefits.
To cut the long story short,
exactly.
yes, we are still in search of the ever elusive magic bullet as far as the stents are concerned. It would have been nice to hear from Marie-Claude Morris as to what is new there technology-wise, how they are going to alter the strut thickness or do away with the polymer or get a better drug than what is currently existing. But as of now, let's agree to one fact that by and large, the restenosis rates have come down pretty low. As far as the diabetes, we should not forget the deployment techniques. Now, when you get a magic bullet, like when we got antiplatelet therapy in itself, a second antiplatelet agent we got, and clopidogrel came, people thought that they could put in stents anywhere and everywhere. And there was suddenly a spate of stent thrombosis. So also I fear that if you bring out a stent specifically for diabetics, people might forget the basics of stenting procedure. In that sense, now calcification is so high. Now shockwave therapy is something, meaning it might interest the audience also. Now that lithotripsy that we talk about, and I think Dr. Dani has got a fair experience with the shockwave balloons that they're using and the lithotripsy that you give intracoronary. How much does that help you to deploy in a diabetic patient the stent better? Dr. Dani.
Okay, I'm sorry, but now I think we will have to close this discussion. I will just summarize it in a couple of caveats or a couple of predictions. That it's not going to be only the drug or the type of the stent or the geometry of the stent or the structure of the stent. It is going to be a whole lot more than that. It is going to be the use of other devices to decrease calcification, to achieve better expansion of the stent, to reduce inflammation in these lesions, plus overall medical treatment of the diabetic patients, which is going to lead us to the better results. It's not going to be just a stent. So having said that, the technology has always helped us so much, and many times we forget that it is not only technology. There are lots of other things which help us in giving better care to the patient. But we must move on. I thank Dr. Giva Zakaria, Dr. Kamal Sharma, and Dr. Praful, especially, for being there, for conducting this discussion. We must give way to the next speaker in the next session. Can we have the chairpersons for the next session, please? And
thank you, Doctor.
Please hold on to your seats so that after this session, we can all have more discussions. Thank you.
Thank you, Dr.
you can take
Samidani,
over.
sir. Good afternoon, everyone. I am Dr. Vidisha Patel, and we'll move on to the next sessions on chronic kidney diseases. I would like to invite our first chairperson, Dr. Bharat Shah. He is the Director of the Renal Sciences in the Institute of Global Hospitals, Director of Anil Clinic, Senior Nephrologist in Mumbai. I would also like to invite Dr. Dharmendra Panchal. He is the Consultant Diabetologist in Diacare, Ahmedabad. Thank you.
So would you like?
Welcome, Bharat sir. Yes, sir. Please go ahead and introduce our next speaker.
Yes, sir.
It's great to have you. He's been our professor, and we are very happy to have you here, sir.
Okay.
Thank you.
So I'm going to share the slide which was sent to me to introduce Professor Hendrik, but I'm not able to share.
So we will be able to share. We are sharing his slide already for you.
Fine, perfect. So it's a pleasure, Rucha and Samir, to make me a part of this wonderful conclave. And it's our great pleasure to have Professor Hendrik join us for this conclave. And he's going to talk to us about whether it is possible to halt the progression of chronic kidney disease. And because this is a diabetes conclave, I would presume that he's going to talk more on diabetic chronic kidney disease and not just on chronic kidney disease in general. Briefly, I don't want to take a lot of time introducing him with the slide. I would like more time to listen to him. He's Professor of Internal Medicine and Chair of Internal Medicine at University of Helsinki. He is also the Adjunct Professor at Department of Diabetes in Monash University, Melbourne, Australia. He has several prizes to his credit, and he has a large number of publications in peer-reviewed journals. So before taking a lot of time, I would like to hand over to Professor Hendrik and see whether halting chronic kidney disease, particularly diabetic chronic kidney disease, is a myth or a reality. So over to you, Professor Hendrik.
Thank you very much, Dr. Shah. I will share my slides with you. I will see. Okay. I just need to open up my slides, and then I will share them with you. Let me just 2 seconds. I will see. Here we go.
Yeah.
And you should be able to see my slides now. Is that right? Can you see them? Yeah, Dr. Shah, thank you very much for that introduction. And Dr. Mehta and Dr. Dani, thank you for the invitation. It's a great pleasure to speak to the audience here. Now it's on my vacation, so this is for me a very special situation because I usually don't do this during vacation. But I'm sitting now on the west coast of Finland. You can see that. If you look out, there is sea outside, so you can think about that. I'm sitting next to the sea and enjoying my vacation. But it's also important to keep in mind that diabetic kidney disease and also non-diabetic kidney disease are extremely important. And the question is, why is it so important and what can we do? And because, as Dr. Shah was saying, I will talk about diabetic kidney disease because the data that are available are very much done in diabetic kidney disease. And I will also show you data on SGLT2 inhibitors, and that's the reason why I show these disclosures, because it's fair to show the disclosure. So what I will do, first, a few words on the prevalence and the consequences of diabetic kidney disease. After that, a few words on what we have learned from the cardiovascular trials with SGLT2s, and then dedicated randomized controlled trials in DKD and CKD, which is extremely important because we need studies in dedicated trials. And also then the question, why do the SGLT2 inhibitors work so well? And I will first give you the common explanation, but after that I will give you an alternative explanation how they work so well, and then I will answer the question, is it myth or reality? So first of all, prevalence and consequence of diabetic kidney disease. This slide shows quite clearly, if you go out and screen for diabetic kidney disease, it's a common complication. So this is at random screening for eGFR below 60 or albuminuria. And you can see that on a global scale, every second person with type 2 diabetes will have signs of diabetic kidney disease. However, if you look at Asia, it's 68%, so even more common. So diabetic kidney disease is extremely common around the world, and especially so in Asia. What are the consequences when you find diabetic kidney disease? This slide shows that there is a manifold increased risk of premature mortality if you have signs of diabetic kidney disease. And you can see the 10-year mortality is about 11 times higher in type 2 diabetes if you have signs of diabetic kidney disease. But it's also an increased risk of cardiovascular events. You can see that the less the kidneys function, the more albumin that leaks into the urine, the more likely the patients are to face a cardiovascular event. And also what is very, very important nowadays, and we have seen a lot of studies on the risk of hospitalization for heart failure. Look at on the left-hand side here. If you have a reduced eGFR, you have a manifold increased risk of ending up in hospital because of heart failure. The same is true for the more albumin that leaks into the urine, the more likely you are to end up in hospital because of heart failure. So diabetic kidney disease comes with grim consequences: increased risk of dying early, cardiovascular events, heart failure, and also ending up on dialysis. This is one of the most important slides in my talk. A 60-year-old patient with type 2 diabetes and diabetes, what we can expect from a patient with type 2 diabetes is a 6-year shorter life expectancy. If that patient has had a cardiovascular event, you can expect a 12-year shorter life expectancy. But if the patient has no signs of cardiovascular disease, but you find the first signs of diabetic kidney disease, you can expect a 16-year shorter life expectancy. So this is extremely important data and tells us that diabetic kidney disease comes with grim consequences. And taking into account that more than every second of your patient will have diabetic kidney disease, we have to do something. Now, so what have we learned from the cardiovascular outcome trials, which were not dedicated renal trials? But what did we learn? So the first out was the EMPA-REG outcome trial. By the way, if you wonder why the REG stands for, it's not regulatory or regulation, it's removal of excess glucose. That's the EMPA-REG outcome trial. But in the EMPA-REG outcome trial, that was the composite endpoint, doubling of serum creatinine, initiation of replacement therapy, which basically means dialysis, or death due to renal disease. There was a 46% reduction in the composite endpoint. By the way, doubling of serum creatinine means a 57% reduction in eGFR. So this is a very hard endpoint. And death due to renal disease is defined as patients should be on dialysis, but they refuse. So 46% reduction. And you can see this data were accompanied by an initial reduction in the eGFR, but after that, what was seen was a preservation of the kidney function. Absolutely astonishing data. There was another trial, the CANVAS program, also showing similar data. They did not use the doubling or serum creatinine, they used 40% reduction in eGFR, otherwise the same composite endpoint components. But again, you can see a 40% reduction in the risk of a composite endpoint. So again, wonderful data and similar data in terms of the initial drop in eGFR, and after which they saw there was a preservation of the kidney function. And there was a third, the DECLARE, also showing very similar data. So a 24% reduction in a composite endpoint and combined with cardiovascular death here. Now, if you then put all together, so on the top we have here, in the patients with atherosclerotic cardiovascular disease, it means established cardiovascular disease. So the EMPA-REG, CANVAS, and DECLARE. And here, the patients with multiple risk factors. EMPA-REG outcome trial did only include patients with established cardiovascular disease. So the multiple risk factor data comes from the CANVAS program and the DECLARE team. What is astonishing here is that not only for the established cardiovascular disease, but also for those with multiple risk factors. You can see left on the unity line, so you have an effect on the composite renal endpoint with all these SGLT2 inhibitors, and not only in established cardiovascular disease, but also in those with multiple risk factors. And this is different from when we look at the cardiovascular events. Now, what about these data are secondary endpoints, so we need dedicated trials to actually prove that these data are true. So one study has already been reported. There are 2 more ongoing, and I will show you a few details on the ongoing ones too. The Credence trial was in fact designed even before any of the big cardiovascular outcome trials. So the people behind the Credence, they are very very happy about that. They designed the study even earlier. But what the Credence trial in patients with type 2 diabetes and established kidney disease, what it showed was the primary endpoint was what actually composite of a renal and a cardiovascular death endpoint. And you can see there was a 30% reduction in the risk of this primary endpoint. But if you then get rid of the cardiovascular death, you just look at the renal endpoint, it was even larger. So you can see here a 34% reduction. So this study actually showed that, yes, the data from the cardiovascular outcome trials are true. And what was shown in the Credence was very interesting, because if you take into account that the average Credence patient had an age of 63 years and an eGFR at baseline of 56, so below the CKD cutoff of 60. What you can see here in the placebo group, if you then consider that an eGFR below 10, then you need dialysis, you can see that was the reduction in the eGFR is about 4.6 ml per minute per year. And then you will reach an eGFR of 10 after 10 years. But if you then look at in those exposed to canagliflozin, it was 1.85 ml per minute, and it takes 25 years. So that difference that you see between the placebo and the canagliflozin group is about 15 years. And keep in mind that I told you that anytime you find a patient with type 2 diabetes and diabetic signs of diabetic kidney disease, you actually can expect a 60 years shorter life expectancy. Now, these data are extrapolated. These are this is just what we can probably achieve by exposing our patients to canagliflozin if they have established kidney disease. However, these are extremely good news if they are true, and I do think that they are true. But of course, as I said, these are extrapolated data. Now, the Credence was a study in patients with type 2 diabetes with diabetic kidney disease. And you can see that the eGFR between 30 and 90. And it's important to keep in mind that all patients in the Credence had to have albuminuria, which is a little bit of a problem, because 20% of patients with type 2 diabetes and kidney disease do not develop albuminuria in the first place, but they still have diabetic kidney disease. This will be addressed in the EMPA-KIDNEY, because you can see here in EMPA-KIDNEY, you include patients with eGFR 20 to 45. They don't have to have albuminuria, but if they have an eGFR 45 to 90, they have to be albuminuric. So this will be addressed in the EMPA-KIDNEY trial that also includes non-diabetic kidney disease and also patients with type 1 diabetes. Then we have the DAPA-CKD, tests the eGFR between 25 and 75. So in the Credence, it was above 30, in the DAPA-CKD above 25, and in the EMPA-KIDNEY above 20. But the DAPA-CKD is also including patients only with albuminuria. So it means that they do not test the 20% with diabetic kidney disease that do not develop albuminuria, which is usually due to aging, hypertension, and obesity. So given the data from the cardiovascular trials that pointed in the direction that SGLT2 inhibitors will be effective in terms of preventing the progression of kidney disease. Also then replicated in a dedicated renal trial in the credence. Why do SGLT2 inhibitors then work so well? So first, the common explanation that you have heard so many times. But after that, I will give you my understanding of this. But first, these are data in patients with type 1 diabetes. And the reason why this study by David Cherney in Toronto is performed in patients with type 1 diabetes is that it's easier to test if they are hyperfiltering or not. So if you have a patient with type 1 diabetes and you give 25 milligram of empagliflozin, you will reduce the filtration rate to the same extent that you will do with an ACE inhibitor. If the patient is normal filtering, nothing will happen. And this is true for euglycemic situation and hyperglycemic situation. So with an SGLT2 inhibitor, you reduce the hyperfiltration. Anytime you have hyperfiltration, as shown here, you will have glomerular hypertension and an increased intraglomerular pressure. And by the way, all the means that we have been used in the past to prevent the progression of kidney disease actually to reduce the intraglomerular pressure. So if you have a normal filtering patient, you can see nothing happens if you give empagliflozin. But if you have a hyperfiltering patient, as I already showed, you will reduce the hyperfiltration, but you will also decrease the intraglomerular pressure. Now, this is accompanied by a reduction in renal blood flow and an increase in the renal vascular resistance. And anytime you see a reduction in renal blood flow and an increase in the renal vascular resistance, this means that you have an increased tone of the afferent arteriole. Definitely true, and also one of the mechanisms how these SGLT2 inhibitors work and ease the burden on the kidneys. And if you look at this slide, in the left-hand side, we can see that this is the normal situation. We have these SGLT2 co-transporters in the proximal tubule in order to harvest glucose, which is an important substrate. And during the evolution, we didn't want to get rid of that glucose. At the same time, you also reabsorb sodium, but you have a sodium balance that is really balanced. So sodium is also reaching the macula densa here too. Macula densa works as a control tower of an airport. This is a control tower of the glomerulus, just like an airport. So in the macula densa, we have another co-transporter consisting of sodium, potassium, and chloride. By the way, the same transporter that also senses the furosemide. So if sodium reaches the macula densa and this transporter, small amounts of sodium are absorbed and you need energy, so you go from ATP to ADP and you generate adenosine. And adenosine is a strong vasoconstrictor of the afferent arteriole. By the way, adenosine is also a potent vasodilator in the medulla. And this is also important when you think about how the SGLT2 inhibitors work. So this is normal physiology. But in a situation where you have hyperfiltration, increased renal blood flow, and hyperfiltration, what will happen is that you push the sodium handling in the proximal tubule. And I will show you a slide later on what are the consequences when you have an increased renal blood flow, hyperfiltration, and you push the sodium handling, which means you reabsorb more sodium and glucose in the proximal tubule. Here you can see this exaggerated reabsorption of sodium makes no sodium reaching the macula densa, and you do not generate adenosine. And instead of having the increased tone in the afferent arteriole, you have actually dilated afferent arteriole. So if you then give an SGLT2 inhibitor, you block that exaggerated reabsorption, you generate adenosine by sodium reaching the macula densa and sensed by this co-transporter. So this is the common explanation how the SGLT2 inhibitors work. But let me point out a very important aspect, and that I said the increased renal blood flow, the hyperfiltration, that is associated with an increased sodium handling in the proximal tubule. And now 90% of the oxygen consumption in the kidneys are due to the sodium handling in the proximal tubule. So let me now give you an alternative explanation for how the SGLT2 inhibitors work, and also may also be the basis for why these medications will also work in non-diabetic kidney disease. So these are now data from experimental animals. So you have pronounced and persistent intrarenal hypoxia as early as 3 days after induction of diabetes in mice. So when you induce diabetes in these mice, you can see the oxygen tension goes down because you increase the oxygen consumption just by inducing diabetes. Now, let's then switch gears. If you induce hypoxia without diabetes, without reactive oxidative species, by giving a drug called dinitrophenol, which is a mitochondrial uncoupler. So you get rid of the mitochondria, and you don't have diabetes, you don't have reactive oxidative species around. What is the effect of dinitrophenol? Yes, you induce hypoxia because you see you increase the oxygen consumption compared to the control. What about then the cortex and the medulla? Yes, that is true, not only for the cortex, but also for the medulla. So by giving a drug, which is a mitochondrial uncoupler, you cause kidney hypoxia, just as you do when you induce diabetes. Now the question is, what are the consequences of kidney hypoxia? This slide shows that when you induce kidney hypoxia, and now this is a situation where we don't have diabetes, you just give a drug, dinitrophenol. You can see that, yes, you have proteinuria. Here you can see that you have inflammation, and here you can see that you have cell damage. So you have cell damage, inflammation, proteinuria. These are features that we see in diabetic kidney disease and also in non-diabetic kidney disease. Also very important here. So when we induce diabetes, here you can see that the glomerular filtration rate increases. And when you do something hereby, you activate the HIFs, so the hypoxia-inducible factors. You actually reduce that hyperfiltration. By the way, hypoxia-inducible factor was the Nobel Prize last year. It was given to Sir Peter Ratcliffe from Cambridge, William Kaelin and Greg Samensa for the discovery of this hypoxia-inducible factor system. And you can see here by stimulating the HIF, you can actually revert the glomerular filtration rate. And also you can see when you induce diabetes, you increase the protein excretion, but when you activate HIF, you can actually reduce that. And now you can see here, when you induce diabetes, you increase the oxygen consumption. When you stimulate HIF, you actually reduce the oxygen consumption. Now, I told you that 90% is due to the sodium handling in the proximal tubule, shown here. So this is the T sodium, this is the oxygen consumption. So you can see when you induce diabetes, you actually increase the sodium handling and also the oxygen consumption. And then if you activate the HIF, you actually revert that. So this is very interesting aspect. You have an increased renal blood flow, you have hyperfiltration, you push the sodium handling in the proximal tubule, and you cause kidney hypoxia. Now, if you then reduce the hyperfiltration, you reduce the renal blood flow, and you reduce the sodium handling, you actually ease the burden of hypoxia in the kidneys. So my take of how the SGLT2 inhibitors work is shown here. So diabetes is associated with increased renal blood flow and hyperfiltration. By the way, you could also write obesity here, or you could write hypertension, because they also go with an increased renal blood flow and hyperfiltration. And when you have hyperfiltration, you push the sodium handling on the proximal tubule. 90% of the oxygen consumption is due to the sodium handling in the proximal tubule. So you increase the consumption of oxygen, and you actually you make the kidneys hypoxic, and that leads to, that I showed you, signs of kidney disease. Now, if you then block the system SGLT2 inhibitor, you actually ease the burden from induced by the kidney hypoxia. So I promised to say at the end, is it myth or a reality? that we can halt the progression of kidney disease? And I think it is a reality. And the reason why I'm saying that is SGLT2 inhibitors have shown to confer renal protection by retarding the progression. If we use the word halt, that might be an over exaggeration of using the word, but still we can say we have renal protection, and it might be if we start earlier and we are able to prevent the hyperfiltration that we can also halt the disease process itself. But SGLT2 inhibitors definitely confer renal protection, and probably by easing the burden of kidney hypoxia induced by increased sodium handling in the proximal tubule. This is the alternative explanation, as I also gave you the common explanation, but I think if we combine these two, we might understand why they work so well. And this is due to the increase in blood flow, hyperfiltration, and as said here, a feature associated not only with diabetes, but also with hypertension and obesity. And that also tells us that they might work also in non-diabetic kidney disease. But of course, we have to say whether they confer renal protection in non-diabetic kidney disease has to be studied. And it is ongoing studies in the DAPA-CKD and the EMPA kidney. So in a few years, we are going to have also the results of these data. That said, ladies and gentlemen, dear colleagues, thank you for your attention. And this picture that you see in the slides is actually left on my where I'm sitting now in my room. So if I go out with a boat about 5 minutes, this is the view, and Sweden is on the other side. So thank you very much.
So can I come back, Rucha?
Yes, sir. Please, you'll leave the. If you have any questions, or I think Dr. Bansi Sabu had raised his hand in the chat box.
Okay.
You can start with a question from your end, Dr. Shah, please.
So, Professor Henrik, that was a very beautiful and lucid presentation about how the SGLT2 inhibitors have added significantly to treatment of diabetic kidney disease.
Thank you.
But as you said, it is unlikely that they would halt the progression. It is more likely that they would retard the progression of kidney disease.
Yeah.
Now I have a question for you. That do you think that addition of ACE inhibitors and angiotensin receptor blockers would act synergistically with SGLT2 inhibitors, and whether implementation of a low protein diet would also act synergistically with treatment with SGLT2 inhibitors?
Yeah, now, Dr. Shah, that is a good question. First of all, as I said, all the means that we use to retard the progression of kidney disease is actually decreasing the intraglomerular pressure. That is achieved by ACE inhibitors, angiotensin receptor blockers. It's also to some extent achieved by low dose protein. So if you reduce the protein intake, and if you switch from animal protein to a vegetable protein, you can also achieve that effect. Now, the cardiovascular outcome trials that have been performed so far are on top of ACE inhibition. So that is, of course, the question is, can you achieve that effect without an ACE inhibitor? And those studies are now ongoing. So we don't know yet exactly, but I do think that it's more important, basically it's more important to reduce the renal blood flow and the hyperfiltration, let's say on the afferent side, because that will lead immediately to a reduction in the sodium handling in the proximal tubule and less oxygen consumption. So it might, I haven't seen the data yet, convincing data, but I think that you might achieve that by actually increasing the tone of the afferent arteriole. By the way, you probably wonder why GLP-1 agonists, who work on the most oxygen-consuming transporter in the proximal tubule, which is the sodium hydrogen, GLP-1 agonists work on that. They call natriuresis a sodium-rich histomacular densa. Why don't they have this renal protective effect? Yes, because they also have an effect on the on the endothelium. Instead of increasing the tone, they actually dilate the afferent arteriole. That is the reason why you only see a reduction in albuminuria, but you don't see the renal protection. So back to your question, yes, I think we might be able to achieve the same effect with only SGLT2 inhibitors. But of course, the standard of care is the 5-finger rule, which includes the use of ACE inhibitors and angiotensin receptor blockers, alongside optimal glycemic control, optimal blood pressure control, lipid lowering, and no smoking.
Sure. Now, one more question before I hand over to Dr. Bansi is you said that SGLT2 inhibitors have been or possibly may be useful in non-diabetic CKD. But to my knowledge, they have not yet been shown to be useful in retarding progression of non-diabetic CKD. Are there some long-term studies about that?
No, absolutely. You're absolutely right. No, if I said that, then I apologize. There are no studies done so far that have proved that SGLT2 inhibitors are able to retard or halt the progression of kidney disease in non-diabetic kidney disease. The only study we have so far is the Credence trial. Now, in terms of heart failure, we have the DAPA-HF study showing that you can actually prevent or you can actually reduce the risk of ending up in hospital because of heart failure, also in non-diabetic heart failure. And you saw the slide where I showed that the effects on the kidneys seems to be even larger than the effects on the heart. And you know that the kidneys and the heart, they go together because 25% of the cardiac output reaches the kidneys. So the kidneys, in fact, have to protect themselves against too much oxygen because oxygen is toxic. And that is the reason why we have a very interesting shunt. So you need the oxygen tension in the kidney is actually lower than in the renal vein. And it's very interesting that the kidneys try to protect them against too much oxygen at the expense of hypoxia when the blood pressure increases, when you have obesity, when you have diabetes, because then you have hyperfiltration, increased renal blood flow. So let's watch out for the EMPA kidney and the DAPA-CKD. They will answer your question, Dr. Shah.
I think you gave a very lucid and a very well illustrated presentation. Thank you once again.
Thank you. Thank you.
Thank you, Dr. Parhanrik, for coming back again to India on a virtual. We are keep on, calling you again and again to India. Fantastic presentation. Do we have any data that more synergistic benefit AC inhibitor or ARB with SGLT2? Is there any data or any difference between if the patients who are along with AC inhibitor with SGLT2 found to be better in compared to ARB with SGLT2?
So I know that David Chern in Toronto he's doing these studies. We don't have any large data sets showing that you have a different effect if you use only an SGLT2 or you use a combination. But what I said, given how they work and the physiology in the kidneys, I suspect that actually you will see the same effect just by having an SGLT2 inhibitor. But we don't have that data yet, but it will be interesting to see. But so far, the standard of care of diabetic kidney disease is the 5-finger rule, and that includes an ACE inhibitor. So it should be, in the standard care today, it should be on top of the standard care, which means a combination of SGLT2 and ACE. Sorry?
One more thing, Henrik, that in India, we can use SGLT2 till EGFR goes up to 30.
Yeah.
Once it is below 30, we cannot initiate it.
Yeah.
And what is your recommendation or in your country, till what EGFR? Off level we do use till it goes up to 20. So do you use till end stage renal disease or can it be used up to the patients who are on dialysis?
Yeah, this is a this is a very tricky question, Bansi. You know that, and I can congratulate India that you allow it to be used down to 30, because all the cardiovascular trials have used it down to 30. But you know that in many countries in the world, you still cannot initiate if the EGFR is below 60, which is of course a misinterpretation of data. And the reason why you have in some countries that you cannot induce it below 60 is that when the SGLT2 inhibitors came on the market, they were glucose lowering medications, and you could not, of course, market a drug that loses the glucose lowering effect when you lose kidney function. But now we know that actually the other effects are much stronger. Now, so 30, we do have a lot of data, and you show that you saw that I showed that the DAPA-CKD data, they go down to 25, and the EMPA kidney go down to 20. So we are going to get a lot more information about this in the future. I was responsible for sotagliflozin study where we went down to 15 without any side effects either. So I think that you know, you can use lower, but this is now off-label use, and we have to be very careful with that. And I would, let's say, in clinical practice in India at the moment, if you are allowed to 30, stick to that, and then because I think it's we need more data to actually go out and give recommendations, you know, at very low level, because you know the people are extremely concerned about, you know, the use of ACE inhibitors at the lower range. So I think we need, if then there's a risk that people then combine, I think we need to be careful. So, but it seems that in the future, I'm pretty sure we will go down to 20. That's a bunch of what I suspect. But now stick to the 30 at the moment, because that's already good news compared to many other countries.
Thank you. Dr. Yagnik wants to summarize.
Yeah. Okay.
Of SGLT2 below 60.
Yeah. What is the factor which drives hyperfiltration in diabetes?
The factor that driving hyperfiltration. First of all, you have an increased. It's an increased renal blood flow. So it's the increased renal blood flow that drives the hyperfiltration. And this is exactly the same in obesity. So if you have an obese patient without diabetes, you still have hyperfiltration, and that's driven very much by the increase in the renal blood flow. And this is the reason why I say that I suspect that these medications will also be effective in non-diabetic kidney disease, because you have the same factors behind the hyperfiltration and how you push the sodium handling in the proximal tubule that causes then hypoxia in the kidneys, with the consequences I showed you.
So in very early stages of type 1 diabetes, when kidneys are large and hyperfiltrating, has it been used there?
I'm not aware of any other trial studies in type 1 diabetes where they have studied hyperfiltering patients from the one that I showed David Cherney. And but you know, the very early stage type 1 diabetes is a little bit different situation, because it's an adaptation to the hyperglycemia that is also a driver of the hyperfiltration. And in a normal situation, you seem to be able to adapt to that, and you don't have further hyperfiltration in the future.
Okay,
Dr. N.K. Singh. Dr. N.K. Singh.
Yeah, sir. My question is, in the CREDENCE trial, after 2 and 5 years, I think 2.5 years later, the rate of decline in eGFR was something in the tune of 60%. That was, if you compare with the placebo, it was the decline something 4.59 ml per minute. Yeah. So even in the Bharti-CV trial, they have shown that there is early decline in the, that prevents the early decline of the eGFR. In that way, can we say that this group of drugs can prolong the life of the patient of diabetic, because sometimes the people say that it prolongs the life something in the tune of 15 years. So what is your opinion?
No, as I showed you the data, and as I said, if you screen for diabetic kidney disease, The consequences are grim. And the first signs you have in a patient, you will see that it's associated with a 16 years shorter life expectancy. And if we, with the credence trial data, if they are correctly extrapolated and if that is true, we might be able to actually postpone the progression, let's say retard the progression and postpone the start of dialysis by up to 15 years. So I hope they are true, but of course I would like to see also data from the EMPA kidney and also from DAPA-CKD. But I think based on what I showed you from the physiology, I think that will be a result. A little bit disturbing is you probably have heard the Vertis CV data, and the Vertis CV data they do not seem to be able to replicate the cardiovascular, the renal data in the same extent. So it might be due to a different molecule. I don't know, but I haven't seen. I've been digging deeper to the data, but I do think that the data we have so far are convincing, and we are able to retard the progression of kidney disease, and potentially in the future also non-diabetic kidney disease.
Thank you. I got one question from audience. It is apart from glomerular, are there any non-glomerular mechanisms which contribute to the diabetic kidney disease? And what's your opinion regarding using urinary tubular markers for the monitoring progression of diabetic kidney disease?
Yeah, that is absolutely. There's a lot of focus on the glomerulus. My focus is very much on the tubules, and as you see that the sodium handling and so on. If you have an exaggerated reabsorption of glucose, think about it. You reabsorb more glucose, and what are the consequences of a lot of glucose in your cells? Yeah, it drives fibrosis. So definitely there are a lot of other effects, so non-glomerular effects too. The use of tubular markers, we have published a lot of studies on the use of tubular markers. For clinical practice, the answer is no, there's no use. For research, yes, it's interesting, but they seem to be helpful at very, very late stage. So there is one, by the way, LFAB, which is interesting because it's a protection against the consequence of hypoxia, and that is increased, and you can use that. So LFAB, we published that paper. I think it was in Diabetes Care. So, but in clinical practice, no.
Thank you. I think Dr. Shalini has a question. Yeah, ma'am.
Hello, Dr. Henry Group. That was an excellent lecture.
Thank you.
I have a question. We understand the mechanisms behind the renal protection that we observe with SGLT2 inhibitors. When it comes to GLP-1 receptor agonists, there also we do see renal benefits coming in. So what is the mechanism working there? I mean, is it only the glycemic mechanisms that are helping in the renal endpoint improvements, or are there some direct mechanisms also involved with those agents?
So if you look at the LEADER trial data, the LEADER trial data shows definitely no effect on EGFR, very minor. However, when the statistician looks at that minor effect is significant. That made them publish in New England a paper where they do sub-analysis at the lower EGFR stages, and they show benefits. It may be that since GLP-1 agonist works on the most oxygen-consuming transporter, sodium hydrogen, that at lower stages that you will have these effects. On the other hand, as I said, that the problem with GLP-1 agonist is that you also have a dilation of the afferent arteriole, and that goes against what you achieve with an SGLT2 inhibitor. By the way, even DPP-4s are natriuretic. So GLP-1 agonists are natriuretic, but as I said, although you generate the adenosine, you actually have vasodilation. Why? What about the SGLT, the DPP-4s? They're also natriuretic. they work on the distal tubule. So you actually go beyond the cyst. And this is the reason why you have different effects of all of these medications on the kidney. But if you want to achieve something on the kidneys, go for an SGLT2 inhibitor. That's that's my take of it.
Thank you so much. And now can we move on to our next session? I would thank you so much, Dr. Bharat Shah, sir, Dr. Vaibhuja Panchal, and Dr. Pawan Harnik. I would like to invite now Dr. J.P.S. Watney. He's the chairman in the Department of Cardiology in Sir Gangaram Hospital in New Delhi. And I would also like to invite Dr. Hemant Antani. He is the senior diabetologist in Anand. So I would like to take over, sir.
Sure. Thank you, Videsha. Let me, it is my privilege to introduce Professor Kaushik Ray. He is the professor, consultant cardiologist and professor of public health at Imperial College of London, and is one of the key researcher, and I've been associated with him at the moment with this a great drive on familial hypercholesterolemia global registry, which is driving, and I'm associated with him here. He is now been elected as the president of European Atherosclerotic Society also. And with this brief introduction, he's got a lot of publication into peer-reviewed journals and a great researcher. I will now request Professor Kaushik Ray to deliver a talk on the management of dyslipidemia based on the guidelines from the European Society of Cardiology. Professor Ray, please.
Great, thank you. Just going to try and share my screen.
We have it.
There you go. Okay, so thank you for the invitation. Nice to see so many friends, even though it'd be nice to do this in person, we have to do this virtually, the new normal. So I've been asked to talk about the new ESC/EAS guidelines. And we often think about different guidelines and whether one is better than the other. And it's not so much that. I think it's much more of a case of we all look at the same evidence, and the interpretation of that may vary, and there may be additional bits of data that come out between certain sets of guidelines. So the ESC/EAS guidelines, which came out last year, are by far probably the most user-friendly, and certainly are the latest of the guidelines that have emerged. These are a list of my disclosures. I obviously do a number of trials and with different therapies. So the premise that all guidelines is essentially our attempt to assess risk and therefore titrate risk factor reduction to match the level of risk. So this is really the centerpiece of all of these guidelines. This is from the cholesterol treatment trialist Lancet paper 2012, showing you 5-year risk, not 10-year risk, 5-year risk. So people here have a risk of major cardiovascular events of 6% per year. And these are deaths here, vascular deaths of 6% a year. And what you can see is that there is no such thing as a normal LDL. There is no such thing as enough LDL lowering. Basically, if you lower LDL a bit more, you will prevent more events. So if you lower it by 1 millimole, you'll prevent 6 events. If your event rate is less than 1% a year, if you lower it by 2.5 millimoles, you prevent 12 events. Now, if you achieve that same level of lowering, but against a background risk of 6% a year, then that simple first intervention of 1 millimole is in a population preventing 61 events per 1,000. On the other hand, if you lower LDL by 2.5 millimoles in people with more than 6% a year risk, you're preventing 142 events. And that's really the premise. So what's new is this concept now of we are doing more and more imaging, and they tend to be things like coronary artery calcification scores, carotid imaging. Now, where you find evidence of these being abnormal, that is something that is useful, because often we're using these things in asymptomatic individuals where their 10-year risk may be in this intermediate level range. Now, this actually helps you to rationalize and place these individuals in a higher risk category or in a lower risk category. Because one of the problems with all risk scores is this use of age, which can over or understate risk in some populations. The other major factor is that there is overwhelming evidence that elevated LDL, LP(a) rather, is far more common than many of the other dyslipidemias. We should be thinking about this, we should be looking out for this, and when we can measure this, it helps us to reassess risk. Other key recommendation changes are, as you will know, the first real clear evidence that targeting patients, I won't say triglyceride lowering, but identifying patients with elevated triglyceride, which is of relevance in diabetes, is important. And this was the data from the REDUCE-IT, looking at highly purified EPA, 4 gram a day in patients with diabetes and hypertriglyceridemia. Then we've got patients with heterozygous FH, where if you've got established cardiovascular disease, we should aim for a lower target. So before, this target was about 1.8, that's gone down now to about 1.4. We don't have huge amounts of data in older people in primary prevention. And so one of the key things, let me go back one. So one of the key factors here is to make sure that we have this general assessment of risks and benefits in older people and have a discussion with them about the potential benefits, particularly of preventing non-fatal events. It's very hard to prolong life in people, for example, who've got advanced atherosclerosis, we've missed 40, 50 years of exposure. And then there's the population with diabetes. So one key determinant now is that patients with diabetes isn't necessarily, unless you've had it for a great many years, a CHD risk equivalent in terms of the absolute event rate annualized. Therefore, we need additional variables, and this may be the most powerful of these seem to be the presence or absence of microvascular disease or individual factors, and risk is risk. So if you've got a high enough event rate, we should be targeting a lower LDL. So at the top, for example, in so-called very high-risk patients with diabetes, the target now becomes 1.4 millimoles or 55 milligrams per deciliter. If you're a high risk, not a very high risk diabetic, you still want to achieve a 50% reduction in LDL from baseline, but now the target is 70 milligrams per deciliter or 1.8 millimoles. And this in previous guidelines would have been about 2.6, for example. In terms of diabetes dyslipidemia, really the key factor here first is intensification of statin therapy. The TNT trial, one of the analyses that we did showed that clearly in this patient population, if you've got elevated triglycerides, you actually get about a 4% absolute risk reduction from going from 10 milligrams of atorvastatin to 80. So in general, we need to think about optimizing the statin first and then look at that potential residual risk, which is how modern trials are done. And the final key thing is to think again about gene-environment interaction. So if I'm a patient who has a previous history of cardiovascular disease, and I'm presenting with my second ACS event, and I'm already on statins, and I'm already on ezetimibe, then actually my LDL is probably too high for my gene-environment interaction. And therefore lowering LDL by another 50% to 60% with a PCSK9 inhibitor may well be beneficial, for example. So there is this consideration because the trials didn't start with enrolling people in the hospital setting with ACS, but pragmatically, if you think about people who are, if you like, frequent flyers with their cardiovascular events, you actually need aggressive control of all risk factors. And putting this in the guidelines really makes a lot of sense. So how is risk defined? So unlike a lot of guidelines which try and separate primary and secondary prevention, the ESCES guidelines really say that risk is risk. So the highest risk group are those people with established cardiovascular disease. Now, whether that's come, you've had a bypass, an MI, a stroke, or we've done some imaging to demonstrate you've got significant atherosclerosis. But then there are people who don't have disease, but they have enough in the way of risk factors. So in the middle, you'll see people with diabetes and target organ damage. This is any form of microvascular disease. Or in the absence of microvascular disease, maybe 3 major risk factors, because what you're trying to do is get event rates high enough to match, if you like, the patient with established cardiovascular disease. You'll see, for example, type 1 diabetes of long duration, severe kidney disease. Now, at the bottom, you've got a calculate. This is for primary prevention, and SCORE, primary prevention risk calculator, uses fatal events, not fatal and non-fatal events. So here, now, it's saying very high risk defined as about 10% over 10 years, so 1% per year risk of dying. That would equate to somewhere between 1.75 to 2% year of fatal and non-fatal events. And then at the bottom, FH with ASCVD. The next group, established CVD, is now out. So now we're looking at primary prevention patients who either have, as you can see at the top, an isolated single risk factor or combinations of different risk factors that put their risk up. So FH, for example, primary prevention is next, and we're aiming for an LDL below, we are identifying these people with LDLs potentially above about 4.9, but also primary dyslipidemias as well. So people who may have polygenic hypercholesterolemia, isolated hypertension, 180 over 110, patients with diabetes, but now without target organ damage, because that would put their event rate too high. Now a shorter duration of diabetes, because again, their event rate is a bit lower than the previous group. CKD now 30 to 59, because again, it's a little bit lower in terms of event rate. And now primary prevention 10-year risk of dying between 5 and 10%. And then similarly, you go down to the moderate risk group, where now we're really talking about primary prevention SCORE risk between 1 and 5%, and now shorter duration of diabetes. Age comes into fact in how you can calculate risk in this patient population with type 1 and type 2 diabetes. So it's really trying to give you an estimate of what the theoretical event rate might be, and in order to target treatment. Now, why is that? Well, on the right-hand side, you'll see at least for the very high and the high risk group, the aim is first to try and maximize the dose of statin. And so because many people don't really think about it in that way, this is why there is this explicit wording of trying to achieve a 50% reduction in LDL from baseline. So first, you do your risk assessment. Then you look at the starting LDL. And then if you've done your risk assessment, you know your first goal is to achieve a 50% LDL lowering with the statin. So now if my LDL were X, what is my target? And that's what the table on the right is very useful for in routine clinical practice. But then if we look at the recommended targets and the goals, we've now seen trial after trial whereby we have seen in people with established cardiovascular disease going down to LDLs below 55 milligrams per deciliter, 1.4 millimoles, is actually beneficial. Therefore, this is a class 1 recommendation. We have 2 trials at least with the PCSK9 inhibitors, so it's the level of evidence. Ezetimibe and improve it took people down to around about 55 as well. Now, it's interesting here that for primary prevention, because of this concept of risk is risk, the class of recommendation is 1, but you'll see the level of evidence is C, because specifically largely cost, and it may be that we will end up doing this, but you'll see that those trials haven't largely been done in that patient population. But if you look at the totality of the data, then the wisdom is that actually, if you're a high enough risk, you want LDL to be as low as possible. And you can work your way down, and essentially, with the exception of the low risk group, where the LDL goals have stayed the same at 3 millimoles or 115 milligrams per deciliter, every group, moderate risk, for example, which would have been 3 millimoles, is now 2.6 millimoles, 100 milligrams per deciliter. High risk, which was 2.6 millimoles, is now 1.8 millimoles. So there has been over 3 of the 4 risk categories, a lowering of the LDL targets. And the aim of that is essentially this graph on the left-hand side, which is you want to titrate LDL to risk. Choose the LDL that is right for you. So in yellow, if my risk is low, I can afford to be less stringent about my LDL. And that should be sufficient because I don't want to undertreat, but I also don't want to overtreat. And then if I go down the level of risk, well, now I'm aiming for lower and lower targets. And you'll see that in the very high and the high risk groups, the first thing is to aim for a 50% reduction and then the target. Now, it's recognized that in order to get down to very low levels, you probably won't be able to do it with monotherapy with the statin, and you need combination therapy. And that's why on the right-hand side, there is this algorithm whereby, first of all, you start with the statin. Have I achieved the 50% reduction? No. Well, if I have, great, but no, if I haven't, then I need to think about add-on therapy. Or if I've achieved a 50% reduction, have I achieved goal? And if I haven't, the first line would be ezetimibe. If that didn't achieve goal, then I would think about a PCSK9 inhibitor. And this table is similar to the first one that I showed you in a couple of previous slides, but now it's estimating based on the baseline LDL cholesterol on the left-hand side, how or what combination of treatment gets me to a particular level. So if you look across this combination of moderate intensity statin with ezetimibe or monotherapy, high intensity statin with ezetimibe or monotherapy, or high intensity statin, for example, with a PCSK9 inhibitor. And we don't think necessarily every patient is going to need a PCSK9 inhibitor, but some may do. And what we want to basically try and do, because risk is agnostic to how you lower LDL, the question is, again, doing it in the right way, in a cost-effective way for our patients. So this is where this algorithm may be really quite helpful. So people obviously always want to know about, well, what's the role of PCSK9 inhibitors? There are some obvious groups where this is really going to be needed. So for example, in secondary prevention patients to get down to very low levels of LDL, and there you've got at the bottom class 1 recommendation level of evidence aid. But if you get there with statins and ezetimibe, you might not need the MAB, because remember, those trials recruited people who had suboptimal lowering of LDL despite statins and ezetimibe and a history of vascular disease. Potentially in high-risk primary prevention patients, but the class of recommendation here for MABs is lower, it's 2B. There is an ongoing trial called Vasilius that is going to hopefully resolve this. FH patients, they start so high in terms of the LDL. If they need lower targets because they've had vascular disease or because they are statin intolerant to some degree, then you will probably need a PCSK9 inhibitor. So the ASCVD and the FH patient population are 2 of the most obvious groups to consider for these therapies. A couple of changes between the previous set of guidelines on the left, 2016, and 2019. I think that we've recognized now that a lot of people say that, well, what's the trial data for ApoB? Well, if you change lipids, if you change LDL, LDL isn't an ApoB containing lipoprotein. And so trials may have been done by targeting a particular reduction in LDL cholesterol, but by virtue of that, you will have got a particular reduction in ApoB or non-HDL. And so in people, particularly with high triglycerides, obesity, diabetes, metabolic syndrome, where LDL on its own inadequately assesses risk, ApoB or non-HDL really become much more important. And the beauty is because these are not calculated using the Friedewald formula or from triglycerides, you can do these in the non-fasting state. So that is one of the advantages. And in general, in those patients with insulin resistance, some degree of background, whether they've got diabetes, obesity, or high TG, we should be thinking about ApoB or non-HDL as a target. One key difference between 2016 and now is we've got more data. And so the data for using combination therapy and starting combination therapy early with things like ezetimibe is really more important. Importantly, previously in 2016, we didn't have much information on PCSK9 inhibitors. We didn't have the outcome trials. We clearly have those now. And so there is a much more important role, the use of PCSK9 inhibitors compared to earlier. And we should be thinking about this early. And I fully envisage that costs will come down. Triglycerides remain a challenge. And there is this disconnect between targeting triglycerides. And when triglycerides are really high, you are trying to prevent pancreatitis. However, when triglycerides are below that kind of level, so now you're thinking about trying to prevent ASCVD risk, then there is really not a lot of data for things like glitazars, for things like fibrates. What we do have, though, however, is that we will have this data for EPA. So, but the first baseline treatment, as you can see on the right-hand side, is to optimize the dose of statin, because what that does is it reduces the number of ApoB-containing lipoproteins, the VLDL, the IDL, that also contain triglycerides. So you are using triglycerides as a marker. And if you use the modern statins, you will get some reduction in the triglycerides anyway of up to about 30%. For FH, and in particular, FH patients with established disease, we clearly have to go to lower levels. There is now even more data than we had previously, and this is basically advocating earlier use of PCSK9 inhibitors in these very high-risk patients. You've seen that the suggestions about older adults. This doesn't really apply to secondary prevention, it's much more about primary prevention. There was a paper last week looking at 300,000 patients, not a trial, observational data, suggesting the use of statins in the average patients over the age of 80 was associated with a 25% lower mortality. Now, the trials that are going on will help to clarify whether we should be actively choosing to give a statin. But what the observational data basically said is, if you've got patients that you've started it on and there are no side effects, then it's reasonable to continue. ACS continues to be a challenge in the early setting because these people, often 60–70%, are not on statins. You first have to optimize their medication and then you assess their LDL goal. But for those frequent flyers, recurrent offenders, if you will, who are already on good doses of lipid-lowering therapy, a PCSK9 inhibitor should be considered early. If your LDL is high, above 190, now you should be going to drug therapy. So no need for risk assessment, irrespective of what you would have calculated. That was clearly shown by our analysis of the WASCOPS data with 20-year follow-up that we published about 3 years ago in Circulation. So as a result of that paper, a lot of these boxes that were not read are now read, i.e. recommending that there is clear evidence now that you should go straight to drug therapy, provided you don't have secondary causes like hypothyroidism, for example. So in conclusion, clinical care starts with an assessment of absolute risk for very high risk patients or very high risk primary prevention patients. We need to aim to reduce LDL by 50% first of all, and then titrate the LDL to the goal, which is designed to match the level of risk. Ezetimibe should be used earlier because for lower goals, we will undoubtedly need combination therapy. We're presenting some data in Europe later on at the ESC that you'll see this. Clearly for lower targets, without it, we won't be able to achieve those. And PCSK9 inhibitors can be added to oral agents when there is insufficient evidence and when the risk of recurrent cardiovascular events or that first cardiovascular event is extremely high. So I will stop there and with the simple message, if this was America and this was an advert, achieve the LDL that is right for you. Thank you.
I think we request Dr. Hemant to.
Yeah, thank you, Dr. Ray. Shall we take the questions now or shall we take the question at the end?
I think at the end.
Samir, should we take the question in the end?
If Dr. Rai can stay back, that would be great. Thank you.
Shall we take the question later, right?
Yes, yes.
Okay. Can I have the slide, please, Dr. Callahan, please? Thank you very much, Samir and Dr. Rucha, for giving me this platform to be a part of this wonderful meet. And it's my pleasure and privilege to introduce Professor Atul Callahan. He is a consultant diabetes and endocrinology at Royal Glamorgan Hospital, Wales. He's a visiting professor, University of South Wales. He's also honorary consultant endocrinologist at the University Hospital of Wales, Cardiff. He has been course director of postgraduate diploma and MSc endocrinology course at University of South Wales. He has been editor of specialty certificate exams, and he's also involved with many academic laurels. So without much ado, I would like to request Dr. Callahan to take over and go ahead with his subject. Dr. Callahan, please.
Thank you. While Atul, we are switching over to your screen, I'm just going to extend a warm welcome. Atul is also a very good friend. And he's a good friend, he's an avid runner as well. So I want to add that to his CV. And he has trained many of our diploma practicing diabetologists in the country with his online program. So Atul, it's a pleasure to have you and we welcome you to the conclave.
So he's the right person to talk about the risk.
Thanks a lot for the kind introduction. I'll start by giving a very simplistic message, right? We are mortals and we want to be immortal. We want to live forever. And this is a book. It's a must-read book for all of us if you've not read it. I wish I was as rich as my namesake, Dr. Atul Gawande, but I'm not. So if you think about it, cardiovascular disease remains the leading cause of death and disability worldwide, killing around 17-18 million people a year. 1/3 of all global deaths and half of all non-communicable deaths are associated with or attributed to CVD. So the global CVD burden, huge. And I think COVID crisis exposed us. My personal take on is the people with central obesity, hypogonadism, male gender, there was a hidden kind of CVD burden which was exposed by COVID-19. The inflammatory markers from the adipocytes have a strong role in the cytokine storm. But anyways, that's another part of the discussion rather than in the forum today. And as we age, our chances of dying because of a cardiovascular disease increases exponentially. So if you've got diabetes, especially age 50 and above, there is around 65 to 70% chances that you'll die with a atherosclerotic cardiovascular disease event. So at the very beginning, I wanted to give you a clinical scenario, right? And I want you to spend at least 30 seconds to 60 seconds to assess this guy who's Indian origin, is around, let's say, mid-30s, comes in for your kind of annual review or sees you in the clinic. BMI is around 27.5 kilogram per meter square. I've given you the value of the cholesterol and the blood pressure, right? Now, I want you to do a simple thing. In your mind, calculate his risk of developing CVD and how are you going to assess it? I'm not seeking any answer at the moment. And I'm sure many of the time, similar scenarios you must be facing in your clinic. Right? So if we have to do CVD assessment for somebody walking into the clinic, we've got limited time to do it. We can do it by physical examination. I think I remember my time as a MD student in India, and we were so into listening to the diastolic and systolic murmurs, which were rumbling and grade 4/6. The only thing which I remember from it is that if something is easily audible, that's a systolic murmur. Something which take strain to be audible is diastolic murmur. So that's the reason I ended up as an endocrinologist rather than being a student of Dr. Sani in there, or so many of the cardiologists around. And I've put a picture that I'm sure you would have spotted the mistake or the error in the examination technique of this young doctor. So we do know, we historically, traditionally have relied on the physical examination for CVD assessment, not CVD, but for cardiovascular assessment. It's good for heart failure, atrial fibrillation, maybe detection of valvular disease, but CVD risk assessment with cardiovascular assessment, it's very limited value. I'll not spend long time in mentioning about the atherosclerosis and the general principles. We all know about it. We were taught about this in our second, third year of medical school. All I'll say, the risk, it's a lifetime risk. It starts quite early in life. Now, higher the baseline risk, earlier the intervention is needed and more beneficial. And adding on to what Prof. Kosek-Ray mentioned, it's the triglyceride-rich lipoproteins, which are extremely important in this scenario. It's not the LDL or the triglyceride, but it's the triglyceride-rich lipoproteins, which have a value in preventing or the progression of atherosclerosis. So, multiple strategies, CVD risk stratification, you have either screen the whole population, which does not work in a multi-ethnic, multicultural country like India. Are you going to target only the individuals who come to attend your clinic or the hospitals? Again, there are issues about the false positive and false negative rates. So if I look at India, obviously I can compare it to Europe, and I'll say that you can't have one strategy which will fit every single region. You have to tailor it to your own region, your own population, based on your own resources. And that's what, having trained in India, I can appreciate it far more than some of my colleagues in here, which, because we follow our guideline, and the population we follow here is quite homogeneous. So moving on, what should be the ideal CV risk assessment for us? Should we screen every man who's over 40 and woman over 50 in presence of cardiovascular risk factor, irrespective of the age, and not to screen certain groups? The elderly, obviously, they've got high risk anyway, so they should be treated as high risk, and patients with, initially we used to say type 1, probably type 2 is a cardiovascular disease, it's a chronic insulitis, so or somebody who's got CKD stage 3 to 5, we should assume they've got cardiovascular risk, which is high. Now, what we learned for CVD, on CVD is based on the Framingham Heart Study, and I'll not waste too much of your time going through it, but if you look at the numbers of what we gained from this study, the number of publications, it's a huge amount of data. It's going into the third generation of people who have participated in the study. It is the first study which obviously picked up people, coined the term risk factor. Prior to it, our knowledge in atherosclerosis management was quite limited. Now, broadly speaking, we all know there are risks which are non-modifiable: older age, male gender. I wish, age can be modified. It's more it's a problem between biological age and the chronological age. Being an endocrinologist, I can tell you and assure you, we can change the gender, but I don't recommend it. There are some modifiable risk: smoking, hypertension, obesity, diabetes, and dyslipidemia. Now, what we know that impact of combination of these risk factors is huge. And this is just a simple kind of chart. I'm not going to read it, but we do know from clinical practice, if it's a female who's age 30 or 35, her risk of cardiovascular disease is totally different from somebody who's 50 and smoking. So the key thing is the Framingham study had multiple limitations. Although it was quite strong, being a prospective trial, first in its of its own kind, large number and huge follow-up. But the problem was the Framingham trial had most of the population, which was Caucasian, Irish origin, or Italian origin. It was a very homogeneous kind of population, not heterogeneous. And there was an age and gender bias also. So thankfully now, we've got more information about how we need to do cardiovascular risk estimation. And my simple theory is that the 10-year risk metric has limitations. It's very good for a population-based evaluation and very good for the politicians, the policy makers. It's not good for an individual because there is a huge amount of bias for example, being a female. And as I said, if you're a younger female, you're smoking, you've got other risk factors, dyslipidemia, these risk metrics will underscore you. And a few years ago, we proposed that we should be thinking about a lifetime risk estimation, and rather than focusing on only 10-year risk engines. Now, over the years, we've learned that there are other factors which modify our CVD risks, be it socioeconomic status, be it family history of CVD. In fact, migraines have been added to it. Presence of carcinomas, autoimmune conditions, psychological health, the list is long, right? So here is just a simple table about the different risk assessment engines we've got at the moment. The historical and the traditional Framingham one on the very left of your screen. SCORE is the one which is followed by the European Union, and I would have asked Prof. Ray about it, that he's following SCORE when we have exited now. So should we not be using QRisk? So, but he's a EAS president, so I'll not debate on this one. But the QRisk engine, the data has been derived from the GP database. Huge number, again, measures the life. There is this 10-year risk of CVD events, and we've incorporated the lifetime risk assessment also in it. Ethnicity, hypertension, chronic disease, social deprivation, these have been included it in, and it's based on the JBS3 guidelines also. And I'll urge most of the members who have not used the QRisk score to do a QRisk assessment for their own self, because it's quite an eye-opener kind of, because it gives you a visual kind of clue about what you can face based on your own assessment. Going on to the novel cardiovascular risk assessment metrics and absolute risk assessment, what is their future role in clinical practice? I'll not go into too much detail, but as Prof. Ray was mentioning, apolipoprotein B is an emerging marker. We should be using it more frequently. If you've got the resources, consider using C-reactive protein, but do remember it's just a marker for inflammation. How to interpret it is based on the observer. Not in UK, but in US, they're using coronary artery calcium scoring a lot. Again, there are points to debate. You can use it as an individualized kind of approach for patients who can afford it. Or if you go further, you can think about carotid intimal thickness. So I'm almost coming to the very end of my presentation. If you look at this slide, it gives you a ABCCHD risk model. On the very left is the pathophysiology, right? You've got your risk factor, organ dysfunction, and the disease. In the middle, you can see the risk indicators, which As I said, some are non-modifiable. Gender we can modify as being endocrinologist, but then we've got few things which we can change, like controlling the providing a good glycemic control, modifying the lipids, and cessation of smoking. On the right are the potential actions, kind of. I'll say in a country like India, it's more important to consider the potential actions using these novel anti-diabetics and lowering LDL and focusing on the green zone rather than the red zone. WHO came up with a CVD risk management 3 scenarios, and it all hinges on availability of resources. And on the far left is scenario 1, in which you've got limited resources. And if I had only 100 rupees to spend, I'll probably give a cost-effective statin to a patient along with metformin and control the blood pressure, right? And if I had everything on my side, I can hit the same person with SGLT2 or GLP-1 analog. I can use a PCSK9 inhibitor along with it. So I think we have to keep in mind the availability of resources when we are going to do a CVD management per se, and especially when we are coming up with a policy per se, right? And this is very important for a country like India, in which there is huge variability in amount of resources. So as I said, if I have a patient who's poor, can't afford, then even starting lowering the glucose, I'll focus on giving a statin which is generic, use our metformin, and probably use a blood pressure lowering medication which is like Reviprin. So that's my the most effective kind of scenario. The other hand, I can use a PCSK9 or throw in whatever is available, GLP-1 and SGLT2. So I didn't want to consume too much of time. It's a fantastically good day in South Wales at the moment. It's sunny out there. I want to go out and soak some sunshine before it disappears and we are again soaked in rain. CVD risk assessment or CVD risk, these are multifactorial. Things start extremely early in life, I think even in your teens. You can have a population-based approach based on the resources and use the risk engines, which you have to adapt locally. More importantly, as an individual, if somebody is at high CV risk, you need immediate attention and do the needful. And for my CVD risk assessment, I run, and this is something very near my home. I've come back from a little cycling tour this morning. Thank you.
Thank you, Dr. Atul. And now Dr. Sani. I would like to ask Professor Ray one comment and one question to Dr. Ray. A comment is that about for the management of acute coronary syndrome, we say we use high doses of statin like 40 milligram of rosuvastatin or 80 atorvastatin. Instead of that, if you start with 20 milligram of rosuvastatin along with ezetimibe, or 40 milligram of atorva with ezetimibe to begin with, as which has been studied in IMPROVE-IT trial, probably this will be more effective, maybe more safer, and working in two different pathological mechanisms will be more able to reach the goal early. I want your comment on this. And number second, the question is, in very high risk population, you have shown that in CT angiogram, if there are more than 2 vessels which are 50% disease, the LDL should be less than 55. And in high risk, only blood pressure above 180, 110, LDL should be less than 70. Are these two based on the evidence, or it is the expert opinion? Why not for every hypertensive we should reduce the LDL to less than 70, like diabetes?
Yeah, so I think I'll start with the first question about ACS. I think undoubtedly, if you want Again, it comes down to the individual versus the population. At a population level, undoubtedly, if you were to use a combination of a high-intensity statin below the top dose, together with ezetimibe, you would probably achieve a lower LDL cholesterol. When you go from 40 to 80 of atorvastatin or 20 to 40 of rosuvastatin, you gain about a 6% further lowering. On the other hand, adding in ezetimibe, you gain 20 to 25% further lowering. So that does make a lot of sense. I think previously, many of these things are often done on the basis of cost, but I think now ezetimibe is generic, and I think it's perfectly reasonable to consider 40. Let's say there was a combination pill or the two together, 40 of atorva or 20 of rosuva. I think the issue that you mentioned about safety, 80 milligrams and 40 milligrams aren't really, it's not like simvastatin when you start to go above 20 milligrams of simvastatin. These drugs really aren't unsafe. What can be an issue is tolerability amongst our patients in terms of statin-associated muscle symptoms, and that does increase a bit more. Previously, most of these patients are very well engaged because they've just had a heart attack, so they may put up with some of these. But I agree with you that basically long-term, it may well reduce your risk of real muscle-associated symptoms. With regard to the hypertension, that really is coming from a predicted 10-year risk. Now, you've got to remember that you had early trials of blood pressure lowering, where now, unless you were studying some population like recently, there was the older patients where you could get people in with very high blood pressures and a placebo arm. It is impossible to do a placebo-controlled trial if you're age 40 to 50 with that level of blood pressure, for example. So I think it was based on largely a population-based event rate. However, if you had other factors, if you had a strong family history, you had a low HDL, or you smoked, then you might well actually be treating those people much more aggressively. It's really just that isolated factor. And I don't think we have the trial evidence to confirm that, simply because they haven't gone down to those levels in that particular patient population. The only trials that got remotely close were ASCOT, and that took people down to LDLs of about just under 2 millimoles.
Thank you. Thank you very much.
Yeah, Professor Ray, I have a question. Supposing somebody is put into a moderate risk by the definition that you showed, but the person's CAC score is, let's say, 300, would that change the risk category?
Yeah, absolutely. And that's exactly the reasoning, as you heard very nicely in the last talk, that when you basically look at asymptomatic individuals, we can overestimate risk, we can underestimate risk. And so if you did have that coronary calcium score level, that would push that person into a higher risk category. And so you would therefore treat that person much, much more aggressively. That's absolutely right. And to the point about biomarkers versus CAC scores, if you use any single biomarker at a population level, you are changing your clinical decision making in about 1.5 to 2% of the patient population. If you use 2, 3, 4, NT-proBNP is probably the best biomarker. If you start adding in that to CRP and so forth, yes, your predictive ability does improve with a multi-marker approach. But now your number needs to screen. Cost of the assays for 3 of those have to be weighed up against the numbers that you change your clinical decision in. Now, across the board, a coronary calcium score basically changes your decision making in over 20% of your patients. So it's far, far more informative than any of the blood-based markers or even CIMT or ankle-brachial indices.
Can I take this question one step further? It's a question of aspirin in a primary prevention. Would the CAC score in some way going to influence that?
Yeah, so this is really driven by the observational data that has come out from the United States, from MESA. And so the first thing I would say is that aspirin, if you look at the primary prevention trials, that particularly as background therapy has changed with greater use of statin therapy, blood pressure control, that the overall benefits of statins are really outweighed by, there's no mortality benefit, for example. They are outweighed by the potential adverse effects on bleeding. So the CAP score data is observational. What it does not tell you is the numbers needed to harm. So when we looked at this some years ago, and there's been a few additional studies since then, you get about 2.5 additional bleeds for every one non-fatal MI that you prevent over a 5-year period. So that's not good population gain in that regard. So I think in terms of net benefit, it's not just the potential benefit. Somebody maybe will do an RCT, but you saw even in the older patient primary prevention, there was no mortality benefit, nothing, not in the diabetics. So I stopped using aspirin in primary prevention about 10 years ago.
And one more question, if you don't mind, is about the PCSK9 inhibitors. You know, they are very exciting drugs, but the cost is really deterrent. So I really want to ask you, in UK, in a real world scenario, according to you, what percentage of patients are really receiving PCSK9 inhibitors?
Yeah. So globally, of the numbers that we thought would be receiving PCSK9 inhibitors, it's now only kind of reached double figures, so 10%. The US has obviously a very different healthcare system. In the UK, we have, at the pricing level that it was available at, in the UK, they kind of suddenly found that actually nobody's using it, or very few people are using it. It's hospital-based only, which basically means GPs can't. But the problem you have is your stable patients, your high-risk patients, sit in primary care. They don't get, I can only do something, and Professor Cullen can only do something if somebody refers them to his clinic. It's not our job to go and find them, and that's the problem. So, for example, one of our nice criteria for PCSK9 inhibitors, where the government will give it to you free, no questions asked, ASCVD with an LDL above 4 millimoles. In northwest London, in my part of London, there's 2.5 million people, 57,000 have ASCVD. We have these big data sets that I can look into. There's 6,700 people sitting in primary care with an LDL above 4. So we're trying to look at designing pathways for them being referred in. And they would be given it under our current system. The problem is that there are lots of low-hanging fruit. They may not be coming to you because they're sitting out there.
Get your point. Thank you very much. Professor Sawhney, if you have any question. Dr. Sawhney, if you want to ask something.
Oh, no, thank you. He has answered my question, and Atul has very nicely told the individualized lifetime risk is much better than it has to be individualized for the risk assessment.
Oh, sir is muted.
Please unmute yourself, sir. Dr. Sawhney, please unmute yourself.
Sorry. My question is, a young boy comes with executive health checkup to me, 28, 30-year-old, with the LDL of 140, no family history, no other risk factor. How to manage? Dr. Ray.
Lifestyle. Dr. Sawhney, it's going to be lifestyle. And that's what I keep on saying,
Yeah.
The first and foremost is going to be, and obviously if it's a high risk, you do a QRIS scoring and everything. Address every single risk factor he's got, And
he doesn't have.
So does he want to go for
we have done the lifestyle modification diet. As you know, 20% plays a role. His LDL is still 140, and he reads on the Google and says, I am having risk of cardiovascular disease. He's not diabetic, non-smoker, no family history. We have not done Quotient score, but shall we start statin or not?
Most of my patients come up with some side effects to statin, which they've seen on Google, like
this is unusual.
epidemiological risk of having diabetes and all. So it will be a welcome change. I will recommend statin if they are really worried about it. It's a very controversial kind of area, but I believe in lifetime risk. And if I individualize it, if the lower the LDL, better it is. And as I started at the very first slide, I said all of us want to be immortal. And we can, if I use a statin, a metformin, and a PCSK9, probably I'll die of dementia age 97, right? So that's the, so this guy, if he wants to.
Yeah, I mean, what I would say is that.
Yeah, would you do CAC score in this patient?
CAC score's really not going to help you here because in most people, you need enough years of exposure. So, if his risk factors were really extreme, if this guy was, you could argue you're going to treat him if he's an FH patient, etc. But the problem is he's in his 20s, and even with male gender and ethnicity, etc., it is going to be really unlikely that his calcium score is going to be anything other than 0 in this sort of individual. The only thing that may help, and we've got a paper in review at the moment about this, which we're then going to try and change into a risk score. You've heard about the polygenic risk score. Now, the polygenic risk score, genetic risk score, you can use that to estimate lifetime risk. The disadvantage of that is that it includes LDL and blood pressure. So what we've tried to do is separate the LDL and blood pressure out from the polygenic risk score. Now, why is that important? Well, your risk of cardiovascular disease depends upon your genetic vulnerability to your environmental exposure. And one of the things that comes out from this is if you basically have a high polygenic risk score, so this person, if let's say did have that, you would be able to estimate how much blood pressure or LDL lowering and over how long would actually be able to reduce this person's future risk of cardiovascular disease. So that would then guide exactly the decision that you've put to us is, would I use a statin? And I would change that to, would I use LDL lowering? Well, if diet and lifestyle did what I needed, and because you're starting so early, there is the cumulative benefits from even a small difference maintained for the next 50 years. But if, for example, it was a much higher risk, then you might think about pharmacological lowering by X amount. And that might be achievable with very low doses of statin. But because you're now doing it over 40 years or so, you're going to get the cumulative benefit. That's the bit we don't know that I think will be the next piece of the puzzle.
Can I add one more question, Dr. Sahni, to your patient only? Would the estimation of LPA help in this patient? Professor Ray.
It would put him at a higher risk.
Yeah. So in this patient, LDL of 140, and you're not sure. Yeah.
So Dr. Ray, one question. Clinically, how to differentiate between FH versus polygenic FH? I mean, the polygenic hypercholesterolemia patient versus
clinically,
how to differentiate?
Yeah, clinically you can't. I mean, clinically you can't. I mean, there's basically, if you find people with the classical tendon xanthoma, arcus, and so forth, that is more likely to be FH than polygenic. If you have, your 45-year-old patient, usual referral is this FH from the GP, and you examine, many of these people will not have any clinical signs. And I think basically the only thing we need to move towards is genetics. Genetic test will give you polygenic, monogenic, and that's how we should classify it. Monogenic hypercholesterolemia, polygenic hypercholesterolemia, simple as that. And there'll be a few with Lp(a) elevations that you'll pick up.
Thank you.
So
I just have a quick question for it can be for Atul or for Dr. Ray, and I'm happy to have both of you here today. So when we talk about risk reduction, Atul, maybe this question is for you. You said lifestyle was your answer. What is the percent reduction we are going to see? There was a very nice paper in the New England Journal. I'm sure you've seen it. They looked at 55,000 patients almost. And this was by Dr. Amit Khera and colleagues, wherein they did a genetic risk scoring, and they also did the lifestyle part of it. And there were 3 healthy habits: keeping a low BMI, not smoking. So they had 3 out of 5 categories you had to fall into. And they found only a 50% risk reduction, even in the ones who were really following everything, and with a high genetic risk score and a family history. And I asked this because Dr. Dani and I actually co-chaired this session or debated against this recently. And he was on the side of no, you cannot change things with lifestyle, whereas I was trying to promote, like you, Atul, that lifestyle and running changes everything. So your comments on what is the amount of risk reduction we can promise our patients? We see so many, like Dr. Sahani said, young patients on a daily basis. In my family, every female has had a heart attack by the age of 40, including my mother. So, I'm a high risk candidate. So that's what I'm trying to understand. Yeah.
On an individual basis, which I told, there are so many variable factors. It depends on kind of lifestyle modification you are able to adapt. Kind of, when you look at the statistics, it's a population derived measure, right? So if I say 1,000 patients, this reduced by 50%, it still does not individualize it, right? So and the second thing which we know, that it's not the LDL, it's not the triglycerides, it's the triglyceride rich lipoproteins and apolipoprotein, which is the CVD risk association. And this has started within you when you were in your teens, kind of, or even earlier, right? So I'll not be able to give a number to an individual because there are so many variable factors. We create statistics to hide behind things, and statistics are at times created on the spot. So one study may say a different thing. So all I'll say, I'm a big advocate of lifestyle modification. There is promise now with some triglyceride lowering therapies which are coming in, pemafibrate and all, and I think the fibrates lost their ground from 2008 onwards in UK. In my practice in diabetes, I'm not using it as, I think the field study was the one which was a big letdown to us, because apart from the retinopathy part, nothing improved. But hopefully in coming few years, there'll be some other, apart from the PCSK9, which are almost, unless until they make it less expensive, we will not be able to use it as commonly in population. But the group which is emerging at the moment is the pemafibrate group, and more than the icosapentaneol. So I'll not be able to give a number to you.
Thank you. I was just trying to say, because we get patients asking this all the time. If I do all this, is it going to take away my risk? That's what they want to know.
It will
They're going to
reduce.
start
It
eating
will
low
reduce.
carbs and take all
I don't know
Yeah.
if. Yep.
Yeah, I think that so that paper, again, as Professor Collins said, is this, it's a group, there's an age range. And so what you know is that from birth, there has been genetic exposure, vulnerability, if you will. And what we're unsure about is the duration of that lifestyle change and the level of that, right? So even if I have genetic risk, so if I have a 30-year-old primary prevention patient versus a 50-year-old primary prevention patient, what's the difference between the two if the genetic exposure is the same? It's that 20 years. So we don't have this yet, but being able to estimate that in general, in your younger patient, blood pressure reduction, irrespective of drugs, irrespective of diet and lifestyle, if you can achieve what you need to do early enough and maintain it for long enough, there is no evidence you get any extra benefit from anything else. So what matters is that intermediate phenotype. So if you were able to get a 30-year-old and you were able to estimate more accurately than you can at the moment their 10-year risk, and you were able to estimate how much blood pressure LDL reduction that you needed, for example, if that was done with diet and lifestyle, you're absolutely fine because you've got that cumulative benefit. But if I make a diagnosis age 60 in somebody, I've missed 30 extra years of unexposed exposure. So diet and lifestyle probably aren't going to work to reverse what's in. So I should have a low threshold for thinking about pharmacological intervention. It's like basically if you have a secondary prevention and primary prevention patient, you need a lower LDL target to give you the same event rate. And that's what you're doing with time here in that regard. So that is, I think, is going to be the real game changer. And it will, that's how we're going to individualize it much, much more. But if you can start in a 20-year-old with lifestyle, fantastic. And if they can maintain it for the next 50 years, fantastic. But there'll be some people.
We just heard today. Oh, sorry.
No, I was going to say, but there are some people who will be more either not get enough reduction for a level of risk that they or you would accept, where you might then want to reserve pharmacological intervention for those people. But as you get further on in your life course, your threshold for drugs gets lower and lower and lower because you've missed the last 40 years. So if we're really going to get serious about prevention, we need to basically move this to between your school and before the age of 40, not picking people up age 40 to 70.
So we actually heard today morning from the father of lifestyle, using lifestyle to prevent CV disease or metabolic syndrome, Dr. Taylor. I actually see him on the panel, and it was reassuring to learn that we don't have to do this very quickly. He said you can take your time, but what you mentioned, lose about 10 to 15% of weight. So I don't know, Dr. Taylor, you're there and you have any comments, feel free to chime in, of course. And if not, I'll let Dr. Dani take over so we are not running too late.
Can I ask the last question to Professor Ray?
Yes, please, Dr.
Professor Ray, that was a very interesting thing that you came up with, the genetic kind of a classification of deciding who are going to, behave which way. Now, is this going to be clinically, practical for everybody to talk about it?
Yeah, so that's our next aim. I mean, so in Europe, we've used score risk, which is suboptimal. The reason for using it is there's not much reliable data on fatal and non-fatal MIs and some of these other events. So the European risk calculators will be updated, but all clinically measured variables, if you think about the age and if you think about the imprecision around some of this, there are limitations. So the idea is that if you basically have a panel, you have $100 full genome score that you can basically generate, then essentially that can feed into your electronic health records. And if you basically program the software, just as you do now with QRisk, with Pooled, it will give you that 10-year risk. And so if you then basically say, well, okay, you could simulate, so that the JBS3 risk calculator at the moment, you can change blood pressure, you could change smoking, and you can look at life years gained. You can look at heart score, for example, and you could do all of these things. That becomes really user-friendly because it shows the patient and it shows the doctor what the gain is.
Thank you. That's very interesting.
So I want to make final comment. I feel, as you rightly said, Dr. Ray, that the irrespective of the age, when we are managing hypertension and diabetes, why not LDL? This is one. So we should give statin, even in small statin, it will be okay. Secondly, I personally feel like diabetes, irrespective of LDL, hypertensive patient should also reduce their LDL to less than 70. What is your opinion?
Yeah, I'm not sure about the less than 70 part. I think it should probably be lower, but individual estimates of event rate depend upon a number of other variables. What age you've started. So, again, if you look at the genetic data, and I look at people with blood pressures that are elevated, we know that a small difference just being maintained is actually beneficial. So if you were to diagnose hypertension early, then I don't think you need 70. But if you diagnose it really late and you've got 30 years of accelerated atherosclerosis, vascular damage, then probably that lower target is more rational and sensible for the patient. But I mean, essentially, there's no such thing as an LDL that's actually too low. And for blood pressure, there are other things like, feeling dizzy, falling over, collapsing, etc. But in general, at least the observational data for systolic blood pressure goes down to about 110 below or up to that level. So essentially, lower tends to be better. Certainly for LDL, it's all the way down, there is no limit. But for blood pressure, there may be at a limit where you then start to get other potential side effects. But in general, if you did that in everybody and we didn't smoke and your BMI was okay, most of cardiovascular disease would actually go away.
Okay. Thank you. Thank you, Dr. Ray and Dr. Kalan for the nice presentations, and Dr. Shahani sir and Dr. Hemantantani sir for being the chairpersons. Let's move on to the next topic, talk of the town or talk of the globe,
Thanks, Atul. Thank you, Dr.
COVID-19.
Ray.
Yeah. Talk of the town or talk of the globe right now, COVID-19 and heart. So for that, let me invite Rakesh Yadav,
Can we have the
cardiologist from
chairperson
AIMS,
slides,
and
please?
Dr. Sanjeev Patak.
And I think I'll give you the size of her.
Yeah. Dr. Rakesh Yadav is
Yes, I'm
from
here.
AIMS Delhi, and Dr. Sanjeev Patak is Director, Vijay Ratna Diabetes Center, Ahmedabad. Now, may I hand over the mic to Rakesh Yadav sir and Sanjeev Patak sir. Sir, please do the sharing.
I think thank you, Samir, for calling me here. And I think today this talk is a very relevant talk because what we are seeing, though there is a lot of literature about COVID-19 and heart, but there are a lot of mysterious things which is happening. And we have encountered so many patients which die suddenly after being cured of COVID and told to be that practically you are okay. So what is happening doesn't fit in this scenario. And I think our eminent speakers will highlight this important aspect because what we believe, lung may be the cause of mortality, but it is basically a heart and thrombotic milia which is causing more mortality than the lung part. So I think Dr. Caste will be the best person to talk about this important COVID-19 and the heart. I think we should hand over the mic to him. Thank you.
So, thank you very much for your warm welcome. I'm here on my vacations in France. Not so hot as you are used to have it in India, but for me even hot enough. And it's my pleasure to share with you some insights of that, what we are thinking about COVID and the problem of cardiac dysfunction, heart failure, and cardiovascular risk. In a moment, I just try to share with you my screen. Just give me 10 seconds. I hope you can see it now. So if you look here to the first entrance slide, you see here the COVID virus photographed by electron microscopy in a heart species of a patient with COVID. We have to discuss what does that mean. Is it just a bystander, or is it really a direct cardiac However, that what we know is summarized here. The World Health Organization has warned us and shown that we are losing a lot of patients with COVID who are older and have pre-existing medical conditions, especially those with cardiovascular risk factors. So we are losing a lot of patients with hypertension or those had already induced in heart failure scenarios years ago. So we say that about 25 to 30% of the patients with COVID will develop severe cardiovascular events. Most of them were already diseased, but to my experience, probably we can discuss that a little bit later, also young people, 30 years. In the moment, I have an 18 years old girl in my intensive care unit who got a severe cardiogenic shock. Are the problems of that we cardiologists have to be aware. As in the beginning, the knowledge came up that, especially in the experience in North Italy with respect to European experience, we learned that most of the patients died the mean age of 79.5 years, 70% of were males, and most of them had severe comorbidities. This had been also reflected in the experience of our colleagues in China, and there was done the mistake to interpret that only older peoples with a lot of comorbidities are those at risk. That's not true. That was the patients who died early. We know now that also 40, 55 years old COVID patients can die from cardiovascular risk events. And even kids, as I just have told you, 18 and 20 years old, young people are in my intensive care unit and fighting for their life. So let's have a little bit deeper view what kind of cardiovascular events can occur during COVID, and you see that summarized here. We can have a progression of the vasculopathy, micro and macro vessels can be further injured during the disease, relative ischemia, probably also due to shock scenarios, systemic inflammation, very important. We'll discuss that a little bit later. And last but not least, the role of the virus toxicity itself. So we can speak about myocarditis, cardiogenic shock, primary or secondary induced due to lung failure, arrhythmias, myocardial infarctions, and new onset, but more often further progression of heart failure are the cardiovascular or the cardiologist scenarios of patients with COVID, and this is more or less age independent, although we lost the first patients who were older as the COVID pandemic reached also Europe. Why is that? And I would like to show you the latest data from Germany and also my center. When we speak about COVID, we believe this is a lung disease. And yes, you see that here the RNA copies show that the virus, the SARS-CoV-2 virus, is extremely high presented in the lung and in the pharynx. But that is not true, that this is the only organ which is affected by this virus. You see that here, you see virus present in the kidney, in the liver, as well as in the heart, showing you that this virus is not a single lung tropism characterizable virus. It is a virus which can entrance in all other organs too. And with respect to the heart, you see that here virus particles of the SARS virus had been found by electron microscopy pictures in the interstitium of the heart. That had been interpreted that probably macrophages from the lung had been also floated into the organ. But here you see biopsy samples from one of my patients 2 or 3 weeks ago, showing that the SARS virus was already inside in the myocyte, and this myocyte is here destroyed, showing you that you can have a direct viral toxicity in the myocytes. Probably they are also inducing a form of myocarditis, but that's not enough. You see here also inflammatory cells in the endothelium associated also with SARS virus particles. So we believe that the SARS virus can be, with respect to the heart, found in the endothelium, in the myocytes, and probably also in the virus in the fibroblast, because these are the cells of the heart where SARS viruses, and I will speak about that a little bit later, are
Sorry to interrupt, Dr. Shoppe. Dr. Kasim. We have somehow poor audio quality of your talk. Can you increase the volume of the mic, or can you come nearer to the speaker?
So is this better now?
Yeah, that's better.
So probably the camera is not so important at this condition because I have to be closer to the microphone.
Yes, you can switch off your video.
Yeah.
If you like.
It's too complicated for me. However,
it's okay. It's okay.
Important. It is just important that you can hear me. So I would like to summarize my last 2 or 3 sentences. I just told you that the SARS virus can be detected in myocytes, in cardiac vascular cells, and also in fibroblasts of the heart. And that means that the SARS virus is not only a lung disease virus, it is a virus which also is affecting the heart itself. And that is important for cardiac function. But also, as you can see on this slide, you see here plaque ruptures in patients with COVID. And if I can summarize that, I believe that COVID is disease where the virus can also directly induce cardiac damage, biomyocarditis, by touching the macrovessels, and especially in the COVID scenario, when the patient has a severe status of the disease, you have a cytokine storm, which induces, of course, negative inotropy and will further progress the bad progression of patients with COVID-induced shock scenarios. So I think this is extremely important to understand that COVID is not a single heart disease. It also can affect a single lung disease. It also can affect the heart directly or indirectly. What kind of strategies to fight against the COVIDs are discussed? And I would like to give you some insights about the pathophysiology and the infection rate of the virus. You see here the COVID virus. It binds to the membrane if there is a specific co-receptor expressed. Most important is the so-called ACE2 receptor together with the TAMP receptor. So cells who have these receptors target cells for the virus. And I will tell you now that this is not only in lung cells, but these receptor subtypes can be also detected, for instance, on myocytes. So if the SARS virus has reached and attacked, entrenched through these viruses, through these receptors, the virus is internalized, it can be then replicating, and then due to exosomes, it can also infect the next cells. What are the strategies to fight against that? And these are complex strategies which has been investigated by a World Health Organization program, the so-called Solidarity program, which is a mega study where different drugs, including malaria drugs, HIV drugs, and remdesivir, further Ebola drugs, are further investigated. So how far we are here and what are doing these drugs. So chloroquine as a malaria drug is a drug which can prevent the endocytosis of the virus and diffusion, and also changing the pH value in the vesicles so that the virus dies. So that was the hypothesis. However, this can be also dangerous. We cardiologists know that chloroquine drugs have very known severe side effects, especially they can induce rhythm diseases by severe QT time prolongations. However, as we had some experience, here's data from a French group showing that 200 milligram hydrochloroquine was able to reduce the SARS expression in the nasopharyngeal test. A lot of people hoped that they have found the key to fight against COVID. You see here, Mr. Trump said 2 months again that that he is a large fan, the biggest fan in the world about these drugs, and let approve chloroquine against COVID. But I think that was a little bit too early. The first studies came up and showed that the effects to fight against COVID were relatively minimal, but QT time prolongation occurred already in the first 2-3 days. And the patients had suddenly an increased mortality. And this Brazilian study, the mortality started to rise already at the second day. And after 6 days, nearly 16% of the patient on hydrochloroquine died, so that the trial was stopped. And here's also the latest observational study from New York, showing you that hydrochloroquine had really not an effect against the disease. but has more insight of side effects. So that I believe this is the end of chloroquine in COVID. And I know that sometimes, since it is also an easy to get drug and a cheap drug, some hospitals still try to use it in patients who had no other opportunities. But after these studies, I really cannot recommend to do so. What about another idea to use proteases inhibitors like lopinavir or ritonavir? These are drugs which we used in AIDS patients affected by HIV. And there we had some first interesting result showing you that using these drugs in severe COVID disease patients, we have a tendency, but not really in a significant result to use these drugs, most probably because the drug was used too late after the 13th or 14th days. We have subgroup analyzing showing you if you are able to use this drug very, very early, then you might have a positive effect, but this is still under investigation. So also the protease inhibitors drugs in the moment cannot be recommended to use them out of trial designs. Probably most interesting and also politically important are the polymerases inhibitor, remdesivir. It was an Ebola drug. You have to give that in the moment still IV. And small preclinical studies show that there are probably some effects which had been reapproved by this New England Journal paper coming from Germany, that you see here an improvement, especially in younger patients with respect to the natural cause of the disease. But still this is not approved in a trial. And even I have heard that some states are very interested to buy all stocks of remdesivir at the moment. We at the Charity are not using the drug because we have no data that this is a really an effective, safe scenario. On the other hand, it's very, very expensive. The treatment will be something by 5,000 to 10,000 euro under these conditions. And even if you would use these drugs, you see that these drugs are interfering with our classical heart failure medication. So not only rhythm diseases can be induced, as I have told you, by chloroquine, but also the effective of other drugs like aldosterone antagonists or ACE inhibitors can be negatively affected by these drugs, which are still under investigation. And therefore, we in Germany do not recommend any of these drugs of the World Health Organization until the study results are finished and the results were positive. So let's come to my first conclusion. SARS attacks the heart directly and or indirectly. SARS can further impair heart failure, and we have no antiviral drugs available. So the question is, what can we do? So I think we have to prepare our heart failure patients, those patients who are at risk, those patients who are in the higher age, they have already heart failure, and there we have to prove whether they have the best optimal heart failure drug oral medications already on board, and whether we have and can to improve that. And usually, as you all know, that we are doing that with ACE inhibitors, beta blockers, and aldosterone antagonists. They are effective. You see that here, if you have a heart failure patient without some of these drugs, which I would call the classical triple therapy, the patient has of course, severe reduced prognosis. If you would give an ACE inhibitor, a beta blocker, and aldosterone antagonist, you can increase the prognosis by a better lifetime from more to 2 to 3 years, just to show that this is really, really effective. The other question is, what about sacubitril valsartan? We know that this is more effective in heart failure patients. You see that here, this is the benefit of the classical, this is of the modern, the ARNI-based effect, and we know that we have here clear with sacubitril valsartan a better prognosis in heart failure patients. However, and that is something what needs to be further discussed, although we know that these are here data from the European community showing us that the heart failure drugs are not well used in our heart failure patients. And I think if you ask me, what can we do in the times of COVID to prevent or to prepare the patients in COVID times? It does not mean that if a patient has COVID, he will necessarily go to the intensive care unit and will develop a shock. This is probably only 4, 5, or 8% of the patient. The most of them have a moderate or mild course of the disease, but still 10, 20% of the patients will get an impairment of heart failure. We cardiologists have the task to prepare the patient for this scenario, and therefore I just can call again for proving the oral medications of those patients who are at risk. We can ask us why principally also without COVID times the heart failure drugs are not so well used. Probably because very often we believe the drugs are too expensive, they induce hypotension, or the patients are very often still stable. But I want to tell you that in the Paragon trial, 70% of the patients were stable. They were NUHA class 2, but NUHA class 2 means that the patients are at risk. And if you want to have a summarize of my idea, what I would like to see here in COVID times, I would like to see that all patients with heart failure, I think that is classical, should have the ACE inhibitor beta blocker MRI treatment. And even when they are NUHA class 2 and they have already signs of the progression of the disease, risk for COVID, aging, you see an increase in BNP levels or something like that. So clinical markers, serum biomarkers by rising of BNP. Then I would like to see the switch from an ACE inhibitor to an ARNI, even in NUHA class 2 patients, to prepare them in the times of COVID when they belong to the risk scenario. So a modern triple therapy with an ARNI is most effective, independent of heart failure symptoms. And I think this is extremely important. And the major question is, of course, can this be really translated to COVID patients? As you remember, I said in the beginning of my talk that ACE2 expression is extremely important, that the virus can integrate into the myocytes. And there we have at least a theoretical thing to discuss. The problem is the following. If you give an ACE inhibitor or an ARNI, ACE2 expression will be increased. And that induced a large debate, at least in Europe, whether we should give in COVID times ACE inhibitors or an ARNI, because if ACE2 is increased, probably it is more easy to jump into the cells for the SARS virus. And yes, it is true that happens, but we have clear recommendations here in Europe, summarized here on this slide, that they say that even if the viruses theoretically would have had a higher chance to integrate into the cells, we still recommend renin-angiotensin inhibitors, including ARNI in heart failure patients, because the netto effect is most probably much higher, larger, and more important for the patient than not to give these drugs to the patients. So, conclusion, 3 guidelines recommend still strongly renin-angiotensin inhibitor in heart failure despite COVID times. Because, and this is my last point I would like to show you, is that renin-angiotensin inhibitors most probably have anti-inflammatory effects for the myocytes. This is important. You see that here in myocarditis, patients, the renin-angiotensin system is activated, more aldosterone synthesis, more angiotensin 2 levels. And if you would treat these clinical scenarios with aldosterone inhibitors, or with AT1 receptors antagonists, or with an additional reduction, that is extremely important. So I come to my end. I believe that especially in COVID times, we need the modern triple therapy, and patient at risk should get, if ever is possible, a switch from an ACE inhibitor to an ARNI under these conditions. So my final conclusions, renin-angiotensin inhibitors can increase ACE2, but they are still heart failure protecting effect are so important that we still need them. And what we can do in the clinical routine, at least in my country, a lot of patients are not coming to the hospital despite they have clear signs of worsening of heart failure because they are afraid that in the hospitals they get infected with SARS. These must be clarified and improved. And I think with modern heart failure triple therapy, we have a very good primary prevention strategy already in our hands to help these patients because COVID is not a pure lung disease. It includes also heart failure. Yeah, that is all what I wanted to tell you. I hope you could understand me as good as possible, and I'm happy to get some questions from you. Thanks for your attention.
Thank you, Dr. Carsten, and it's a wonderful talk about COVID and heart failure. But there's few quick questions. First, sometimes it is very difficult to diagnose heart failure in a COVID patient who is in ICU, in ARDS, and on ventilator. And often the troponin, whether you take troponin or pro-BNP or BNP level, they are always mentioned that it can be increased without heart failure. And to contrary that, if you have a frank heart failure, you are going to give a lot of diuretics to this patient, you are going to restrict the fluid to these patients, and it has of its own side effects. Moreover, all the medications which increases the QT interval, whether you give antiviral or whether you give hydrochloroquine, they all increases the QT interval, and there's often an electrolyte imbalance. So tell me, in a patients of COVID who is admitted in ICU on ventilator, all the guidelines recommend you should have a clinical heart failure before you diagnose a heart failure, because these all parameters are not going to help you out. So what should be your approach? How to diagnose these patients? Sometimes it is very difficult, and the cardiologists are often called, the echo facility is not there, or the cardiologist is not ready to do echo in COVID patients. So what is your approach? How you diagnose? Basically, that is always a challenge for everyone.
Very important question. So my talk was mostly directed to those patients who were not in the intensive care unit. But of course, those are in the shock scenario. You see suddenly a rise in BNP and troponin T, and then you know that the heart is also affected, even if the ejection fraction would not still be already reduced. And there, I think, there are 3-4 very important recommendations to follow. First of all, give these patients low-dose steroids. That sounds counterproductive because you believe this is a viral disease. However, the SARS virus is so toxic because it induces a cytokine storm. A lot of cytokine interleukin 6 is increased, and that you need to stop because the cytokine storm and therefore we give 10 milligram steroids. The other thing is we do a severe anticoagulation because we know that during the cytokine storm, you have an activated coagulation system. So all of our patients get low dose steroids, 10 milligrams. All of these patients get a full hyperonization, PTT time 70 seconds. And I think this is something what you should do in all the cases. There came up a new trial 3-4 days ago. Was a trial in Greece. There they have given colchicine. You know colchicine? I don't know whether this is the right name in your country. It is the anti-inflammatory drug against gut. That could be something, but it's still an experiment. So if you ask me what we are doing at the charity, we give low-dose steroids and we give anti-hyperonization.
Excuse me, sorry to butt in, Dr. Yadav. Dr. Neil Mehta has to leave in 20 minutes or so. So let's have his talk, and then if we have time, we can discuss things further.
Yes, wonderful talk, Dr. Carsten. And I think very relevant in this current scenario. I think COVIDology is now a new branch itself, and COVIDocardiology is going to be new super specialty, I think. Thank you, Rucha, and thank you, Dr. Samir Dani, for organizing this wonderful meeting. Yesterday, I had opportunity to introduce my colleague, Dr. Samir Kapadia. And I again thank you for giving me an honor to introduce another colleague of us, Dr. Neil Mehta, who was our senior in our undergraduate and postgraduate days. It's over to you. He is an internist and associate dean of curricular affairs at the Cleveland Clinic Lerner College of Medicine, USA, and is director of Center for Technology Enhanced Knowledge and Instructions, holds the Johns Day Endowed Chair in Medical Education at Cleveland Clinic, and his specialty interests are chronic disease management, diagnostic, internal medicine, management of patients with multiple complex problems. Recently, we read your review article on ACE-ARB. I think it was published in NEJM or some important journal. So over to you, Dr. Neil.
Let me just share my screen. Good afternoon, everyone, and thanks, Samir and Rucha, for inviting me today. And Sanjeev, yeah, we go back a long way, and thanks for the very kind introduction. I'm a general internist, but most of the work I do is actually in medical education. But when COVID came along, I think all of us really had to go back to basic sciences to understand, either to treat it better or to teach our students better. And this was one of the reasons why I really got interested in the topic of ACE and ARB and COVID. But as we think about ACE and ARB and COVID, and we say, you know, we are, this is a cardiometabolic conclave, and wonder how COVID got in here. And secondly, you wonder where the lungs are, right? Because we generally think of COVID as a pulmonary disease or a respiratory disease to start with. So I'm just going to take a stab and put the lungs in here into your logo, Samir and Rucha. I hope you don't mind. And what I'm going to do is walk you through some of the basic science behind the ACE and ARB system that you just started to see in the previous talk, and realize that we live in an incredibly complex body. I mean, this body, we had such a linear idea of what things were, you know, renin, angiotensin, angiotensin 2, and done, right? I mean, that's kind of what we knew when we were in med school, and everything has changed. Also wanted to share very quickly one paper that I just found as I was preparing for this talk. And this is because COVID toes has become a big thing, right? And COVID is everywhere in your body, so much so that it's in the toes. And what they have actually found is just like they have found it in the myocardium, the chemical stains have found COVID particles in the endothelium of the toes, and that is what causes the chilblain-like COVID toes. And this has become so popular that this is Washington Post. It's one of our national newspapers. And even to the lay public now, they have these very simple diagrams trying to explain to them that this is not just the lung, it's the whole body. And so let's try and see how COVID affects COVID and the ACE and ARB system are interconnected. So I'll go back a little bit, right? Just to simplify this, because I think unless we have this background, we will not understand the key questions that keep coming up. COVID affects blood vessels, it affects the heart, it affects the lungs. It seems to affect everything. How is the ACE and the ARB system connected to that? So we know that renin lives in the juxtaglomerular cells. It's released from there, and it's released when the volume is low, the sodium level is low, or by direct stimulation of the beta-1 sympathetic nerve fibers. So what does renin do? So it works on angiotensinogen. Angiotensinogen is present in the circulation. It's made mostly in the liver, and it's in the plasma. And it converts it to angiotensin 1. So basically, angiotensinogen converts to angiotensin 1, and renin works on that to do that. Next step is the ACE enzyme. And ACE converts, which is present in the lungs, in the vascular endothelium. It'll convert angiotensin 1 to angiotensin 2. And this angiotensin 2 works on the AT1 receptor. So AT1R is usually what you will see listed everywhere. And remember, it's angiotensin 2 type 1 receptor. It's not angiotensin 1 receptor. Some of my students confuse that. So it's AT1R is what it's popularly called. Okay, so why is all this important? So the role of angiotensin 2, which works on that receptor, we know that it kicks in because renin kicks in, and renin kicks in to, wow, when the blood volume or the sodium is low. And angiotensin 2 does everything to get it all back. The problem is that everything it does, it releases aldosterone, causes vasoconstriction, sodium reabsorption, increases norapi, causes release of ADH, increases the thirst center drinking water, and leads to cardiac and vascular hypertrophy. And everything it does in the setting of inflammation is actually causes harm. And this is one of the key things that you will need to realize is angiotensin 2 is considered to be one of the key mediators of lung injury in the setting of various, it could be aspiration pneumonia, or it could be infection, it could be influenza, or it could be Ebola. So let's go back to that picture. And the part that I think most of us did not know 10, 15 years ago was that there is something called, there is a second kinase, it's ACE2. And why is this important? And this is critical to understand SARS. So what happens is angiotensin 1, which is normally just going down this path to attack the AT1R, it gets converted to something else. It's angiotensin 1,9 by ACE2. And angiotensin 2 is converted, and this is the critical thing, is it's converted to angiotensin 1,7 by ACE2. Again, so ACE2 is actually reducing the levels of angiotensin 1 and 2, increasing the levels of these two. And even though this is the enzyme receptor we keep talking about, there is two more receptors. There is the MAS1 and the AT2R receptor. And these do exactly the opposite of what this does. So whatever this increases, these two will decrease. And the two products we just saw, this here works on this, and this works on this. And they therefore negate all the bad effects of angiotensin 2. So I said a lot of things, but if you keep this picture in mind, what you got is the pathway that leads to things that cause harm and the pathway that leads to things that cause good, okay? And angiotensin 2 is the good guy and ACE is the bad guy. If you can just keep this simple in your mind, I think it helps a lot to understand SARS. So what do these two other receptors do? They do vasodilation, they cause natriuresis, they're anti-fibrotic, and they're anti-thrombotic. And you know this is one of the key problems with COVID, is seems like everyone is clotting. And like you just heard, there is possibly a role for prophylactic thrombolytic treatment in the people who are sicker. Several trials are going on to see if they would do better with that. Very, very complex diagram, just trying to summarize what I just went over. So angiotensin Gen converts to angiotensin 1. Angiotensin 1, this is the ACE2 enzyme. The reason I show this is the membrane of the cell, right? And this is where these enzymes sit. Sometimes we think these are all just floating around in the blood. We are talking about the cell, a human cell wall, okay? And ACE2 will convert this to the good chemical. ACE itself converts it to angiotensin 2, and which attacks the bad receptor or acts on the bad receptor. Again, this ACE2 is a good guy, converts it to the good chemical, which works on the good receptor. All right. So all the green things are good, and this is clearly bad. And all this is happening on the cell surface. And one thing that we'll come back to later is ACE2, even though it sits on the cell surface, it can also be floating around in the blood. All right. So this is in the blood, and this is on the cell surface, and completely different effects, because if it's in the blood, it has a different effect in the setting of SARS than if it's on the cell membrane. Okay, hopefully I haven't lost people yet. So we talked about the renin, angiotensin, aldosterone system. Let's take a look at something. Most of you are cardiologists, or a lot of you are. This is very common, right? So cardiac distension, sympathetic stimulation, and angiotensin 2 lead to what we all know are the natriuretic peptides, right? And these are good guys. And what do? Why are they good? They decrease renin, amongst other things. And this leads to decrease angiotensin 2 and decrease aldosterone. Again, this is the bad guy, remember that, okay? So natriuretic peptides are good, and these, it's important to remember these because again, you could see they're connected with the renin-angiotensin system. Okay, and finally, this thing always gives me the creeps, is the coagulation pathway. And the reason I bring it up is COVID is a disease of clotting. And I won't do a quiz on this because I know I personally always fail on the coagulation pathway. But the intrinsic pathway is named intrinsic because it doesn't need anything from outside to make it work. And what sets it off? And your eyes may glaze over a little bit, but just bear with me. So this is the collagen, subendothelial collagen from microtrauma, plaques, what have you. Okay, so we go through the pathway, and I won't bore you with the details, but finally we come to something we all know, which is factor 10. And this pathway activates factor 10 to factor 10A, okay? So we are good there. Factor 10A converts prothrombin to thrombin, and thrombin converts fibrinogen to fibrin. Now, this is the part, remember the high molecular weight kinin and the plasma kallikrein. What do? So high molecular weight kinin, it basically is converted to bradykinin. And what converts it? It's plasma kallikrein. So the two things we just talked about. And how does this impact us? Factor 10A is converted to, or activated to, factor 12 is converted to 12A by both these agents, as we just saw. But it also has a feedback loop, and it activates kallikrein. So once you start clotting, you are in trouble, right? And bradykinin, we kind of know a little bit about this because ACE inhibitors cause angioedema, right? So think about that. Why do they cause angioedema? So bradykinin causes arteriolar dilatation. It causes increased capillary permeability and venoconstriction. So if you put all these three together, you're basically going to end up with a lot of inflammation and a lot of edema, and they also stimulate the pain nerve fibers. And why is this important? Bradykinin in production is decreased by ACE, and ACE also causes breakdown of bradykinin into all its degradation products. So if you have ACE, which we all do, we have less bradykinin. And when we give an ACE inhibitor, the level of bradykinin goes up. And there is the theory that if you have more bradykinin, it actually makes your lungs behave like ARDS because you are essentially having increasing edema. Okay, so I think I bored you with a lot of detail already about the pathways. So just to summarize, we talked about renin-angiotensin aldosterone pathway. We talked about the natriuretic peptides pathway, and we talked about the coagulation cascade and how it connects with the kallikrein and kinin pathway. So keep all that in mind. Summary, angiotensin 2 is bad, and you want less of it in the setting of lung injury. And it all connects with the natriuretic peptides. It connects with the coagulation pathway. All right. So now, why is this important in the setting of COVID? And this is a diagram that actually you just saw with the previous presentation. And I just want to go into a little bit more detail. So remember that cell membrane right here, and on it is the ACE2. So this is the receptor. And unfortunately, for both SARS and SARS-CoV-2, this is where the spike protein, which is this thing here, it specifically binds to this receptor. And there is a couple other chemicals that you may hear about, TMP, RSS2, furin. These are two that you may hear about because there may be ways to prevent or decrease SARS effects on the body with some inhibitors of these agents. And what they do is they help with the ingestion of the SARS virus into the body. So essentially into the cell. So this is kind of what happens is the SARS gets ingested by endocytosis. And again, you saw this in the previous talk. Now the concern here is that, remember, you will have thousands and thousands of SARS viruses. So what happens is you end up depleting your ACE2 receptors that are present on the cell. And we just saw that ACE2 is the good guy, all right? So when you have a lot of SARS, you could end up with less amount of ACE2. And the other thing to think about is if you did not have ACE2, you would never get SARS because that is what attaches the SARS virus to the cell. So ACE2 is bad because it allows the SARS to get into your cell. But ACE2 is good because it decreases the lung injury and fights the effect of angiotensin 2. This rest of the slide puts it all together. So this is the AT1R receptor, and it does all the bad things we just discussed. And remember that this green is good. So the ACE2 is converting it to all the good chemicals which work on the MAS1 and AT2R receptors, which are good guys. All right. Now, why do ACE inhibitors and ARBs play a role here? And this gets into the very interesting questions that we are facing right now. So SARS gates entry via the ACE2, we saw that. This is the question that we still don't have a 100% answer for in humans. Some data from cardiac studies in mouse models and some data about renal studies in humans that the renal studies was on olmesartan. And if you give olmesartan, people have increased level of ACE2 in the kidney. We have not actually proven that this increases in the lungs in humans, but animals models suggest that. So if you have patients on these agents, they have more ACE2. Assume that this is true. We don't know for a fact in humans, but in animals it is true. And you just saw that ACE2, having more ACE2 can be good or it can be bad. And so this is a critical question that we had to face. If you are on these agents or your patient is on these agents, what are you going to do? Are you going to stop them? Or you want to put them on these agents? Because if they upregulate ACE2, you could hurt them or harm them. And so this was one big question we had. The second question is the bradykinin question, is if bradykinin is causing some aspect of ARDS by causing non-cardiogenic pulmonary edema, let's look at what data we have. So in mice, bradykinin actually causes this, and it also increases the inflammatory cytokines, and IL-6 is included in there. ACE, as we know, decreases bradykinin levels, but ACE inhibitors, we also know that they cause angioedema, ARBs don't, right? Or generally don't. And that's because they increase the level of bradykinin. So can ACE inhibitors make lung injury worse? So what do you do with ACE inhibitors? So the previous question was for both ACEs and ARBs, but what about ACE inhibitors alone? Are they different than ARBs? And is there a difference between the two? And then looking at ACEs and ARBs, if they upregulate ACE2, now remember when you get the virus and all the ACE2 goes into the cells, there is decrease in the level of ACE2. If there is a decrease in level of ACE2, there is more lung injury. So these could be good chemicals, right? So even though they increase ACE2, they're actually good because they're protecting you from the downregulation caused by SARS. So maybe they're protective. And then finally, they increase the level of angiotensin 1-7, right? And because of that, there is this theory that it causes some conformational change because ACE2 is what is causing this change, right? So if there is more angiotensin 1-7, is it modifying ACE2 because of the amount of it that's binding? And that maybe it might impact the binding of SARS-CoV to ACE2. This is completely hypothetical. This was just a theory. So the big question is, are they good? Are they bad? And how do you answer this? So you'd think it's a pretty simple study, right? I mean, you just look at people who are on ACEs and ARBs and see if they do better or worse. Well, it's not that simple. You know all this. These are the people who are on these agents. They're critical medications for a lot of these problems. So why can't we answer it? Well, unfortunately, we know from the very first studies that ACEs and these are the same diseases that cause worse outcomes in people with COVID. And these are the same diseases that are treated with ACEs and ARBs. So the question is, are the conditions causing people to die more or have severe disease, or is it ACEs and ARBs? And this is the classic confounding question, right? I mean, you guys know this is a problem with every type of observational study that you're going to do is how do you split apart this problem? To make matters worse, these three things get worse with age, and people with at higher age have worse outcomes, and again adds to the confounders. So how do you tease all this apart? So I'm going to stop with the basic science part and quickly give you a run through of some of the studies. I'm not going to go deep into the studies because the answer you will see is the same at the end. So the early studies were kind of what we had, right? I mean, this was in March, and essentially most of the early studies obviously came from China. And what they found was that this wasn't the aim of the study, but they were measuring troponin levels. And the people who did worse had higher troponin levels. And the people who had higher troponin levels were more likely to be on ACEs and ARB as opposed to people who had normal troponin. And this raised a concern. Was ACEs and ARB the reason they were doing worse? Well, you could answer they are the sicker patients because they were on ACEs and ARBs, and that's why they got high TNT. You can't answer these questions with observational studies. Another very, very small study, but this was looking at people. And again, this is what led to a lot of other studies, which is why I'm kind of walking you through it. 10 people on ARB, out of them, 3 got severe disease and 7 got mild disease. And so there was a question of maybe ARBs are really protective and they're not bad. This was a study out of the UK of hospitalized patients. And out of 205, 53 died. And out of them only, out of the total 205, 37 were on ACE inhibitors, and only 9 were on ARB. So very small numbers, but here ACEs were felt to be protective. ACE inhibitors were protective. Fewer of them died or went into the ICU. And this was another paper, again, early papers. And basically the problem here was that you see the difference between these two cases here. In the all-cause mortality, The problem was that they allowed doctors to, this wasn't a randomized trial. Doctors would stop the medications if people were sicker, right? Because if your creatinine is going up or the blood pressure is low, you're likely to stop the ACE or the ARB. And so there was a huge bias with this study. So since then, there has been a spate of these studies. I won't walk you through all of them, but you can see a lot of work has gone through this. The short summary is, and I should get this out of here, this was the study, all of you know this, the Surgisphere study, and this was retracted along with the hydroxychloroquine study in Lancet. This was the NEJM paper. And so this was our paper that came out in May, but we did work from March to April on this. All of these were observational studies. And this is the problem, is we still don't have data from randomized controlled trials. But you don't do randomized controlled trials when there is a risk of making people worse. So you need this first before you can think about randomized controlled trials. I'll just walk you through a couple studies. This was in the NEJM, the Reynolds paper, big amount of data. The summary was that ACEs and ARBs did not make people test positive more or have more disease. So basically, there was no difference, okay? Being on these did not make people get SARS, or if they got SARS, make them worse. Again, these are the numbers, but in the interest of time, I'm going to kind of take my word for it. All the numbers cross unity. And this is with matched hypertension, patients with hypertension, and this is all patients in the study. This was our paper, and you're actually going to hear from Ankur later today, I think. And he also did an amazing study with us. He led the study on Takotsubo, and we found that there is increased Takotsubo cardiomyopathy in patients in the era of COVID in patients who don't even have COVID. So it's just a fascinating paper. This was our paper. Basically, what we found was our primary outcome we were looking at was everyone who was tested for COVID. And we look back and see how many were on ACEs, ARBs, either both. And we found that there was basically no difference in the people who tested positive or tested negative, whether they were on these agents or not. All this below this is secondary analysis. And there is a signal here that people on ACEs and ARBs actually had a higher rate of hospital admissions. People on ACEs had higher rates of ICU admission, and no difference as far as ventilator, but our numbers for ventilators were very low. The problem is there is so many confounders here that we do not want to go out on a limb and say, at this point, you cannot say that these are good or bad for you. Since then, a meta-analysis of 10 studies essentially showed the same thing, that there is basically there are divergent results and it does not change the impact. And this is just very, very recent paper that just came out. It's in a preprint. And again, they looked at multiple countries and huge data sets of more than 1 million patients. And what they found was essentially with ACEs and ARBs, there is no difference. So we have reached a point of equipoise, and there is really, we don't know if they are good or bad. And I think we really need trial data, but make sure your patients stay on these agents. So I'm going to stop there and turn it back to Samir. I have a couple minutes for questions. Unfortunately, I have to leave for our medical school white coat ceremony. And maybe 2 or 3 minutes. Thanks.
Dr. Phatak, Dr. Yadav?
Yes, yes. Excellent presentation, Neil. And you clarified the debate regarding the use of ACE and ARB. And as the guidelines also recommend not to stop if patient is already on ACE or ARB. Samir, are there any quick questions?
Anil, there's one question very important, relevant, because a lot of physicians ask this question.
Yadav, would you like to comment or ask anything?
I think If we are audible?
Yes.
Yes, yes, you are.
One quick question, because a lot of physicians ask if a patient is on ACE inhibitor, is a young hypertensive with no other comorbidity, why not we should switch over all these patients to calcium channel blocker for temporary period? Because the effect of ACE inhibitor in mild hypertension young will come after many years. So why it is why we resist that we should continue it? Because there is a lot of apprehension in patient also, because they read Google. So is there is any harm switching over? Because people, if you debate me with a calcium channel blocker with an ACE inhibitor in a young patient, mild hypertension for a short period, switching over. So what is your comment about this?
A great question. I've had this happen. And when we actually started the study, I was worried enough that, and you treat the anxiety of the patient, not just the blood pressure, right? And so if the patient doesn't have diabetes, heart failure, etc., you're just using ACE as a frontline agent for hypertension. The question is, should you switch them over? And the problem right now I have with this is they may actually be helping you. So if you have, it's a big if, right? But if your level of ACE2 is increased by these agents, you may actually be helping them avoid serious lung injury if they get COVID. Now, being a young person, their overall risk is very low. We know that. And so if someone's less than 30, the risk is so low that you probably could do whatever you want. And I would say you could go against the guidelines and switch them because you are treating their anxiety. And that is something that no one measures, but it is important. You have to deal with that as a primary care doctor. But as they get older and the risk of COVID is higher, of severe complications is higher, I think I would not switch at this point, mostly because it's seriously possible that they may be protective. We just don't know yet. And we also don't know the difference between ACE inhibitors and ARBs. And so switching between the two is also something that I don't know if anyone is able to comment on those.
Thank you. Thank you.
Okay, so you all will agree that we have had a wonderful discussion, wonderful talks from Dr. Chope and Dr. Neil Mehta. If there are no further questions, we will allow them to go and take the next speakers in for the next session.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Neil. Thank you, Dr. Carsten Chope. So our next session begins now. The genes, gender, and severe risk. And the chairpersons for this session are Dr. G.R. Kane, Dr. Vinod Mittal, and Dr. Altamash Sheikh. Dr. Kane is a senior cardiologist from Mumbai, a very dear senior friend. Dr. Vinod Mittal is a visiting consultant, Sir Gangaram Hospital, Delhi, and Director, Delhi Diabetes Care Center. And Dr. Altamash Sheikh, the senior consultant endocrinologist in Saifi Hospital, Mumbai. Over to you, Dr. Kane, Dr. Mittal, and Dr. Sheikh.
So, good evening, everybody. I think, may I take the charge of just telling that maybe Dr. Kane, Dr. Mittal, sir, you can introduce the first and the second speaker, and I would take the second one. Over to one of you who would want to take Dr. Leslie. Dr. Mittal, sir, please.
Okay. So, good evening, everyone, and we are having a very exciting and very important, session. And the first talk is going to be by Dr. Leslie Cho from Cleveland's Clinic. She's director of Women's Cardiovascular Center as well as section head of preventive cardiology and rehabilitation. She's also professor of medicine at Cleveland's Clinic and, has got a main interest of research in women and heart disease and the role of, treatments in hyperlipidemia and novel risk factors. And she's also on the steering committee for international trials on hypercholesterolemia. And she's going to speak on, cardiovascular risk factors, which are unique to ladies, women. So over to you, Madam Dr. Leslie Cho. Please go ahead.
Hi, everyone. It's my pleasure to join you today. I was sharing my screen, but I'm not sure what happened right there. Can you guys?
You can start sharing it now.
See my screen? There you go. Okay, great. So thank you for joining me on the unique cardiovascular risk factor in women. It's my pleasure to join you this Sunday morning or Sunday night in your case. So the next slide. Interesting. Oh, there you go. Hold on. So let's just talk about some risk factors. Recently, we published a paper. It's a state-of-the-art paper in JACC, sort of detailing this unique risk factor in women. And one of the most important risk factors is the pregnancy-associated cardiovascular disease risk factor. If you look at adverse pregnancy outcomes, these are defined as hypertensive disorders. They go all the way from just having hypertension all the way to HELLP syndrome and preeclampsia, gestational diabetes, preterm delivery, loss of the fetus, and then intrauterine growth restriction. If you have any of these adverse pregnancy outcomes, which can occur in 10 to 20% of all pregnancy, it increases your cardiovascular disease risk by almost up to fourfold. It's been up to 1.8 to fourfold increase in cardiovascular disease. And the higher the risk, with obviously more severe adverse pregnancy outcomes, but also with more than one pregnancy associated adverse outcome. When you look at why that might be, it's very interesting because being pregnant is like having a stress. It's like a 9 months of stress test. There is some placental vascular abnormalities which leads to adverse pregnancy outcome, which in the long term probably is a predictor for having, endothelial dysfunction, having pro-inflammatory, sort of atherosclerotic milieu. And that together with aging and sedentary behavior all leads to having cardiovascular disease later on in life. So let's look at something that's pretty common, which is hypertensive disorder in pregnancy. If you have hypertension during pregnancy, you have around 2.3-fold risk of having hypertension later on in your life, about 1.5-fold increased risk for coronary artery disease, and you have also a significant increased risk for stroke. If you have gestational diabetes, you have a significant risk of developing diabetes later on in your life, but also developing high blood pressure, coronary heart disease, as well as stroke and TIAs. The other sort of interesting thing is preterm delivery. If your first child was delivered, or if you had a child delivered less than 37 weeks, you have a 40% increased risk for cardiovascular disease. If you have a very preterm delivery, less than 32 weeks, it doubles your risk of having cardiovascular disease. Also, pregnancy loss and intrauterine growth restrictions have been associated with developing cardiovascular disease.
Dr. Cho, sorry to interrupt. Your voice is undulating. So can you come nearer to the computer and speak?
Yes.
Thank you. Thank you very much. Thank you very much.
So when you look at the American College of Obstetrics and Gynecology, they recently published, as well as we did, this sort of conditions which should undergo cardiovascular risk screening within 3 months of postpartum. So if you had hypertension, gestational diabetes, preterm birth, intrauterine growth retardation, placental abruption, excessive obesity, or maternal age greater than 40, they recommend that you undergo cardiovascular screening. At Cleveland Clinic, if you had hypertension or gestational diabetes, or you had any of these adverse pregnancy outcomes, you're automatically referred to preventive cardiology clinic for consultation. Now, the point is not to start them on medicine, but point is to obviously teach them diet and exercise, and also to really do good laboratory screening and physical exam to determine the risk for cardiometabolic disease, and also to prevent future cardiometabolic disease. The other unique risk factor in women is premature menopause. So menopause before the age of 40, regardless of why you underwent menopause, whether it's natural or surgical or chemical because you had breast cancer or whatnot, whatever the cause, it increases your risk for having increased cardiovascular disease. So if you had it in your less than age of 40, your hazard ratio is increased by 1.55, and then and so on and so forth. Now, obviously, you all know why, because when you have early withdrawal of estrogen, you have redistribution of body fat, you have decreased metabolism, elevation of your LDL, increase in blood pressure, and then of course endothelial dysfunction and increased vascular inflammation. So in fact, it's such a great risk factor that the 2018 ACC-AHA cholesterol guideline actually considers premature menopause as one of the risk enhancers for consideration of possibly starting statin therapy earlier. The other unique risk factor for women is polycystic ovarian syndrome. And polycystic ovarian syndrome is extremely interesting because it's a common endocrine disorder that affects young women, associated with hyperandrogenism, ovulatory dysfunction and insulin resistance. And obviously these ladies go on to have significant increased risk for cardiovascular disease. The other extremely interesting thing for this audience is that East Asian women have highest prevalence despite lower BMI, and they have less hyperandrogenic features. So the international guidelines for PCOS recommend that all women with PCOS should be screened for cardiovascular disease risk with annual blood pressure checkup, fasting lipid panel, screening for glycemic control, and then weight changes, and obviously the importance of diet and lifestyle modification. Metformin is recommended for cardiometabolic features. And then I think the other sort of interesting thing is the extreme importance of psychological factors that are prevalent in PCOS patients. And you know that if they are depressed or anxious about their appearance, that actually leads to worsening compliance with dietary and lifestyle modification. And then the other interesting thing we never think about when we think about gender is autoimmune disease. But autoimmune disease is an extremely gender-centric disorder. So when you look at autoimmune disease or inflammatory disorder, 80% of patients with autoimmune disease are women. So even though we think of autoimmune disease as being gender neutral, it's actually very gender centric because 80% of patients with autoimmune disease are women. And in fact, it is considered as one of the risk enhancers. So psoriasis, rheumatoid arthritis, lupus, as well as elevated CRP. Now, if you're a African-American woman or a Black woman, you're 2 to 4 times more likely to have lupus compared to Caucasian women. And the link with autoimmune disease and heart disease is well known, so I won't belabor you with this point, but it is a particular problem in younger women. Ischemic heart disease is the #1 cause of mortality for lupus. It's associated with accelerated atherosclerosis as well as microvessel dysfunction. And the duration of rheumatoid arthritis flare is associated with cardiovascular disease. And most people who study this believe that the autoimmune disease obviously leads to pro-inflammatory conditions, which then leads to endothelial dysfunction and atherosclerosis and plaque instability. But the interesting thing, and this is something for the audience, I think, to really ponder over, is the lipid paradox. So when you take a cholesterol level in patients, for example, rheumatoid arthritis patients, even though they have this, they may have low cholesterol level, but we know that those patients, in fact, go on to have cardiovascular disease. So what we consider in terms of the quote unquote, the lipid level where you should be starting statin therapy, we need to be much more, I think we need to think about these patients in a much higher risk category, and perhaps even use less LDL as a threshold for starting statin therapy. Now, you know that higher levels of inflammatory biomarkers are obviously associated with MACE, such as hsCRP, IL-6, and statins have been associated with reduction of events in these populations. It not only lowers hsCRP, but also lowering LDL. And I think the important thing, so if you look at things like the canakinumab study, when you lower the inflammation in these patients, regardless of LDL, you have benefits. So I think that for these particular patient population in whom the risk is so high, it's really important to be very, very aggressive about cholesterol reduction. And then I just want to say one thing about hypertension. You know, we think of hypertension and we think of hypertension as being neutral, gender neutral, but there's been very interesting studies about women. And one of the studies about women is that women, the trajectory of blood pressure elevation is much steeper in women. So even though, you know, women develop hypertension most likely after menopause, once they hit menopause and they have that, once they go into a postmenopausal state, their elevation of blood pressure trajectory is quite high. The other thing about women is that women don't have the nighttime dipping. So, you know, you want to see your blood pressure go down at night, and women don't necessarily have that. Now, this particular thing, fibromuscular dysplasia, is very unique to women. 90% of patients with fibromuscular dysplasia are women. Fibromuscular dysplasia not only causes spontaneous coronary artery dissection, but it causes renal hypertension. And 75 to 80% of FMD patients have renal involvement. And the first line of treatment is medical therapy. And when they're resistant, or if they have renal dysfunction, then we think about balloon angioplasty. But this is something that we should be looking for in younger women with resistant hypertension. And then, you know, people continue to ask about menopausal hormone therapy and whether that is beneficial. And it is definitely not recommended for cardiovascular disease prevention. The American College of Gynecology in 2018 and again in 2013 and again in 2018 recommended that we do not start hormone therapy for cardiovascular disease prevention. The guidance is for symptom management for the shortest amount of time possible, for symptom only. There's been lots of debate about whether if you start these things early, whether you would have cardiovascular disease prevention, or whether the latest hormone replacement therapy might be better. But unfortunately, the data is extremely inconsistent. The 2017 meta-analysis showed absolutely no benefit of menopausal hormone therapy, but increased venous thromboembolism risk. So even when you're starting menopausal hormone therapy for symptom relief, it's important to consider the venous thromboembolism risk. And then lastly, I'm going to finish with depression and psychological issues in women. And this has been has not received as much attention as it should, but it does increase cardiovascular morbidity and mortality. And in some studies, it's anywhere from 50% to 300%. It's so when we talk about psych issues, we're talking about depression, traumatic stress disorder, childhood adversity, and socioeconomic deprivation. And when you look at the risk factors side by side, the impact is no less than traditional risk factors. It's associated with cardiometabolic risk factors, and it's obviously associated with healthy behaviors. So it's much more frequent in women than in men, approximately twofold increased risk for depression and PTSD and early life adversity. Women are much more likely to have had these than men. It's very common in outpatient setting, and it has extreme importance in terms of developing future events. Now, if you come to the Cleveland Clinic Prevention Clinic, every single person that comes through our door gets a depression and anxiety screening test. We've been doing it since 1993. It's actually has a very good data, and we believe that it's such an important risk factor because that predicts whether you're going to follow with lifestyle modification, medical therapy. So it has been hardwired into our DNA. And then finally, one of the hypotheses for why the chronic and acute stressors may have a negative impact, it affects the neuroendocrine stress system, and of course, healthy behaviors leading to an unhealthy behavior, which then all increase your inflammation and vascular function and platelet aggregation and hypercoagulability, as well as leading to cardiometabolic risk factors. Now, obviously, there's some genetic component as well as some emotional resilience factors that can play into this, but I think it's something that's really important and important for us to address. So recognizing it is the most important first step. It can affect adherence to preventative care. It's usually not part of routine assessment, but we strongly encourage it. Even, it's really gender neutral because a lot of our cardiac male patients have depression and anxiety, and really stress management, counseling, and all those things should be recommended when appropriate. So this is the paper that we recently published. It's a summary of our updated recommendation from the American College of Cardiology, Cardiovascular Disease Writing Committee. And these are the factors that you and I went over today, the unique cardiovascular risk factors in women, which is related to pregnancy, autoimmune disease, PCOS, psychological disorders. And then, the paper also talks about some of the other traditional risk factors that might be a little different in men versus women, all leading to inflammation, endothelial dysfunction, atherosclerosis, and then cardiovascular disease. So in conclusion, heart disease is still the #1 cause of mortality for women. There are unique risk factors that we've learned a lot about recently, and we still need to do plenty to close the treatment gap and the diagnosis gap in women. Thank you for your attention.
Wonderful talk, Dr. Cho. And chairpersons, Dr. Leslie Cho has to leave in next 5-10 minutes. So I think you can go ahead and initiate the discussion, ask questions or make comments, and then we can move on to the next lecture, please.
Sure. Dr. Mittal, sir, please take over and conclude this session. Dr. Mittal. Okay, I think we have a question for you, Dr. Leslie Cho. How common are the mental health issues in people you've been studying over the years who don't primarily report such issues directly? Any gender differences that you have seen, Dr. Leslie?
You're muted.
You're muted.
Please unmute. Yeah.
When we, that's an excellent question. When we look at our patient population, especially those that come to our clinic and they answer the depression and anxiety score, most people who have severe depression, they know that something is wrong and they're having issues. But people who fall into that range of mild depression, they're quite surprised that they have answered those questions. Now, whether the patients in mild depression have increased cardiovascular disease, we don't really know. But I think the one thing we do know is that even if you have mild depression, you're less likely to take your medications. So patients who have had heart attacks, people who've had bypass surgeries, patients who've had defibrillators placed, even if they have mild depression, mild anxiety, that leads to them not being compliant with cardiac rehabilitation, not being compliant with medication adherence. So we think it's such an important part that has become a routine assessment in our clinic.
Dr. Cho, I would also ask you one question. Except maybe psychosocial issues, most of the problems I could make out are related to insulin resistance. Whether it is hypertension or it is, PCOS. So have you done any studies saying that people who are having PCOS later on after pregnancy in the postpartum period or having pre-menopausal, preterm menopause, they were having GDM? Because if they had GDM, that makes them more prone to insulin resistance. And obviously later on, even in the postpartum period, they will have more of cardiovascular diseases, hypertension, PCOS, etc. And maybe they can start it on metformin right from the beginning in a way. If they have pre-diabetes and they have insulin resistance, if they are put on in metformin, maybe we can avoid all these complications which happen later on.
That's a great question. I mean, I think, there's been a couple of studies that have shown that obviously if you're overweight and all those things, you do have insulin resistance, but there are patients who are thin who have pregnancy adverse related outcomes who go on to have cardiovascular disease. So it's beyond, I think, insulin resistance. However, as you know better than I, people with, in DPP-4 studies, when you look at patients, I think it's the DPP-4, when you look at lifestyle versus exercise versus metformin versus, just a regular standard of care, patients who did best were patients that were on aggressive lifestyle modification and exercise. And while metformin is an excellent drug, I think the importance of lifestyle modification in terms of reducing diabetes later on, as well as reducing cardiovascular disease and cancer, I think cannot be underestimated.
And even ladies who have a premature menopause, maybe there is underlying insulin resistance there. And if you can manage that, maybe they don't have, we can make them normal. I mean, this is only a speculation. Maybe the studies can be done and they can be put on metformin to avoid this premature menopause.
I think that there are issues beyond just insulin resistance because I think there are some issues with endothelial function that changes. I think there's also issues about lipids that change with menopause, as well as platelet platelet coagulability that changes. So I do think that you're absolutely right that there are a section of patients in whom insulin resistance because of obesity or increasing weight may be the cause, but I think that there are other people in whom that may not be the central issue.
Okay, thank you.
All right.
Thank you, Dr. Mittal, and thank you, Dr. Leslie. It was a very wonderful session. And if there is no other question, I think with the permission of my co-chair, I would like to introduce the
Dr. Shekhar, there are 2 more lectures in this session.
I know that, yes. So that's what I'm saying. I would like to introduce the second speaker, Dr. Ankur Kalra. Thank you, Dr. Samir Dani, for that reminder. I think we've met earlier with Dr. Ankur Kalra when he was here, when I was there for one of the conferences. And after this gender risk factors, let us look more into genomics and what he has to talk about the jignasa that has been printed on the cards of this particular second topic of the symposium of gene, gender, and the CV risk. Dr. Ankur Kalra has been a cardiologist at the Cleveland Clinic with numerous specialties, interests, and he's also been editor-chief of so many peer-reviewed and cardiology journal, and has been authorized with several articles and others. So over to Dr. Ankur Kalra, and we are eagerly waiting to listen to you. Dr. Kalra, please.
Yeah,
Can
you
you
hear me now?
share the slides?
Yeah, can you hear me now?
Yes, 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 please.
Okay, perfect. I'm gonna share my screen right here. Is it working now, or can you see my slides or not yet?
Not yet.
Okay, let me see. Gonna share my screen now. Can you see it now or no?
Not yet.
You want me to start, sir, as you have shared it to me?
Yeah, I mean,
Sure,
that's
sure.
the reason
I
why
will share it just for you.
Perfect. Thank you.
So just for the transition, you tell me next when I have to.
Yeah, that sounds good. Yeah, you can just start playing those slides. Okay, great. Thanks. First of all, I really want to thank all the panelists for having me, present about Jigyasa, and special thanks to Dr. Dani for the invitation. You've been very kind through all our communications and interactions, and also special mention to both Dr. Mehta and Dr. Kapadia for introducing me to this wonderful audience. So with that, I'm going to get started on the talk. So Jigyasa, is a Hindi word. I'm sure the audience, a lot of whom would be familiar with our language, the Hindi language. Jigyasa, it means curiosity, and what Jigyasa stands for is Joint Initiative for Genomic Risk Stratifications by Urine Asians to identify premature heart disease in South Asians. So this is, one of my endeavors, if you will, or one of my dream projects that I really want to start working on, and have been sort of conceptualizing over almost a year now. As we actually speak, just next week, I have a special conference with Dr. Kapadia to see how we can move forward with this, but because we've made a lot of ground over the past 1 year to see if we can start working on this. So with that introduction, I'm gonna move to the next slide. So next slide, please. Okay, so want to acknowledge Alka Kanaya. I don't know if the audience knows about Alka. She is I believe a professor of medicine at UCSF, and she's I think has a background in internal medicine, and has had a lot of interest in South Asian health and South Asian heart health, and give her a lot of credit for establishing a cohort, the first of its kind, quite frankly, in North America, to specifically study South Asians. South Asians, like myself and Dr. Mehta, Dr. Kapadia, a lot of us are now residing in the US, and there is a sizable of us, enough for us to now specifically start studying some of the risk factors, both environmental and obviously genetic, because as we know, and I'm going to share in some of the slides that I'll be presenting, that onset of heart disease, particularly in South Asians, is premature. Somewhat also extrapolating from the data that Dr. Cho showed earlier in her talk. Next slide. So, so aims of the Masala study, and these are from the slides and data that Alka shared. So the purpose was to establish a prospective community-based cohort of South Asians in the US. And, the idea was to determine the traditional sociocultural, behavioral, and novel risk factors which are associated with subclinical atherosclerosis and type 2 diabetes. Again, just because this is talk on genetic risk factors and metabolomics and subclinical disease. I think this was one of the first studies which wanted to systematically study subclinical atherosclerosis in South Asians. The second aim was to compare the adjusted prevalence of heart disease and its risk factors to the other ethnic groups which were studied in multi-ethnic study of atherosclerosis, the MESA study. So the other four groups were Chinese, whites, African Americans, and Hispanics or Latinos. And then the last aim was to investigate factors which are associated with incident cardiovascular disease. So those were the main aims, or have been the main aims, of the Masala study cohort. Next slide. So I'm going to, here talk a little bit about the study design of the Masala study and sort of compare it with the MESA study, which I think all of us in the metabolic world or in the cardiology or cardiometabolomic world are aware of. So Masala, ages were between 40 and 84 years, and I think it's a good age range because a lot of the work that we've done through Pinnacle India Quality Improvement Program, through the American College of Cardiology, and others have done, Dr. Prabhakar in India, have shown that the onset, or also Dr. Salim Yusuf and from the Pure Study Group, a lot of these observational studies and epidemiological studies have shown that onset of disease in Indians or in South Asians appears to be at least a decade earlier, which is extremely worrisome. And as Dr. Cho was mentioning, some of these patients, have no risk factors at all, as we're gonna see soon. So Masala thought that they would have a cohort of about 900 patients with no existing heart disease, so no established coronary disease or I think primarily atherosclerotic heart disease, not valve disease. Only South Asians. They started recruiting patients at 2 sites, UCSF in San Francisco and Northwestern in Chicago. The first study was a pilot study of about 150 South Asians, which was conducted in years 2006 and 2007. A baseline exam was conducted somewhere between 2010 and 2013, and I'm going to go over the time frame of how they plan to conduct these examinations, because again, they're studying subclinical disease, they're not studying patients who have had manifest disease. So I think it was important to come up with a plan of follow-up so that they could prospectively follow these quote unquote healthy patients and see what happens to calcification or incident heart disease. And then the second exam was completed about a couple of years ago in 2018. So next, and I think Masala's MESA is going to show up. Perfect. Yeah, you can click one more time. Great, thank you. So MESA, or multi-ethnic study of atherosclerosis, in comparison with Masala, because Masala obviously was inspired by MESA, age ranges, fairly comparable. I would say anywhere between 45 to 84 years. 6,500 patients, again, with no existing heart disease. MESA studied a lot more ethnicities than Masala. Masala is specifically for South Asians. MESA, as I mentioned before, whites, African Americans, Hispanics, Latinos, and Chinese. Obviously had a lot more sites: Columbia, Hopkins, Northwestern, University of Minnesota, UCLA, and Wake Forest. And similar to Masala, but they had a lot more exams conducted for prospective evaluation for incident heart disease. Started in 2000, the 5th exam, so the 5th follow-up was completed in 2012. The 6th follow-up was completed in 2018. All right, next slide, please. So this is the timeline for the Masala study. And like we discussed, exam 1 between 2010 and 2013. So with all these 906 participants, as you can see at the bottom of the slide, they conducted blood tests. They conducted the glucose tolerance test. They obtained a coronary CT scan for calcium score. They did carotid ultrasound, and then they performed an EKG. And then, fast forward to 2018. So they now have data of on over 1,000 patients. So they have been able to accrue prospective data on over 1,000 South Asians, making it the largest South Asian cohort, which has been prospectively followed for that many years, almost a decade, within the US. and they've obtained some insightful information, information on how is the progression of the glucose tolerance test, or how is the progression of premature or pre-diabetes in South Asians, and also coronary calcium CT or and incident heart disease. So I think if someone is interested in South Asian health or South Asian metabolomic profile, I think I would encourage the audience to look up papers published from the Masala cohort, because you'll have tremendous insights on how disease is, about the onset of disease, and also how the disease becomes manifest, particularly in South Asians. All right, next slide. So, we know this. We know this as cardiologists, I'm sure, as internists or as, diabetologists or endocrinologists, that one of the most sensitive methods or techniques for measuring subclinical atherosclerosis, meaning you've not had manifest heart disease. So you've not had an acute coronary syndrome, you've not had stable angina or unstable angina, you've not had a myocardial infarction, you're apparently healthy, young, and you sort of want to understand, okay, I'm a South Asian, which, in my opinion, is an independent risk factor for having, manifest heart disease. And if you truly want to understand, your profile, your risk profile, I think obtaining a coronary artery calcium score is a very sensitive method of doing that. And what it does is it actually picks up plaque. So it picks up plaque which is calcified, and it's sort of stable plaque. The idea is that if you pick up stable plaque, which we know is a marker of incident heart disease, then you can sort of extrapolate and say just by the fact that you have stable plaque, you also have unstable plaque, and that puts you at a heightened risk for having a coronary event. So on the right side of the screen, you see the evolution of plaque. So there is a calcified shell, which then becomes a calcified plaque, and if then the plaque becomes vulnerable, that the core is rich in lipids, the fibrous cap is thin, and all it requires is for then to have the perfect storm of environmental risk factors, which would then result in plaque rupture. And then, all of us know what the cascade is. There's thrombosis, and then there's infarction. All right, next slide. So this is an extremely important slide. Once again, this is data from the Masala study, which was published in the journal Atherosclerosis by Alka Kanaya, as you can see, Kanaya in 2014. And what they did was they actually compared the evolution of coronary artery calcium score in various ethnicities. So in green is the white population, and all of us know that through all the data that have accrued in North America, a significant proportion of patient representation is actually white. So no surprises there that we have most data on and most follow-up in whites compared with other ethnicities. But you compare the graphs, so in green are whites, in red are South Asians, and you compare the graphs between men and women, and you see that the graph for men, the South Asian men, appears to be steeper, as one ages, compared with women. I'm sure to the audience who are listening, who predominantly take care of South Asian patients, this does not come as a surprise. But again, I think what was sort of interesting about this paper was that this was a follow-up, a longitudinal follow-up of just the progression of calcification, specifically looking at South Asians. So I think that this is an interesting data point and this interesting slide, that if you keep following your patients, and if you want to follow up with serial calcium scores, you'll see that the progression of calcium score is a lot steeper in men compared with women. And these are men and women of South Asian descent. All right, next slide. So this is actually a forest plot. What it does is it is essentially adjusting for all the traditional risk factors we know are associated with heart disease. So, just by the sheer fact that you're a male, so male sex, age greater than 45, they also looked at, educational status. They looked at smoking. They looked at body mass index, diabetes, hypertension, dyslipidemia, mixed atherogenic dyslipidemia, and use of any cholesterol medication. And then they looked at, they stratified the analysis by sex, so men versus women, once again, South Asian men versus South Asian women. And, interestingly, they compared it with, men and women of all the other ethnicities. So whites and African Americans and Latinos and Chinese. And what you see is that in comparison with all the other ethnicities, South Asian men in particular, not so much for women, as because you see the confidence interval for women is crossing the dotted line, but for men, for South Asian men, in comparison with all the other ethnicities, they appear to be at a significantly heightened risk for coronary calcification. We don't know why that is. Now, these are also men who apparently have no risk factors. So they could be in their early 40s. And I have colleagues, my family is in New Delhi. My father is a cardiologist, but also, several of, my related family members, cousins and extended family. We see this, I'm sure cardiologists see this in India more than any of the cardiologists here in the US, that, young South Asian men in their late 30s, early 40s, apparently with no risk factors, have a lot of coronary events. And this has been looked at by the cohort that Dr. Prabhakaran established with the Northwestern group and published in JAMA and Circulation, and also been looked at by an old study which was published in JAMA, the famous Joshi study, which was published in 2007. All right, next slide. So what about change? What about change in the calcium score? So I talked about the onset of disease. Now let's talk about disease progression. Okay, so we've talked about incidence of new calcium or new calcification, and then can you move on to the next one? And then we're going to talk about progression of calcification, which I think is another important endpoint to understand. So look at this. This is extremely provocative data, which was published last year, but also by Alka. And what she did was you can just click on another slide and it'll show you an asterisk. And if you could just press next on the slide set, can you click on next? Okay, great. So what it no. So go back one slide. I'm sorry. You can just go back one slide. Okay, great, perfect. So what it showed here, again, a similar pattern. You see that this is not only the incidence of new calcification, this is percentage change. And again, you see that the risk group, which stands out amongst all ethnicities, whites, African Americans, Latinos, and Chinese, is actually South Asian men in black. So South Asian men in black is the worst performing group for any new coronary artery calcification. All right, next slide. So next slide is even more provocative. So go to the next slide, please. Click once more. It'll show you, it'll highlight a particular section in red. Okay, great, thank you. So what you see here is progression in calcification. So not only incidence of new coronary artery calcification, now this is progression of coronary artery calcification. And what you see here is that in both the deciles, so 10 to 99, that's a decile of coronary artery calcium score. And then in 100 to 200, you see that the group which worsens the most is, again, South Asians. So 61 and 13 compared with 50, 47, 45, and 59, that's her first row. And second row is 11, 10, 10, and 6. So even numerically, the highest score, and this is change in calcium, not absolute calcium, is the highest in South Asians. All right, next slide. And this is, what she was alluding to here was that this is, despite the use of statins, because statins, I think, are the only drugs in our armamentarium which we can use, which have shown that there may be some plaque regression, but even despite the statin use, there was still faster progression of coronary calcification in South Asians. All right, next. Yeah, so we've sort of talked about this. So the conclusion so far from the Masala cohort has been that South Asian men had significantly faster calcium progression than men in all other racial or ethnic groups. And there were no differences in progression between South Asian women and other women, which is sort of reassuring for our mothers and our wives and our sisters and our daughters. And then smoking, diabetes, high blood pressure were associated with development and progression of calcification, which I don't think is a surprise to anyone in the audience. All right, next. So with that, I'm going to talk about jigyasa. So jigyasa, the rationale is to identify genomic risk in South Asians using polygenic risk score. and do this with an existing cohort of patients. For example, Masala, and I've been in talks with Alka, and she's been very supportive and collaborative. She has a collection of biosamples, so salivary samples and blood samples, and all that need is for us to do genetic testing and polygenic risk score, and then we can start looking into some of the genetic risk factors which have led to premature onset of heart disease in South Asians. So next slide. So with that, this is my nonprofit, and I sort of started a fundraiser for us to be able to do this study. The fundraiser was started earlier this year, and anyone who is interested in collaborating or contributing should log on here and see how they can help us. But as we speak, Dr. Kapadia and I are going to be meeting next week to see if we can make some progress in this realm. I know that there has been a lot of support from California. So with that, I'm going to stop, and I apologize for the background noise.
Yes, Dr. Mittal, Dr. Sheikh.
Yes, is Dr. Ankur going to stay with us, or do we take his questions now?
If Dr. Kalra is staying back, we will go ahead with Dr. Brumer's talk. Dr. Brumer is already here. Hello and welcome, Dr. Brumer.
Yeah, thank you very much, Dr. Mehta. And I would like to particularly first thank Dr. Dani and Dr. Mehta for inviting me, but I'll give it back to the chairs for a second. So.
Right. I think Dr. Dennis Brumer is one of the very star speakers of today's evening at this third session. And I think it's been a big privilege to introduce him. He's the director of the cardiometabolic health section of preventive cardiology and rehabilitation. He also is a blend who has got both endocrinology, both certified, along with the cardiovascular and comprehensive cardiology. He's got very, very focused research interest in the risk factors, intervention, and atherosclerosis. And his research has been granted by AHAs and the ADA and has been cited over 5,000 times. It's going to be a pleasure to listen to you, Dr. Dennis Bruner. Over to you.
Yes, thank you very much. I'm going to see if I can share my slides here. Can you see my slides and can you hear me?
We can hear you.
Yes, we can. We can hear you.
So again, I would like to thank Dr. Dani and Dr. Mehta for inviting me and for allowing me here to participate in this meeting. I would like to congratulate you first for putting together this symposium, because I think that this is a unique time for unique interaction between endocrinology and cardiology. And I think as we move forward over the next years, we will be interacting much more between, again, endocrinology and cardiology, because we think for the future have a big task to attempt to leave a footprint in kind of working around this small rise here, going back to an increase in deaths attributable to cardiovascular disease.
Dr. Brumer, can you please put it to slide?
Sorry?
Can you please put it to the slideshow? Enlarge your slides.
Yeah. Is this better?
Yes, thank you.
Okay, sorry about that. So while we try to leave a footprint here to work on this rise again that we note in the death rate that's attributable to cardiovascular disease. And this is mainly due to overall poor cardiovascular health. If we look at the 7 goals of the American Heart Association, particularly with respect to physical activity, diet, body mass index, and diabetes, certainly on the rise. So the problem for this, and particularly here in the United States, is that currently about 60% of the food consumption in the US is ultra-processed food. And this is, of course, driven by industry, highly palatable, highly caloric dense nutrition, all through the ranks from young to old. And ultra-processed food, of course, creates this dilemma of increased weight gain. This is a controlled study comparing ultra-processed food compared to unprocessed food, rise in body mass index, and actually rise in food intake associated with ultra-processed food. So not surprising with this rise is the increase in obesity. We currently in the United States have about 70% of the US population is either overweight or obese. And this then, of course, because of the close link between adiposity and insulin resistance, there's the prevalence of diabetes, which in the US currently is about half of the US population with pre-diabetes and diabetes. You're all aware of this tight connection. Has been many times discussed throughout this meeting. Now, what we are, of course, concerned about is the high prevalence of pre-diabetes in the United States and in other countries, of course. If you look at the rise in the hemoglobin A1C, as you're all aware, once you start even in the pre-diabetic range, there's about a twofold increase in cardiovascular event risk associated with being pre-diabetic. Now, if we look at what we have actually accomplished with respect to mortality in type 2 diabetes and death from any cause, you can see on this study here, published a couple of years back, that mortality has gone down, but still remains very high, so almost flat over the past 15 years here. So what I would like to do in the next couple of minutes, kind of give a very simplified overview of how do we manage risk for patients with diabetes, and how do we use comprehensive care to try to improve cardiovascular event rate in patients with diabetes. Now, this slide is very important because it summarizes what we're really dealing with when we're talking about diabetes and cardiovascular risk. You can see here, this is the prevalence of risk factors that circle around being diabetic. It's not just dyslipidemia, 70%, hypertension, even smoking is still quite common in patients with diabetes. Of course, you're aware of sedentary lifestyle and obesity. What this means is that we have to provide a comprehensive risk factor program to our patients that addresses all of these factors, and that really builds the foundation for collaborative networks between endocrinology, cardiology, and primary care physician care models. If we look at how do we attempt to treat our patients, what is the impact that we can leave? And these are a number of trials that I'm just going to briefly go through on those tools that we really have available to protect patients with diabetes. We have aspirin, of course, relative risk reduction, about 9%, statin, very powerful risk reduction, about 22% in many studies, blood pressure reduction, lifestyle. This was data from the Look Ahead trial. But what really leaves the biggest impact here for patients with diabetes is the combination of all these combined with lifestyle. This is data from the Steno 2 trial done in Denmark, showing a 53% risk reduction with a comprehensive care program consisting of diet, exercise, and medical therapy in patients at risk, yielding a 53% risk reduction in event rate. So it is really the combination of medical therapy with lifestyle that we should be using, but that's also part of the challenge. So if we currently look at in the United States, this is data from a large registry published about a year ago, looking at how do we currently treat patients with diabetes and pre-existing atherosclerotic cardiovascular disease. You can see Statin use is about 87%. PCSK9 inhibitor use in the United States is quite high in this diabetic patient population. If you look at ACE inhibitors shown here, the primary medication, now this is of course considering the date, this is probably was early in the GLP-1, SGLT2 inhibitor time, but if we look at the combination of all these medicines then, and look at what is actually the number of optimal medical therapy that we provide to our patients with diabetes and cardiovascular disease, estimated at about 7 to 10% of the patients receive optimal medical therapy. So certainly suboptimal, and certainly a lot of work to do for us. Now, what I'm going to be going through in the next couple of minutes is who manages these patients with diabetes? How do we currently care for our diabetic population? Of course, there's a primary care physician and the endocrinologist and the cardiologist. So I'm going to give you a couple of examples as to how are we doing on that perspective. Now, this is rural primary care physician practices in the United States. And if we look at hemoglobin A1C testing regularly as recommended by current ADA standards, so it's still about 20% of the patients get regular recommended hemoglobin A1C testing. Foot exams, very low. Dilated eye exam referrals, exceedingly low. Lipid profiles, we're certainly doing a little bit better. So there's much room for improvement in primary care physician settings. And if we look at the most commonly used medications, still for diabetes, second-line therapy for most of the patients still are sulfonylureas in about 30% of the cases right after metformin. Now, again, this is a couple of years back. I would expect that the use of SGLT2 inhibitor and GLP-1 receptor agonists has now further improved. So who then comes next after the primary care physician? The physician group that then we would talk about is the endocrinologist. And the endocrinologist really currently plays a very minor role in caring for diabetes on a large scale population basis. In the US, we have about 5% of diabetic patients seeing an endocrinologist. And the average wait time in the United States to see an endocrinologist is about 30 to 60 days. In 1987, the US generated about 140 endocrinologists per year. It is now down to 122 patients, 122 endocrinologists per year. The entrance and workforce per year is about 280 endocrinologists. And those 280 endocrinologists are certainly not able to take care of 100 million US people with prediabetes and diabetes. So hence the endocrinologist overall plays a minor role in this forces collaborative networks again between primary care and endocrinologists. So how do we do as cardiologists? And if we look at patients, this is a study published a few years back looking at how do cardiologists manage diabetes in patients that are admitted with an acute coronary event. And this is basically the proportion of patients that get an adjustment of their anti-diabetic treatment regimen when they're admitted with acute coronary syndrome. And if you just focus on this hemoglobin A1C group here, if the hemoglobin A1C is somewhere between 7 to 9, which in this trial was about 36% of the cases, only about 30%, 35% of the patient populations have an adjustment in their diabetic care. When the hemoglobin A1C is above 9, then just about half of the patients admitted with acute coronary syndromes to cardiologists have an adjustment in their diabetic care. So that leaves a lot of room for improvement, not just diagnostic for diabetes, but also management of diabetes is certainly suboptimal. And I think this has probably gotten a little bit better now because medications are available for cardiovascular event reduction in patients with diabetes, and cardiologists are becoming to become more comfortable to use of this. So this is a work published a year ago looking at who actually sees patients with diabetes. And this is the endocrinologist and this is the cardiologist. So this underscores the importance for cardiologists to become more comfortable in treating diabetes, because cardiology sees about 5 times more patient volumes with diabetes than actually does the endocrinologist. So it is really that cardiologists will need to become comfortable to manage diabetes. And this is going back, if we look back at who initially started to use statins, it was mostly the endocrinology clinics that started to use statin therapy 20 years ago, and cardiologists have become much more comfortable over time, and they will become more comfortable with using novel agents to treat diabetes as well. So how do we maneuver through this trial maze of data that we have available for diabetes? How do we manage the complex guidelines that are provided? When I talk to cardiology colleagues looking through endocrinology guidelines, it is just too convoluted and too complex. So we need simplified approaches for cardiologists to actually be usable, and cardiology-friendly approaches simplified for our colleagues to start to initiate treatment and manage this complicated disease. So what I will do is I'll share some of our approaches here at the Cleveland Clinic. For those more interested, we've just reported those. They're very much along the guidelines, particularly the American Association of Clinical Endocrinology guidelines, and along the European Society of Cardiology, ESC guidelines. So we basically use very simplified approaches. And you can just follow, I walk you through this because you're going to see that this is actually quite simple. So we have lifestyle therapy, we have obesity therapy, we have atherosclerotic cardiovascular risk therapy, and we have diabetes therapy. So those are the 4 cornerstones of recommended treatment approaches. Now, lifestyle therapy is probably the most challenging aspect of our care because it really mandates a comprehensive structure and available of resources and tools to treat diabetes and to treat behavioral support. So we need medical nutrition therapists, we need physical exercise physiologists. We here at Cleveland Clinic are fortunate with having all of this. We have behavioral support, behavioral contracting, cognitive and motivational support, smoking cessation program. We work very closely with our colleagues from sleep medicine. So these are all aspects. Patients certainly do very well when they enter a structured program with frequent encounters and frequent physician visit and appropriate timely adjustment of their treatment plans. I'm not going to go much more into detail here, but what comes next then is basically an obesity algorithm. And again, this goes very much along with the American Association of Clinical Endocrinology guidelines. Keep in mind, I'm talking about patients with diabetes and overt cardiovascular disease. So looking at obesity care, of course, lifestyle, again, is the first aspect of all care, but the obesity treatment algorithm, in addition to lifestyle, is basically after a body mass index above 27, we add GLP-1 receptor agonists for medical weight loss therapy. Those patients that have a body mass index above 35, we encourage early referral to metabolic surgery for risk factor control. So these are the 3 cornerstones of our obesity work: lifestyle, early initiation of medical therapy, and early initiation to metabolic surgery. Now, looking at the dyslipidemia and hypertension algorithms, these are fairly straightforward. We target an LDL cholesterol of less than 55. These are, again, keeping in mind patients with diabetes and cardiovascular disease. So by current guideline recommendations in the United States, their goal is less than 55. We intensify early statin therapy, we add ezetimibe, and we use PCSK9 inhibitor therapy very early. In our patient population here, we have about 30% of our diabetic patients already on PCSK9 inhibitor therapy. With respect to blood pressure management, again, very much along the guidelines. If the blood pressure is less than 150 over 100, we encourage early ACE and ARBs. If the blood pressure is above 150 over 100, ACE and ARBs plus second therapy, calcium channel blocker, beta blocker therapy, and diuretics. Of course, because again, these are patients with cardiovascular disease I'm discussing, we use a lot of beta blocker therapy in these patients. If not at goal, quick intensivation of treatment after a few weeks, adding the next treatment. We have other options here on the right. So talking about pre-diabetes and diabetes, that's the third aspect of these algorithms that I'm walking through. This is fairly straightforward. I think most importantly, the hemoglobin A1C goal for most patients with diabetes by current guidelines from the endocrinology guidelines in the United States is less than 6.5%. Of course, we use individualized therapy. We use dual therapy, starting with the hemoglobin A1C above 7.5, and most patients, unless they're very early in their stages, will require insulin therapy with above 9%, and that's where we work closely with our endocrinologists. So when we have patients with established cardiovascular disease, heart failure, or CKD, it is lifestyle therapy plus metformin. That is still part of the guidelines. Europeans have adjusted this. In European guidelines, SGLT2 inhibitors now have a class 1 indication over metformin. So the second drug we add is an SGLT2 inhibitor. The third drug we add is a GLP-1 receptor agonist, followed by additional treatments of the potentially DPP-4, basal insulin, or pioglitazone. Keeping in mind the GFR above 45, there's some on the right. These are some of the rules that we like to use in our patients, just because of the data that currently exists in atherosclerotic cardiovascular disease. We favor empagliflozin over canagliflozin for primary outcome data. And because of many of these patients may have peripheral vascular disease. Patients with heart failure, we favor dapagliflozin because of the DAPA-HF data. CKD from Credence, we favor canagliflozin. GLP-1 receptor agonist, liraglutide, semaglutide, dulaglutide are those three GLP-1 receptor agonists with primary cardiovascular outcome data. DPP-4 inhibitors we infrequently use because we favor the injectable alternatives for cardiovascular benefit. In patients with heart failure, we do not use saxagliptin and rarely use pioglitazone, obviously. So this treatment algorithm is pretty straightforward. We favor, of course, initiation of lifestyle therapy through structured programs that are transferable to other clinics. We have an obesity algorithm, LDL cholesterol, aggressive algorithm, blood pressure goal, and of course, the diabetes part that we discussed. So how do we improve the care for our patients? What is needed? Well, I think the most important aspect of our care is to avoid therapeutic inertia. This has been very well termed and coined, that physicians are hesitant to rapidly target to goals. So we favor early treatment intensivation, referral to specialized care centers. I think the cardiologist has a unique window of opportunity to diagnose and treat diabetes when the patients are admitted to services. I think multidisciplinary care teams are critical between primary care endocrinology, cardiology, nutrition, educators, and pharmacy. And we need updated guidelines, focused inputs, and true translation of cardiovascular outcome data with early initiation and titration of appropriate therapy with cardiovascular benefit. I think systematic treatment plans are important. I think it's very important that we provide a comprehensive approach, we standardize the approach, and we start to use quality tracking as to how we're actually doing. This is another, probably the second most important aspect is patient-centered care and empowerment, keeping in mind that diabetes is mostly a self-managed disease. For most of this care happens at home. We encourage patients to send us their logs. We have plenty of patients that send us blood glucose logs. We on a weekly basis where we quickly intensifies their care. So I will leave it at that, and I'll be happy to entertain any questions.
Very well said, very well alluded, Dr. Brunner. And I think we would really love your paper to read whenever it comes off the press. And over to my senior co-chairperson, Dr. Mittal, for his expert comment and to start question answer session. Dr. Mittal, please.
Yeah, Dr. Brunner, it was really a great talk, no doubt. And I think, but slowly as we having more molecules like SGLT2 inhibitors, so even the cardiologists are now, managing diabetes, I think, better than the past. And so it's kind of now cardio diabetology and a lot of conferences are there where both cardiologists and diabetologists are there together. So I think overall diabetes management is improving, no doubt. But definitely, I think it is both ways, whenever, like if we are not achieving the target, I think we should take the help of, each other.
Yeah, I think this is a unique time, of course, because for many years, diabetes care was much more complicated than it now is. I mean, we have oral agents that have very good data, support data that are easy to use with little side effect. We even have oral GLP-1 receptor agonists now. So I think the care has certainly over the past 5 years fundamentally changed and improved, and it becomes now much more easy for the cardiologist to start treating this disease.
One question I would like to ask you, or maybe Dr. Dani can, because related to more of cardiology. Now, with the availability of now bempedoic acid, especially in states, there is a combination available, ezetimibe and bempedoic acid. So now after statin, there is a very good medication now available, and I think it should be available in India also. So what is your take that people who are not controlled on statins and straight away, it can be, a combination of ezetimibe and bempedoic acid?
I think it certainly is a good combination for cardiovascular benefit. I think, again, keeping in mind that we target an LDL cholesterol of less than 55, we do see a fair amount of patients with statin intolerance, though. So I think the combination, we frequently defer very early to PCSK9 inhibitors, I have to say, because of their potency. I mean, when patients can't achieve their goal on statin therapy, the frequently ezetimibe and even the combination with ezetimibe and bempedoic acid does not get the patient quite to goal. So we then become very aggressive to use PCSK9 inhibitor therapy. Of course, costs being limited, but we have been quite fortunate with our program here in being able to apply PCSK9 inhibition to a large proportion of our patients.
And one more question I would like to, or maybe a comment regarding statin intolerance. I think, the number is not that high. It is actually the real statin intolerance is not much. If we lower the dose of statin, start in a lower dose, or maybe we switch over from lipophilic statins to hydrophilic statins. A lot of patients are on atorvastatin, which is a hydrophilic statins, and there are more musculoskeletal, side effects and, even myalgia. So we have to take this into consideration that, maybe if patient is on atorvastatin, maybe then rosuvastatin, and giving even now intermittent statin treatment, alternate day or maybe twice in a week or once a week has also shown benefits. So what's your take, related to, because it's no point in stopping statin just for some small side effects. I think we should give some time, decrease the dose, and try to, understand the problem and restart in a smaller dose.
Yeah, I think that's currently the recommended approach pretty much, but I think we do. So first of all, the patients that come in with statin intolerance, oftentimes, as you pointed out, there's not really, they may not really be statin intolerance. They may come in with some joint pain, some muscle pain, and say, well, we then frequently encounter a resistance to statin from the patient side. They just say, well, I don't want to take a statin anymore. And the patient says, at least from my experience, the patient says, well, I'm done with statins. And then we pretty rapidly advance to PCSK9 inhibitor therapy. If you look at the data, statin intolerance is, it's not infrequent. We estimate about 1 in 15 patients maybe. So, and I think the problem with the 3 times weekly alternative dosing, lower dosing, even in combination with ezetimibe, it's very challenging to get to the goal threshold that we try to achieve for our patients with coronary, keeping in mind the patient population I discussed, those are cardiovascular disease patients with diabetes. So we try to get early goal achievement, and with the resistance from statins towards statins that we deal with patients, I think many patients that we see, they much prefer to get a monthly injection. So I think it will become easier once we have RNAi-based approaches with once every 6 months treatment or so, which is coming, as you know.
Okay. Dr. Brunner, I think I would like to ask 2 quick questions. The first one is, in this talk of this gene, gender, and CV risk, if we add thyroid along with diabetes and obesity, would your algorithm change from CV?
If we add, sorry,
hypo or hyperthyroidism in this algorithm of diabetes and obesity, how would your algorithm change? Or major changes in your algorithm once thyroid also is into it?
I mean, if we add hypothyroidism, I mean, obviously we test for thyroid in these patients. Now, at least I don't treat hypothyroidism unless the TSH is above 10, period. Okay. And we see this all the time, that patients come in on 25 micrograms of levothyroxine because the TSH was 8, and this is because the patient goes to the doctor and says, oh, I feel tired, and that applies to 99% of the people. So I think there is an over-treatment. There is certainly an over-treatment of hypothyroidism with suboptimal dosing, if you will. And I shy away from treating hypothyroidism if it's not indicated, of course, unless you have a 25-year-old hypothyroid patient that wishes to conceive. So.
Okay, my second quick question. What are those 3 lifestyle changes that you would want to tell our population and our physicians, those who are listening to you? 3 lifestyle changes for risk factors.
If it tastes good, don't eat it. Okay. so stay away from eating out in the restaurant. And I tell my patients, set achievable goals. I think setting a weight loss goal of 1 pound per week, weighing yourself every day, recording your weight with a piece of paper next to the scales so that you can be feeling accountable, and joining a group program.
It was almost like saying, follow the COVID regulations, mask, sanitize, and hygiene. Stay away, don't eat, and cover yourself. Excellent session. And I think with the permission of my co-chair, thank you so much, Dr. Brunner, and over to Dr. Samir Dani and Rucha Mehta.
Thank you so much.
Thank you so much, Dr. Brunner, and thank you to entire team. We've had a wonderful session, and I see Dr. Pratley is here and Dr. Neeson is also joining in. So we need to move on to our next session. And for the next session, I would like to invite the panelists, and thanks to Altamash for always making it stimulating, of course, and Dr. Mittal, Dr. Harshvardhan and Dr. Meena Chhabra. Dr. Harshvardhan is a senior cardiologist from New Delhi. He's here with us today. And Dr. Meena Chhabra is a senior diabetologist from New Delhi to take over the session and introduce Dr. Richard Pratley, who will talk to us about the Vertis CV trial. And we look forward to it. And Rich, very nice to see you, of course.
Thank you very much,
Dr. Meena Chhabra or Dr. Harshvardhan?
Yes, thank you very much, Dr. Rucha. At the outset, first I'd like to compliment you and Dr. Dani for the wonderful program that you have put in. In this session, we're going to discuss about the Vertis CV trial, which was very recently presented last month in virtual ADA meeting. And this adds another drug to our armamentarium of SGLT2 inhibitors, that is atogliflozin. And to present this, we have with us Dr. Richard Pratley, who is Samuel E. Crockett Chair in Diabetes Research and Medical Director at Advent Health Diabetic Institute. He is a Senior Investigator and Diabetes Program Lead at the Advent Health Translational Research Institute. Dr. Pratley is an internationally recognized expert in diabetes. He lectures frequently, has conducted numerous research studies on the pathogenesis, prevention, and treatment of diabetes, and has published over 250 peer-reviewed articles on diabetes and its complications. He served as a member of the editorial board of Diabetes Care, The Lancet, Diabetes and Endocrinology, the Journal of Diabetes and its Complications, and the Journal of Clinical Endocrinology and Metabolism, and is an ad hoc reviewer for many other journals. May I request Dr. Richard Pratley to present us the trial Vertis CV.
Thank you very much. Let me share my screen. And are you able to see the screen and hear me okay?
Yes, sir, we see
Okay.
that. We do. You can start.
All right. Well, I am delighted to be here with you this evening or morning for me. I must say that this is not as good as my other trips to India, where I've actually been there in person, most recently in October, because I really enjoy India. I particularly enjoy Indian food, and I love meeting and talking with everybody individually between the programs. And hopefully we will be able to get to that point at some point in the near future. But in the interim, we are, I think, doing really well with our virtual meetings, which are allowing us to continue to share information that's really relevant for our patients. So in that spirit, I'm happy to be sharing with you results from the Vertis CV trial. We published this, or we presented this at the American Diabetes Association meeting in June, and we are going to be publishing the results shortly. These are my disclosures. And I'm going to start with the very basics, although this is a group, of course, that has broad familiarity with the SGLT2 inhibitors. I use this to point out that the SGLT2 inhibitors in this complicated diabetes guideline have a very prominent role. treating patients with a need to minimize hypoglycemia, treating patients who need to weight loss, and then finally, patients who have heart failure or chronic kidney disease. So in that context, we need to really understand the role of the SGLT2 inhibitors in all of them. The SGLT2 inhibitors, of course, work on the proximal tubule to decrease glucose reabsorption, and they're co-transporters, so there's also obligate sodium loss with the SGLT2 inhibition. The distal delivery of the sodium to the macula densa changes the glomerular filtration pressure. This probably has a beneficial effect for the kidneys, and it might also have some beneficial effects in terms of heart failure and other cardiac outcomes. So, as you are aware, our current practice to do cardiovascular outcome studies was based largely on
better audio at your end. Your audio is poor. Could you come a bit closer to your computer?
Yeah, I will certainly do that. So the FDA gave guidance in 2008, and this has been updated in 2020. But the sense of the guidance remains the same. We need to make sure that our cardiovascular outcomes for patients with diabetes are not worsened with our diabetes treatments. So in that context, the new diabetes drugs that were being studied in 2008 and later all had to do cardiovascular outcome studies. Here's the timeline for the ones that have reported out so far: EMPA-REG Outcome, Canvas Program, and Declare TIMI 58. And this has led to the need to adjust our guidelines, and that's why we now recommend SGLT2 inhibitors in patients with diabetes who have atherosclerotic cardiovascular disease, as well as those with heart failure or chronic kidney disease. Now, erdagliflozin is the fourth SGLT2 inhibitor globally that has completed a cardiovascular outcome study. So I wanted to put that into perspective. As you can see in the right-hand panel, the selectivity of erdagliflozin for SGLT2 versus SGLT1 is quite high, very comparable to empagliflozin. So it's a very clean molecule and a potent SGLT2 inhibitor. The VERTIS-CV study was initiated in December 2013, just when EMPA-REG Outcome, Canvas, and Declare TIMI 58 were underway. When the EMPA-REG Outcome data became available at the EASD in 2015, we took a look at the data and said, holy cow, we need to adjust the VERTIS-CV study. Initially, it was a 4,000 patient trial. We doubled the sample size to 8,000 patients and added efficacy objectives for both superiority of CV and renal outcomes. Our last patient visit occurred in December 2019, and as I mentioned, we presented the results in the ADA in June. VERTIS-CV was a true global cardiovascular outcome study with representation from North America, South America, preponderance of sites from Europe and Eastern Europe, but also representation from Africa and Asia. All told, 8,246 patients were randomized from 531 sites across 34 countries. Here's the design of the VERTIS-CV. This was, again, a multi-center randomized, double-blind, placebo-controlled, and importantly, event-driven trial. Patients were randomized in equal proportions to placebo, erdagliflozin, 5 milligrams, erdagliflozin, 15 milligrams. The primary outcome for this study was a composite of MACE, or cardiovascular death, non-fatal MI, and non-fatal stroke, and this was tested for non-inferiority. Secondary endpoints, which are tested for superiority, included a composite of CV death and hospitalization for heart failure, CV death, and a renal composite, which comprised renal death, dialysis or transplant, or a doubling of serum creatinine. And of course, there were other pre-specified endpoints as well. The inclusion criteria for VERTIS-CV included patients with type 2 diabetes above the age of 40 with an A1C between 7 and 10.5%. In VERTA-CV, all the patients had established atherosclerotic cardiovascular disease. This could be coronary, cerebrovascular, or peripheral artery disease. And they were stable on their background medications. And of course, there were some selected exclusion criteria as well. So the study looked like this, and all told, we had about 3 years and almost 4 years of follow-up in this study. There were 14,607 patients assessed for eligibility. Of these, 8,252 were randomized. It turns out that 6 patients were doubly randomized. They were excluded from this study, and the ITT population included 8,246. Of these patients, around 88% completed the trial. 8.5% to 9% died within the trial. Only about 4% discontinued prematurely, and we had vital status on over 99% of all patients. Here are the baseline characteristics of participants in the trial. Remember, they all had cardiovascular disease. 75% of them had coronary artery disease. Almost half had had an MI. Over 50% had had a prior coronary revascularization. And importantly, in this study, 23 to 24% had a history of heart failure. The remainder had peripheral artery disease or cerebral vascular disease. In terms of their background anti-hyperglycemic medications, they were treated with multiple drugs in most cases, metformin in about 75% of the patients, insulin in almost half of the patients, sulfonylureas in about 40% of the patients, and small numbers on DPP-4 inhibitors and GLP-1 receptor agonists. They were very well treated from a CV background medication perspective. Almost 80% on RAS blockers, 70% on beta blockers, calcium channel blockers, diuretics, and 85% on platelet aggregation inhibitors, including aspirin. 82% or so on statin therapy. So you can see that there was a high use of preventive medications in this population with established cardiovascular disease. Here's the effects of erdagliflozin on A1C over time. For the first 18 weeks, the sites were instructed not to change background therapy. And after that, they could adjust therapy in order to maintain glycemic equipoise and get patients to goal. You can see that there's the expected reduction in A1C with erdagliflozin, both doses, which amounted to about 0.8% and was typical of what we see with the class. Now, notably, over time, there continued to be a difference in A1C that amounted to about 0.5 percentage points for the duration of the trial. Here's the change in body weight. You're aware that the SGLT2 inhibitors cause a reduction in body weight. And what we saw was at 12 months, a reduction in body weight of about 2.5 to almost 3 kilograms of body weight change. And this continued throughout the course of the trial. So you can see this is a very stable, durable effect during treatment with erdagliflozin. And then finally, here's the effect on systolic blood pressure. Small reductions in systolic blood pressure, 2.6 to 3.2 millimeters of mercury that were sustained for the duration of the study. Here's the primary outcome of MACE, cardiovascular death, non-fatal MI, or non-fatal stroke. You can see that the event rate occurred in 11.9% of the erdagliflozin treated patients and 11.9% of the placebo treated patients. The hazard ratio was 0.97, and the p-value for non-inferiority was, of course, significant. However, this was tested later for superiority, and this was not significant. So it met its primary endpoint of showing non-inferiority to usual care. When we look at the 2 different doses of erdagliflozin, there was really no difference in the hazard ratio for the different doses of erdagliflozin. Looking at the individual endpoints of cardiovascular death, non-fatal MI, and non-fatal stroke, they too lined up around the line of unity with the confidence intervals crossing that line. Now, looking at the primary secondary endpoint of cardiovascular death or hospitalization for heart failure. This occurred in 8.1% of the patients treated with erdagliflozin and 9.1% of the patients on placebo. The hazard ratio here was 0.88 or a 12% reduction, and the confidence interval is 0.75 to 1.03. So the p-value for the secondary endpoint was 0.11, so it did not meet the superiority test. The secondary endpoints that were also tested included CV death. That was not significantly different, and hospitalization for heart failure. Now remember, this was tested in a hierarchical fashion, so although the significance is nominally significant, we can't call it as truly significant given the statistical plan for the study. At any rate, hospitalization for heart failure occurred in 2.5% of ertugrofloxacin-treated patients versus 3.6% of placebo-treated patients for a hazard ratio of 0.70, which nominally was significant. Finally, the renal composite endpoint. This composite was renal death, need for dialysis or transplant, or a doubling of serum creatinine. The hazard ratio was 0.81 with a p-value of 0.08. You can also see that for the most part, the lines were similar for the first 3 years of the trial and then began to diverge. So there's the numbers of the different events, and you can see nobody had a renal death. The need for renal replacement therapy occurred in very few patients, and all of this was really driven by a doubling of serum creatinine. Finally, a look at the EGFR. Typical of the class, there was a prompt decrease in EGFR of about 3 to 4 milliliters per minute per meter square. And then there was return of the EGFR, and it was largely sustained in the ertugrofloxacin-treated patients for the duration of the trial. Whereas in the placebo-treated patients in gray, you can see a reduction in EGFR that occurred over the duration of the trial. So at the end of the trial, there was a significant difference in EGFR relative to placebo. So now looking at the primary and secondary endpoints of the trial. MACE we saw was not significantly different. CV death or hospitalization for heart failure was not significantly different. CV death was not significantly different. Hospitalization for heart failure was different, although again, we can't call it significant because of the statistical analysis plan, and the renal composite endpoint bordered on significance. So summarizing the CV and renal outcomes in patients with type 2 diabetes with pre-existing atherosclerotic cardiovascular disease. Ertugrofloxacin, when added to guideline-directed secondary prevention therapies, was inferior to usual care, was non-inferior to usual care, sorry. The key secondary endpoints did not achieve statistical significance, but we did note this 30% lower risk for hospitalization for heart failure and a 19% lower risk for the renal composite. Overall, this pattern effects is largely similar to other SGLT2 inhibitors. And I wanted to show you that after we talked about adverse events. In Virtus CV, we saw the usual increase in genital mycotic infections, a slight increase in episodes of hypovolemia-related adverse events, but no increase in hypoglycemia or pancreatitis, as you would expect. Fewer patients numerically had acute kidney injury, and this was tested statistically. So there was renal protection with ertugrofloxacin in this regard. Numerically, more patients had amputations with the 2 ertugrofloxacin doses, but this was not statistically significant. There were very few episodes of diabetic ketoacidosis, but numerically more in ertugrofloxacin-treated patients, and the rates of fracture were similar. No patients in Virtus CV experienced Fournier's gangrene. So the safety profile was largely consistent with what is already known about the SGLT2 inhibitors, and the events of special interest occurred relatively infrequently. So to put this into perspective, we performed a meta-analysis of all of the SGLT2 cardiovascular outcome studies that had been published to date. And I want to remind you that we were able to test the significance of the point estimates, and we used Cochrane's Q-test statistic to create p-values, and the Thomson's I-squared estimates, which test the proportion of the observed variance attributable to heterogeneity beyond chance alone. So a I-squared of less than 25% represents low heterogeneity, 25 to 75% moderate heterogeneity, and above 75% high heterogeneity across the trials. The baseline characteristics of the study populations are seen on this slide, and you can see that for the most part, VERTIS-CV was quite typical. Like EMPA-REG outcome study, all of our patients had atherosclerotic cardiovascular disease. The numbers of patients studied in VERTIS-CV were quite similar as well. Age was representative. There were fewer females than there were in some of the other trials, like DECLARE-TIMI 58. The A1C was typical, as was the diabetes duration. And then finally, one thing that differentiated VERTIS-CV is that a higher proportion of patients had a history of heart failure. Now, looking at time to first MACE, which is the primary endpoint for most of these studies, you can see that there is variability among the studies. Both EMPA-REG outcome and CANVAS were significant. DECLARE-TIMI 58 was not, and then VERTIS-CV we've just talked about. And this pooled estimate was significant, but the estimate was 0.90, so a relatively modest effect on MACE. When it comes to time to first MACE stratified by the presence or absence of atherosclerotic cardiovascular disease, there was really no difference in that hazard ratio for those with atherosclerotic cardiovascular disease, and has been shown before. The VERTIS-CV didn't add anything to this because all of our patients had pre-existing VERTIS-CV. The point estimate for a reduction in MACE with those with no atherosclerotic cardiovascular disease was not significant. When it came to CV death, we saw more variance in the point estimates as well as the significance. So EMPA-REG outcome had a robust effect on cardiovascular death, and then credence tended to have an effect on cardiovascular death as well. But none of the other CVOTs demonstrated a significant effect on cardiovascular death. Here, there was a suggestion of heterogeneity with a p-value of 0.02 and an I-squared of 64%, suggesting moderate heterogeneity between the trials, largely driven by the EMPA-REG outcome study. In contrast, when we looked at time to first hospitalization for heart failure, you can see that the point estimates line up very nicely, and the pooled estimate of 0.68 is largely in line with all of the trials. Here, the p-value, of course, is not significant, and the I-squared indicating heterogeneity was 0%, which indicates essentially no heterogeneity between the trials. So this is clearly an effect that is common between all of the SGLT2 inhibitors. This is also true when we look at patients with atherosclerotic cardiovascular disease and those who did not have atherosclerotic cardiovascular disease. You can see that it really does not change that pooled estimate, nor the estimates of heterogeneity. And then finally, time to first renal outcome. You can see that there was some variability among the trials in their renal outcome. The p-value was 0.09 for heterogeneity, and there was evidence of a moderate degree of heterogeneity within the trial. So the summary of this meta-analysis, really the meta-analysis represents the totality of the data that's available for the now 4 CVOT trials with the SGLT2 inhibitors available in the US. These results largely confirm the effects of the SGLT2 inhibitors on both cardiovascular and renal outcomes. We saw the greatest magnitude of benefit for a reduction in hospitalization for heart failure and kidney disease progression. And the estimates for the effect on hospitalization for heart failure risk was really the most consistent across the trials. These data seem to indicate that the meta-analysis support the contemporary society recommendations to prioritize the use of SGLT2 inhibitors independent of glucose control considerations, particularly in patients with diabetes, with cardiovascular disease who are at high risk, and particularly those with heart failure and chronic kidney disease. So lining up the outcomes across the 4 CVOT studies, you can see in green those that were significant, in yellow that indicated safety. And for the most part, you can see that for all of the cardiovascular endpoints, the SGLT2 inhibitors represented a safe approach, in some cases associated with a significant benefit. There was more heterogeneity around cardiovascular death, but the hospitalization for heart failure endpoint was remarkably consistent. So one of the questions that frequently come up is, why are the MACE and CV death results different across the SGLT2 inhibitor trials? Well, one possibility is it represents the effects of different molecules. But as I've shown you, the SGLT1 specificity is really very similar and very high across all of the SGLT2 inhibitors. Could it be an off-target effect? We don't know. Are there differences in the patient population studied? I think this is probably one of the more likely explanations. We see certainly some different effects in primary versus secondary prevention when it comes to MACE, but are there regional differences? One area where there was a regional differences in the number of patients recruited from Asia Pacific in empagliflozin outcome study versus the erdagliflozin outcome study. Were there differences in the study design? I've shown you that by and large, the sample size was similar. The exclusion-inclusion criteria was largely similar. Definition of endpoints has been very similar across all of the trials, as has the collection of data and endpoints. These are all adjudicated endpoints. And the analysis approach is really standard. So it's unlikely that this represents a significant contributor to some of the heterogeneity. And finally, were there differences in the comorbidity management after 2015 and the empagliflozin outcome results? Well, there are some differences in recommendations during that period of time. We didn't see a lot of differences in drop-in of other glucose-lowering medications or blood pressure medications in VERTA-CV. And we saw some improvements in lipid management, but those also occurred in patients treated with erdagliflozin. So it's unclear whether or not this represents any significant contributor to the results, the different results. So just to summarize then, VERTA-CV achieved its primary endpoint of non-inferiority for MACE compared with placebo. So it's a safe medication for use in patients with diabetes and established cardiovascular disease. It provides further evidence for the CV safety across the class and adds to the benefit of hospitalization for heart failure, entirely consistent with the class. These data do not materially alter estimates of risk for any specific safety events, such as amputation, acute kidney injury, or diabetic ketoacidosis. And finally, the meta-analysis continue to support our contemporary society recommendations to prioritize the use of SGLT2 inhibitors independent of glucose control considerations for people with type 2 diabetes at high risk for CV and renal complications. So with that, I'm going to close and thank you very much for your attention.
Thank you so much, Dr. Richard Pratley, for taking us through the trial. But the trial has raised more questions than it has given us answers. So honestly, were you disappointed that there was no hint of reduction in major adverse cardiovascular events and cardiovascular death? And vis-a-vis the EMPA-REG outcome trial, although we are comparing two trials, a trial in 2015 and a trial in 2019, but there was a 14% reduction in MACE in EMPA-REG and a 38% relative risk reduction in cardiovascular mortality. So were you personally disappointed? Or?
It went beyond disappointment. I was crushed, to be honest. And we had every reason to believe that erdagliflozin should perform very similarly to empagliflozin. It's a very similar molecule. The potency is high. If you looked at effects on A1C, body weight, blood pressure, it's all consistent with the class. And the design of the study really mirrored that of the empagliflozin outcome study in terms of the number of patients, the risk of the patients enrolled. And if you looked at the event rates for the placebo group, the event rates in the placebo group really were pretty similar between the two trials. So we are still scratching our heads. And in fact, I've scratched my head so much, I've worn off all the hair on top in thinking about this, this problem. I think that, there are some explanations, and Dr. Nissen can certainly opine about some of those. We see this in clinical trials. They don't always turn out as you expect, and there is variance around those confidence intervals, which overlap by and large. There may be differences, in the types of patients that were recruited from these different sites, which were a little bit different in the VERTIS-CV study. So, I think that we take from this study what we can, which is, by and large, it mirrors the effects of the class, and that we still have very strong evidence that this class is great for patients with heart disease, as well as diabetic kidney disease.
Dr. Pratley, did you pay the price for recruiting more patients quickly, as the Savatimi also did? So did you pay the price of recruiting more patients because the event rates had not been reached, and so the confidence interval was raised, which was 95% with for MAZE, for EMPA-REG, and your confidence interval was 98, I believe?
Yeah, so that's one thing that was different in this study. In the EMPA-REG outcome study, people were recruited as a single cohort, and then when we had the modification of the study, we, this occurred about midway through the study, and we had to add another 4,000 patients. We used all of the same investigative sites, so that was one advantage, and probably wouldn't contribute to differences in the characteristics of the patients. And as you saw, our retention was pretty good within the study. But we've asked whether or not that those two cohorts, if you will, contributed to variance in the outcome. And they actually seem to track pretty closely to one another. It's of course very hard to figure out retrospectively what the actual impact was. But that is one difference in VERTIS-CV versus EMPA-REG outcome.
But I think, Dr. Pratley, I'll agree with you that in 2019, GLP-1 receptor agonists were used more because we had the cardiovascular safety data from the REWIND, from the trials, from the REWIND trial, from the LEADER trial. And probably, there were more people on GLP-1 receptor agonists like you just told us. So for the
well, there were. So we looked at drop-in of medications that could affect the outcome. And what we found was, the GLP receptor agonist use was pretty low in the beginning at baseline. It was about 3.5% to almost 4%. And it did increase over time. But the difference in utilization in the placebo and the ertugrofloxacin treatment arms only amounted to about 1%, favoring the placebo group. So it's unlikely that that really contributed to differences in the cardiovascular risk in the two groups. And as I've already pointed out, the event rates were pretty similar in the placebo-controlled group in our study versus the EMPA-REG outcome study.
May I ask a question?
Yeah, I was just going to invite any of the other speakers. Yes, sir. Please go ahead, Dr. Nissen. We are very happy to have you here.
Yeah. So thank you, Rich, for a really great presentation. And the question, of course, that comes up is a class a class? And notably, only one drug in this class strikingly increased amputations. That was canagliflozin. Now, why that happened, nobody knows, but perhaps there are some other off-target effects. So I have really two questions. What was the total number of events that the trial was powered for? That clearly will affect statistical power. And, we can then back calculate all of that. I assume it was powered for at least 90%. And so I'm guessing that you powered it for around 1,500 events, but I don't really know the answer, and I'd be very curious about that.
As I remember, it was about 1,300 events, which we achieved, because this was an event-driven trial. But I don't remember exactly the number, but good question.
Yeah. it is a very surprising result. I would have bet anything that this drug would have had very similar effects to Ampareg or the other trials. So I agree with you. This is a pretty big surprise.
This is why we do trials.
Yep.
Chance effect.
Do we have any comments from Dr. Harshvardhan, or I see Dr. DeFranzo also is maybe wanting to ask something, or any of the other panelists we have? We have a fully packed audience out there listening to all of you. So all comments are welcome because this is a very important trial for all of us. So Ralph has unmuted himself. So watch out, Rich.
Exactly. Now we have got another SGLT2 inhibitor in our armamentarium. And we know that the usage of SGLT2 inhibitors is increasing amongst the cardiologists in treatment of patients with diabetes and CVD. So when they have to choose between one of these four, can they be taken equally or one is to be preferred over the other? So can you give me, how do they compare with each other? So far as using in clinical practice is concerned.
Yeah, so in my clinical practice, I feel pretty comfortable if patients can get in on any of the SGLT2 inhibitors. That's our biggest hurdle, is getting them on something. And then in the US, very peculiarly, we don't get to decide who gets which SGLT2 inhibitor. It's really not a rational system. It's largely determined by the payers and the contracts they have with the insurance companies, so and the drug companies. So it's a very peculiar system. You know, I feel comfortable with using any of the SGLT2 inhibitors, and honestly, I use all of them in my practice. I think that when I'm talking to patients about the SGLT2 inhibitors, I generally talk about the class effects.
Dr. Pratley, is it right to say that, seeing the difference in results from these different trials, there still are some tissue-specific differences between each of these molecules? And then going further, do you think that it's time that we start stratifying the SGLT2 inhibitors just like we stratified pioglitazone, rosiglitazone, and all the others? For somebody with established CVD, the empagliflozin group does better, so empagliflozin comes in there. Somebody in the primary prevention group, dapagliflozin comes in. We have credence, which shows the CKD. Ertugliflozin shows only primarily a hospitalization in heart failure reduction, which stands out prominently. Rest of the parameters are not significant. So do you think it's time to probably think of tissue-specific differences and stratifications?
So in certain respects, I think that makes sense because this is, we have data for the different SGLT2 inhibitors in different indications like heart failure and chronic kidney disease. But I think it's a little bit of a slippery slope. So for example, the data with empagliflozin for MACE is entirely driven by cardiovascular death. So if you had a patient with MI, is this going to be a patient who experiences cardiovascular death who would benefit or not? Or, if you had a patient with stroke, there was actually an increase in the point estimate with empagliflozin. Would you not use the SGLT2 inhibitor in that circumstance because it might increase risk of stroke, but potentially could save their life? It's really hard to try to stratify when you look at the each of the individual outcomes. So I'd be interested to hear what other people think about that approach. I think it does make sense where we have robust trials like Credence with renal benefits in a renal population, and where we have DAPA with a heart failure population. I think that makes a great deal of sense.
Thank you.
I want to know that as you already showed that the higher use of ARNI or the PCSK9 inhibitors or even the SPRINT trial, they minimize the residual CV risk. But why there any penalty of statistics like in EMPA-REG you chose the confidence interval something like 95.02%. And for 3P MACE, 95% for all other outcomes. But here you choose 95.6% confidence interval for 3P MACE and 95.8% confidence interval for CV death or HHF. So what do you think? So this could be some penalty of statistics in this case.
Yeah, so in part that those statistical decisions had been made because of the hierarchical testing, but also because there was an early look at the data that helped to support the licensing of the products before the results of the trial actually were released. And so it's a kind of a convoluted statistical adjustment that you have to make. You know, the point estimates wouldn't have been affected by any of that. And those really didn't seem like they were going in that right direction anyway. If you'd had point estimates with kind of, that were closer to some of the other endpoints, then you might say, yeah, maybe the statistical approach penalized us. But I think in this case, it just didn't turn out as well.
I think Dr. DeFranco has been raising his hand. He has some comments.
Yeah. So I invented this class of drugs, did something stupid, not patented it. And that was the dumbest thing I've ever done in my life. But to me, like Rich and Dr. Nissen, I found these results really quite surprising. Everything, now I haven't worked extensively with this particular SGLT2 inhibitor, but I have a lot of experience with the other ones. And in my opinion, they basically do the same thing at the level of the kidney. And if there are significant differences, it's going to have to be explained by some kind of off-target effect of the drug that we don't understand. Now, we also need to remember that when you do studies, we use a p-value of 0.05. That means you can be wrong 5% of the time. And I have a feeling that this may be the 5% of the time, and it was just bad luck. I know this is kind of a drop-back explanation, but clearly I'm surprised, Steve's surprised, Rich is surprised, and I think everybody in the diabetes and cardiovascular field is surprised. But as Rich tried to point out in a subtle way, there are tendencies that this drug is doing what the other things are doing, the other drugs are doing, particularly the hospitalization for heart failure. That's one of the most characteristic findings. And we do see tendency in terms of the renal effects and other effects. They just don't reach statistical significance. And I have a feeling this may be a case where there's bad luck. I don't know whether Dr. Nissen or Dr. Prattley want to comment on this.
You know, Ralph, it's pretty hard to attribute this to bad luck. You know, they were well powered with 1,300 or so events. You know, it's probably 90% powered. So, boy, it's really hard. I mean, if this came in with MACE at 0.90 and didn't quite make significance, then I'd say, well, maybe it's bad luck. It's 0.99. I mean, it's close. Stone cold neutral. And so it's really hard to call that bad luck. It just didn't work to reduce cardiovascular events.
It's a problem.
It goes to point out that despite what we think we know, we still have a lot to learn. And we should keep doing it. Dr. Chabra?
Were there lesser number of Asian patients in the Vertis trial, lesser patients from Asia as compared to the EMPA-REG?
Yeah.
About 6.4% patients from Asia as compared to about 19% in EMPA-REG.
Right.
Do you think that could have influenced the geographical difference in the patients recruited? Lesser patients.
We have wondered about that because in EMPA-REG outcome study, the patients from Asia had the biggest effect. They were sort of outliers in terms of the population. Those in North America and Europe really had point estimates for MACE anyway that were closer to unity. So maybe.
I'm just going to interrupt you for a second and just say we need to end this session so we are not too delayed in with Dr. Nissen's talk. And as you rightly put, Dr. Chabra, that there are more questions than answers and we may never get done discussing this trial. So I'm going to thank all the chairpersons Dr. Pratley, and all the other panelists for their wonderful questions. And I'm going to now invite, and maybe can we have this, the chairperson slides for the next talk? Yes. So it's my great pleasure to, for the last plenary talk of the day, to invite Professor Ralph DeFronzo, who has been my professor, and he's the chair of the Diabetes Division at the UT Health System in San Antonio, Texas. He gave us an excellent plenary talk yesterday and needs no further introduction. We also have with us, and we are very fortunate, for every session, we've kept a cardiologist as well as an endocrinologist, diabetologist. So we have a balanced question answer session. We have Dr. M.K. Das, who's the president of the Cardiology Society.
You muted yourself, Rucha.
I'm sorry, was I not audible all this time?
No, you were muted after Dr. Ralph's introduction.
Okay. And then I'm sorry, so I'm just going to say I'm inviting Dr. M.K. Das, who is the president of the Cardiology Society of India. And he's a senior practicing cardiologist in the east part of the country from Kolkata. Welcome, Dr. Das. And also we have with us Dr. Usha Sriram, who has a special interest in cardiac diseases in women. And she's a senior endocrinologist. And she heads up an ASEER Foundation and has been very proactive for all of us young women endocrinologists and most all of us in the country. So with that, Dr. Ralph DeFronzo is here to introduce Dr. Neeson.
Yeah, thanks, Rucha. And Steve and I are great friends, so it's a real pleasure to be able to introduce him. You know, Steve is a very quiet, sedate type person. And Rucha looked around and said, I have to find a very quiet, sedate person in the diabetes field. So I think that's why I was asked to introduce Dr. Nissen. But I think anybody in the cardiology, endocrine, diabetes field knows who Dr. Nissen is. He is the chief academic officer of the Heart and Vascular Institute of the Cleveland Clinic. He's served as head of the cardiovascular division at the Cleveland Clinic. He's also professor of medicine at Weston Reserve. He, in the past, has served as president of the American College of Cardiology. He really did some of the pioneering work using cardiovascular ultrasound to show the effects of lipids in terms of resolution of plaque within the coronary arteries. Interestingly, we had this discussion yesterday and Steve's name came up with the Periscope study showing very similar results in terms of stopping the progression of plaque with pioglitazone. He's published extensively with over 500 articles. And I have to say, he's probably the reason why we're all here tonight. Because Steve was the person who raised the questions about safety of diabetes drugs. He has worked very closely with the cardiorenal panel at the FDA and was instrumental in convincing the FDA that we needed to really look at these drugs in terms of cardiovascular safety. And although there was, I think, some concern initially as to, are we just going to waste money on these studies and learn nothing? What we've learned has been incredible. So we've learned a lot about the SGLT2 inhibitors, their cardiovascular benefits, the GLP-1 receptor agonists. And quite frankly, if it wasn't for Dr. Nissen, these studies wouldn't have been done, and we wouldn't be having this cardiometabolic conclave. And now the bottom line is interesting. I just didn't know this, Steve, but you are recognized by Time magazine as one of the most 100 influential people in the world. That's pretty damn impressive. So I would like now to go ahead and introduce Steve to you to give his presentation, and thanks for joining us tonight.
Okay, someone else is sharing their screen, so I can't share mine until they unshare. So maybe Rich, you can unshare your screen.
I think now you can start sharing.
Now you can. Now you can share your screen.
Now I can do it. Okay, Ralph, that was extremely gracious of you. Really gracious introduction, and I'm just delighted to be here with all of you. You know, I have a great love for India, and as do a lot of us. And you know, Ralph, you've been an incredible leader in the diabetes field, and I can't thank you enough for all your work over the years and your very gracious introduction. I'm going to talk with you about something different. which is lipoprotein little a. This is an emerging novel target of enormous importance globally. And I'm going to try to convince you that we are on the verge of a breakthrough in treating this very bad disorder. So New York Times published this a year or two ago. They referred to this as a heart risk factor even doctors know little about. And I fundamentally agree that the New York Times was right about this. There's not a lot of knowledge in a lot of areas of the world, and it's going to be our job together to make sure people learn more about this disorder. So I would ask all of you to think about what is this and why is it relevant to lipoprotein little a? And yes, it is certainly atherogenic and certainly diabetogenic, but this is a Danish kringle. And it turns out that it has a lot of implications for lipoprotein little a, because lipoprotein little a, it contains these kringle domains, which are autonomous protein domains folded into large loops stabilized by disulfide linkages. These kringles are found throughout the blood clotting and fibrinolytic system. And the name comes from the Scandinavian pastry that I just showed you. They're found in plasminogen, hepatocyte growth factor, prothrombin, and apolipoprotein A. And here's what these kringle domains look like. They're these folded domains with disulfide bonds. And this is kringle 4 type 2, which plays a pivotal role in the structure of lipoprotein A and also plasminogen, which we're going to talk about. Now, it turns out that the more kringle 4 repeats you have in your lipoprotein A, the lower your blood level. And the fewer repeats that you have, the higher the level you have. So it turns out that genetically determined kringle domains are a key factor in who gets this disease and who doesn't. So what is lipoprotein A? Well, it's an LDL-like particle consisting of ApoB covalently bonded to ApoA via disulfide bond. We think it evolved from the plasminogen gene, the very important fibrinolytic protein involved in the clotting system. LPA has similar properties to LDL, but it is much more atherogenic, promoting both inflammation and thrombosis. It has many isoforms based upon these kringle repeats, and all isoforms contribute to some extent to atherogenic risk. So here's the structure. And if you look at the structure on the left, you see a structure with just 4 kringle 4 repeats. And you see over here, you see the kringle 4 repeats that are limited. And then you see the LDL-like particle with oxidized phospholipid in the center. On the right, you see many kringle 4 repeats. And those kringle 4 repeats, again, would result in a lower level. And then look at plasminogen, and you see exactly the same structure with all of these kringle repeats. So here's plasminogen, and here's apolipoprotein A. And you can see, in fact, why many people think that somehow or other this gene evolved from plasminogen to apolipoprotein A. So how does it contribute to atherosclerosis? Well, it's a dual noxious mechanism. On the left, you see the LDL-like particle and all the things that LDL does. I don't need to tell this audience, you deal with it every day. And on the right, the ApoA component, which is prothrombotic. And it does all of the things listed here on the right that are promoting clotting. So you got one particle that's both atherogenic and prothrombotic at the same time. So what are abnormal risky levels of lipoprotein A? Well, first of all, you have to understand, and I don't know what units you use in India, but in The US, most people use milligrams per deciliter, which approximately convert to these levels of nanomoles per liter. And so you're going to have to think about what system you use. We use milligrams per deciliter, and somewhere in this range of 50 to 70 milligrams per deciliter, risk starts to climb very quickly. So here's what the distribution looks in the general population. In blue, you see most of us. In gold, you see those people who have levels above 50 who have increased cardiovascular atherosclerotic risk. And that's true for both men and women, 20% of the population. It is also true that it is racially different. We think this gene evolved in Africa and migrated with the Great Migration from Africa, out of Africa, so that African Americans, Blacks, have levels that are substantially higher, shown on the left, than white or Hispanic patients. I am unaware of data on South Indian patients, but maybe someone on the panel can help me, let me know whether you've got such studies in India. So here's where we stand. In the US and globally, if you take this top 20% that have a very substantial risk, then there are 64 million Americans. There are 150 million in the European Union, and globally, 1.4 billion of our fellow citizens have this problem. And if you look at the top 10%, and these people have extraordinary risk, there are 700 million. So if you're in a room with 5 people, look around the room. One out of 5 of you has this disorder. And most of you probably don't know you have the disorder. It's a huge societal problem. The key insight here, by the way, that I want to make sure everybody knows about is that most assays for LDL are giving you LDL and lipoprotein A in the standard lipid panel. And so if you see people that you treat with statins and ezetimibe, and you declare them to be statin resistant, you know they're compliant, but their LDL level doesn't go down, you have to consider the possibility that LDL didn't go down because their lipoprotein A was extremely high. There are formulae for adjusting LDL for LPA mass, but they're not standardized. I'm going to give you a rule of thumb. If you, let's say you have a level of 120 for lipoprotein A, 120 milligrams per deciliter, probably about a third of that is going to get read out as LDL. And so your LDL is going to be inflated by additional 40 milligrams per deciliter when you measure it. And you can see that if you measure it at 100, the actual LDL component could be only 60. This is one of the few risk factors that diet and lifestyle do have absolutely no effect. These levels are genetically determined, and you can eat any diet you want. You can eat a vegetarian diet. You can eat cardboard boxes for dinner, which some people in the United States, think high fiber diets are great. Whatever you do, you're not going to change your lipoprotein A levels. It's purely genetically determined. And there are a bunch of SNPs that have been identified. I don't know whether these studies have been done in India. It'd be very interesting to know, but these are, basically mostly in America and Europe. If you've got the second SNP is really one of the more common. That's RS104555872. And you can see your odds ratio for coronary disease is around 1.7. It's approaching the odds ratio for smoking. It's a really big odds ratio. And some of the SNPs have even a higher odds ratio. It turns out that both of your alleles contribute to your risk. In this example, on the right, there is a patient whose one allele codes for 25 Kringle 4 repeats, the one on the left for 10 Kringle 4 repeats. So the left-sided allele gives you the levels in red, and then you're adding a little bit more because of the right-sided allele. Now, needless to say, if you have a SNP that affects both of your alleles to raise levels, you're in big trouble. And that's exactly what has been shown. With two variant alleles, the odds ratio for coronary disease is fourfold, 400% increase. One variant allele, 70 to 90% increase. So what's the actual relationship between lipoprotein A and adverse cardiovascular outcomes? Well, you see here that this is from Copenhagen. Again, it's European data, but you see that if you're below 5, your risk is set at 1. If you're in 5 to 29, your risk is up a little bit, but not significantly. 30 to 76, you're looking at 50, 60% risk. You get up here into the 90 to 95th percentile, you're doubling your risk, and you get above 117. I have many patients, fairly significant number of patients in my practice. Their levels are not 117. They're 300 or 400. And they've had myocardial infarctions in their 30s or 40s. We have to find these people for many reasons. This is yet another study, the emerging risk factor collaboration. And what you see here is, again, down here below 25 on the left, not much risk, going up at 48, then around 96 and on up to the hundreds, the risk is going up progressively. What about non-vascular risk? There's nothing there. There's just no effect on cancer, everything else, it has no effect. So it's a pure cardiovascular risk factor. And it doesn't matter who you are, whether you're a man or a woman, young or old, thin or overweight, with an HDL that's low or high, triglycerides, you can see there's no heterogeneity in the increased risk. Now, it turns out, however, that if you are Black, your levels are higher and your risk is higher. And so for the US population, where we have a very significant number of African Americans, we have to be vigilant to look for this disorder in African Americans, particularly if they have premature coronary disease. It also turns out that lipoprotein A is a major driver of aortic stenosis. Here is the relative risk. If your level is 3, not much risk, you get up to 40 and the risk is now beginning to go up, you get to 80 and you're about double the risk, and at 124, you're triple the risk of developing aortic stenosis. Very important finding. And in fact, the progression rate of AS, not surprisingly, is about 50% higher. This is just measuring peak velocity by echo. And people who are in the top tertile, which is above 58 milligrams per deciliter here, these people have a much more rapid progression. And their survival with aortic valve replacement is markedly reduced. They are twofold more likely to end up with aortic valve replacement or having non-survival if they have an Lp(a) above around 60 milligrams per deciliter. Well, what about statins? We all love statins. I know you certainly do in India as we do in the US. What do they do for lipoprotein(a) levels? What they do is they raise lipoprotein(a) levels, not by a lot, but by about a little bit. And so this is what rosuvastatin does to lipoprotein(a). It raised it about 10, 15%. And here is a meta-analysis of all the statin trials that measured lipoprotein A, and the net effect is about an 11% increase. So people will go from 90 to 100, something like that. It's not trivial, but you certainly can't count on statins to help you fix lipoprotein(a). So let's talk about current treatments. And the answer is there are none. That lifestyle changes, minimal effect, statins to lower LDL are reasonable, but they don't really do a great deal. Estrogen replacement is reported to lower LPA by a little bit. Niacin, yes, it does lower it, but we don't think it reduces events. PCSK9 inhibitors and reduce it a little bit, and apheresis can significantly reduce levels. It may decrease events, but it's very, very cumbersome. Aspirin has been reported in the Women's Health Initiative in people with genetically confirmed SNPs to decrease risk. I frankly am somewhat skeptical about this finding. Someone is unmuted and we're getting a bit of noise. There we go. Can these levels be pharmacologically addressed? That is the most important question now to be addressed. And it turns out that there is an approach. Dr. Mittal, I think you're unmuted. And there are really only one approach that works, and that's gene silencing. And what gene silencing is about is turning off the message to make apolipoprotein A. There are three approaches, two of which we are studying. One is to use an antisense oligonucleotide, and the other is to use a short interfering RNA. And I'll show you the approach that we're using now in our ongoing phase 3 clinical trial. And so you have the LPA gene, and the antisense oligonucleotide is a single-stranded DNA-like particle that then combines with the messenger RNA and is degraded. And you don't make apolipoprotein A. And so what we're doing here with antisense oligonucleotide therapy is we're turning off the message. This is an amazingly important approach that's going to be, you're going to be using this approach now in the next decade for multiple targets. But the target that we're addressing here is lipoprotein A. And the way it works is you give the antisense oligonucleotide, it gets into the liver, it then combines with messenger RNA in these hepatocytes that are making apolipoprotein A, and it blocks synthesis, and you simply don't make the apolipoprotein A. Now, in a phase 1 trial, first published in 2015, this antisense oligonucleotide developed by Ionis Pharmaceuticals in a dose-dependent fashion lowered lipoprotein A by an astonishing 80 to 90%. However, if you look at the doses used here, they're hundreds of milligrams. And there were some off-target effects observed. And so it's a crude approach where you give a lot of this oligonucleotide, you turn off apolipoprotein A, but you have the risk of off-target effects. And then a breakthrough occurred, and the breakthrough is using something known as GalNAc. I won't read you the long name of what it is, but it's a sugar, and it's a highly efficient ligand for hepatocytes. There's a receptor in the liver for this sugar. And so you conjugate this sugar derived from galactose, and you conjugate it with the apolipoprotein A antisense oligonucleotide. And it leads to a 10-fold dose reduction. It's more efficient at getting the antisense into the liver. And here's what happens. In blue, you see the original product with hundreds of milligrams required. And in gold, you see the conjugated GalNAc antisense oligonucleotide with this 10-fold improvement in the dosing. And here you see now the next trial, and this is now using the GalNAc antisense oligonucleotide. And you can see here almost, I mean, it's about a 90% knockdown with 10 to 40 milligram doses. Huge knockdown with a much, much smaller amount of the antisense oligonucleotide. Big breakthrough. And this went on into a phase 2 trial. And what you can see is that the top dose in humans in the phase 2 trial, published recently in the New England Journal of Medicine, but presented last year or in 2018 at the AHA. And you can see that it's very, very effective in a pretty good size 286 patient trial. So where we now stand is we're conducting, I'm the study chair for this trial, at 1,000 sites in 48 countries. I should have looked up whether we have sites in India, but I think we probably do. We're going to enroll about 8,000 patients with established CAD and levels greater than 70 or 90. It's actually stratified into 2 groups by level. They're on optimal background therapies. They get a monthly self-injection of this drug, now called TQJ 230, because the product has now been taken over by Novartis, or placebo for 4 years. We have 4-component MACE. We think this trial has enormous public health implications. However, we must find the patients and enroll them. And that's really hard because most places in the world, people are not measuring it. At the Cleveland Clinic, the cost for measuring this is about the same as the cost for our ordinary lipid panel. It's not an expensive lab test. I think more physicians need to know whether their patients have elevated lipoprotein A. Now, there are some guidelines for who to screen and who to measure. They include people with premature cardiovascular disease, people with FH, people with a family history of premature disease, people with recurrent disease despite statins, and you can see people at high risk. This comes from the European Consensus Panel. At the Cleveland Clinic, we measure this in virtually every coronary disease patient, and you get some incredible surprises. You know, I've literally found people whose levels are over 400, and we're getting them into our trial because even though it's placebo controlled, you know, for them, they got a 50% chance of getting the drug and knocking down their levels by 80% or more. We're very excited that after I've been, you know, after this target for decades, now for the first time in 2020, we've got an opportunity to actually treat these patients. Very exciting. I tried to make this talk a bit short so we'd have a little bit more time for questions, and I'm happy to chat with you about this concept. Okay, I can't, whoever's talking, I can't hear.
Yeah, I'm Dr. M.K. Das speaking.
Yes.
Can you hear me, Dr.
I can hear you fine.
Yeah. Yeah. It's a very nice lecture you have delivered, actually. I just want to go back almost 30 years back when I was doing my residency and was studying the various aspects of coronary artery disease. We found that the Indians are having the coronary artery disease almost 10 years ahead of the Western counterparts. Now, during that time, we are studying various risk factors and we're trying to correlate with the coronary artery disease. In fact, in one of my papers, I did that kind of work, and there lipoprotein A was taken as one of the risk factors, as it was coming out as a very, very important emerging risk factor that time, 30 years back. Now, we found around 30% of patients in our study
where we took up the younger generations, and ultimately we are trying for the intervention in those cases where the lipoprotein A was high. And there was only one drug that was available, that is the niacin. And we tried with the niacin, and we found that really the lowering effect of the lipoprotein A level. But to my surprise, I found that there was no, not only myself, but so many other workers, they found that it was not being converted. The lowering effect of the lipoprotein A level was not being converted to the, the reduction in the MACE or other events. Now, why is actually this happening when you are talking about the newer drugs like PCSK9 inhibitor or even this antisense genes? They are lowering the number of the lipoprotein A molecules, and they are being converted to the good results in terms of the MACE and all. But why it did not happen with the niacin?
Yeah, it's a very good question, and we went back and looked at the niacin trials. There were two. There was a trial done with niacin liraglutide, and then there was the AIM-HIGH trial. And what we found is that the amount of reduction with niacin was modest. It was nowhere near what we're going to achieve. Brian Ferentz published in JAMA Cardiology an analysis of the amount of reduction you need to actually get efficacy. And it's to get the same efficacy as we get from a 1 millimole reduction in LDL, we need about 100 milligrams per deciliter reduction in lipoprotein A. We think the mean levels in our trial will be about 130. And so we're going to get about 100 milligrams per deciliter reduction. It is also notable that niacin has some very significant adverse effects that may well negate the benefit on lipoprotein A. Take a look at the the AIM-HIGH trial, and you'll see all the bad things that niacin does. So I gave up on niacin a number of years ago. You've done the same thing in India, which is great, but it doesn't work.
Professor Nissim, I just wanted to first congratulate on this amazing talk. I think you have brought Lp(a) back into the radar of all of us. It was kind of the fashionable thing in the 90s. And Dr. Ines from Chicago, who's done a lot of the CARI study and has looked at Lp(a) with many collaborators from India. So there's a lot of studies on Lp(a) from India. I'm happy to share them with you. But what happened was we were given the impression that it's just a surrogate for LDL. So you just treat the LDL and don't worry about the Lp(a) was the kind of the final conclusion. And we moved on to the statins and ezetimibe. So I think that's where we stopped looking at Lp(a). And I'm really thrilled that you have brought it back into prime time.
Thank you very much. Let me just comment about this because we have this database. I shortened my talk so that I didn't show you the Cleveland Clinic data, but we have collected Lp(a) over the last decade in about 20,000 patients. And we've looked at them and we've asked the question, is Lp(a) still an incremental risk factor when your LDL is well treated with statins? And the answer is yes. It still represents an incremental risk factor, even when your LDL is low. And so we think it's a lot more than just the LDL component, that there's something very prothrombotic about this. That's why we think maybe aspirin's a good thing to give these patients because, in fact, most of them, had thrombotic events, and the antithrombotic effect of aspirin may be useful. We have a lot to learn, but we're going to learn a lot in the trial.
Could you also quickly comment on the isoforms?
Well, this whole business with the Kringle repeats. By the way, since we have an audience that contains a lot of endocrinologists, you should know that there are a couple of manuscripts that show that people with high LPA have a lower incidence of diabetes, and that it's related to the Kringle 4 repeats. So the isoforms just relate to these different Kringle, 4 repeats. And what we found is the Kringle 4 repeats are only one of several factors that determine blood levels. They're not the only factor that determine blood levels. So it's a little more complicated than I suggested that it was in my talk.
Thank you.
Dr. Nissen, hi, this is Dr. Samiran.
Yes,
we are very happy and honored to have you here. And thank you very much for accepting the invitation and delivering a great talk. As Dr. Usha said, Inas had done a lot of studies in South Asians living in North America and in India also. Most of the studies have pointed that roughly 20 to 25% of the coronary artery disease patients walking in our clinic have Lp(a) higher than 30 milligram percent. And another thing which was shown in that study was that Lp(a) is kind of a factor which amplifies the effect of other coronary risk factors. Like if you have Lp(a) in presence of diabetes mellitus, your coronary risk multiplies by 4 to 6 times. Similarly, if you are smoking and you have high Lp(a), your coronary risk goes up by 2 to 3% and things like that. So how does that happen? And do you think that Lp(a) of its own has a direct effect, or it has to have a presence of other coronary risk factors in order to increase the coronary risk?
Well, it's a really great question. First of all, I don't think we absolutely know the answer, but I'm not surprised that it is a amplifier of these other risk factors. And, it's something we'll take a look at in our database, which is, quite extensive. But in our database, even relatively low risk primary prevention patients at the Cleveland Clinic had increased risk over time. Now, you had to look out 36 to 48 months, but we measured mortality rates, and they were 28% higher. All-cause mortality was 28% higher, even in these relatively low-risk people. They didn't have a lot of other risk factors. Lp(a), because of its prothrombotic and proatherogenic properties, if you wait long enough, it catches up with you. And so one of the reasons I think it's good to find these people is, boy, if they smoke, you can say to them, look, if you don't stop smoking, you're headed for really big trouble at a young age. And so you're making a very, very good point that part of the reason why we've got to measure it is so we can take all those other risk factors off the table so those patients can live longer.
Yeah, and we have been measuring Lp(a) in all our young MI patients for last almost 20 years. And though we have not really studied them so well, one of the observations was, sorry?
I was just going to say, you're way ahead of a lot. I went to Johns Hopkins and gave grand rounds. I shouldn't probably say this because it's embarrassing, but I went to Johns Hopkins and had an audience of about 100 people. And I asked them to raise their hand if they routinely measure Lp(a) in young patients with coronary disease. And 3 hands went up. I did the same thing at Houston Methodist Hospital, and 3 or 4 hands went up. Most people in America aren't measuring this, and that's a really big problem.
I chanced upon it because of a problem in my family.
Yes.
My own uncle, my paternal uncle, husband of my father's wife. So he and his family had a very, very bad atherosclerosis history. Nobody for last 4 generations had gone beyond the age 65. And almost everybody had a atherosclerotic vascular death. And I lost my cousin who was a doctor and who was responsible for bringing me into medicine. He died in US. He was a very fit person, a sports person actually. He was a studying budding neurophysician, and he died at the age of 32. He was found dead on one of the Colorado mountains while trekking. And they autopsied him and found a triple vessel disease. And nobody knew. He was an avid tennis player. He was a tracker. He was wonderful athlete. So then we checked. I had just come across some studies on LP little, and we checked one of my other cousins, his younger brother's LP little a, and it was 120. And then I checked my deceased cousin's daughter, and her LP little a was 120. So then we started looking at it. And another observation, I will not go into details of these, but another observation was that many patients with LP little a who had high LP little a came back with DES restenosis. So we are looking at those patients who have DES restenosis. We try to check their LP little a levels. Another association is with insulin resistance, and I would like to know from Ralph DeFronzo and you whether there is any such study between LPA levels and insulin resistance.
I don't know of any data. Ralph, do you know of any data? Are you muted, Ralph? We may have lost.
He's there. He needs to unmute. He's doing it.
Yeah, I'm back now. Yeah, I have to say I'm not aware of such data, but you know, as part of the insulin resistance syndrome and the metabolic syndrome, you would think that someone has looked at it, but off the top of my head, I cannot quote such articles.
We have a question in the chat box from the audience. Is there any correlation to lipoprotein little a? Any implications with HDL levels also by Dr. Shweta?
To my knowledge, there is not any relationship. So, you know, we're taking all comers, but we'll look at that subgroup, of course, in the clinical trial, and we'll see people with high HDL and low HDL and see if it makes any difference. But to my knowledge, I don't think that it does, at least not from any of the published series.
Dr. Nissen, I have got another query. The query is, so far we are teaching and we are expressing this particular comment that coronary artery disease, or for that matter, atherosclerotic cardiovascular disease, is a lifestyle disease. Now, you know, so far the lifestyle disease is concerned, there are so many risk factors, not 10 that have been mentioned in the intra-heart study or other studies. There may be 20, maybe 50 or so. And all of them have got single mechanism of action, that is the pro-inflammatory action. Now, lifestyle as well as exercise, both of them have got tremendous effect on the inflammatory process. Now, as you have already highlighted, and we also know that the lipoprotein A causes inflammation. Apart from the plaque formation, it also is prothrombotic. Now, why lifestyle disease and exercise? In fact, in India, and also it has started elsewhere, the yoga. Yoga is a concept which is a sort of holistic one, and that has got some mechanism to influence the, you know, the inflammatory process. Now, why lifestyle and the dietary mechanisms are not actually influencing the lipoprotein A mechanism?
Well, it doesn't influence lipoprotein levels, but we're not telling people who have high lipoprotein little a not to exercise, not to, you know, eat right. I mean, we want them to do all those other things, because the difference between, you know, I mean, that the story I heard from your colleague, you know, age 32 physician dies while walking in Colorado with triple vessel disease, and his whole family's got this disorder. We see this everywhere, and we got to find these families, and we got to intervene, and we got to tell them to do this. Now, I have to tell you that your question turns out to be really important. please look at this week's JAMA Cardiology, because there's an article from our group on the relationship between CRP levels and outcomes with high Lp(a). And I'm not going to tell you what it shows. Just, pull it up, look at it, and see what you think, because you asked the question, and I think we have an answer for you.
We have Professor Amalia Gastadelli, who has posted a comment on the question about insulin resistance and lipoprotein(a). Amalia, do you want to?
Yes, Dr. Nissen, congratulations for your presentation. It's very intriguing. And I'm mainly interested in liver disease and fatty liver disease, but also, insulin resistance and diabetes. And I have a long-lasting collaboration with Professor Ralph DeFronzo. Well, actually, there are recent studies that are showing an inverse relationship between insulin resistance and lipoprotein(a), and also NAFLD and lipoprotein(a). And I was expecting exactly the contrary, because the more liver fat in the liver, the more you try to get out of this by increasing lipoprotein secretion and VLDL. So I was expecting exactly the opposite. So I was wondering if you could have any idea why this is happening, because we know NAFLD have an increase in VLDL. So, and also they are more atherogenic, they have more cardiovascular diseases. So it's quite an unexpected result. This is a Korean study with over 2,000 people, if I remember well.
Yeah. Well, your question's a very good question. First of all, I've looked at much of these data, and of course I didn't include it because I could have made this talk 3 hours long, so I didn't talk about this. But there is some evidence that somehow the Kringle repeats have an effect on the incidence of diabetes. And so people, it looks to me like people that have more Kringle repeats have less diabetes and probably less insulin resistance. It may, in fact, be one of the reasons why the gene has persisted. I don't understand it. I don't know the mechanism. These are observations. We're going to look at all of these things. Most of the things that have been looked at are in retrospective observational studies. We've got a pretty big prospective randomized trial that's going to let us look at a lot of those questions about diabetes and insulin resistance. And we're collecting a lot of information that we can then report back to you that may be of some help in understanding this atherogenic particle.
We have a question also. Amalia, does that answer your question? I'm sorry.
Yes, perfectly.
Okay, thank you. We have a question from Dr. Chitranjan Yagnik. He's the one who does a lot of genetic work in India. Dr. Yagnik, I think you're on the panel. He's asking, is there any information on lipoprotein(a) changes with bariatric surgery?
To my knowledge, there isn't. We've done a number of randomized controlled trials. Interestingly enough, we are in the process of working with the NIDDK and NHLBI on a 3,000 patient multi-center randomized controlled trial of bariatric surgery versus optimal medical therapy in diabetic patients. And we're going to get all these biomarkers in those patients to learn as much as we can. And so we're going to get a chance to answer the question. If the NHLBI, if the NIH funds our trial, we're going to be able to give you an answer to that question.
We look forward to that because we do have a bariatric surgeon on the panel as well. I have a question from Dr. Purvi Chawla, and she's here. Do we know the effect of dietary traits, low fat, low carb? What would be a good macronutrient manipulation or a low calorie diet on lipoprotein(a) or any lifestyle, especially diet?
This has been studied, and it has none of the diets have any effect at all. We cannot show any effect whatsoever from diet. Keep in mind that you've got these two alleles sitting at the LPA gene, and those alleles determine your level. As we heard from your colleague who has a huge family incidence here, everybody in the family, no matter what they did, I mean, even the guy who's completely fit, who's a tennis player and an athlete, has high levels and gets premature disease. He probably was thin, he probably ate well, but it doesn't make any difference. I wish it did, but it doesn't.
Great. We have a follow-up question on this. Somebody is asking, so should we be looking at nutrigenomic diets or nutrigenetics, and would that be helpful for
Well,
the Indian
I don't know
subtype?
what nutrigenetics are, so someone's going to have to educate me about that.
Maybe Amalia wants to answer that. I'm not sure.
My
repeat?
question is that although it is a very great lecture by you, so you told that the lifestyle modifications had not much role in reduction of the LPA. So you showed it. So this is a bit. I wonder what is the evidence for that? Because although it is true that in many cases of the MI, when we screen, the lipid profile is normal, even the LDL is normal. We don't go in all cases in our setting to screen for the LPA. So what will be the your message to a practicing physician? What to do in such cases?
Okay, let me just say something I think is important here. I am not saying that we shouldn't have people eat heart healthy diets, exercise, and do all these other things. I'm just telling you it doesn't change their level of lipoprotein A, but it may lower their risk, and probably does, because as somebody said earlier, these risk factors are additive and maybe even synergistic. So what I tell patients that have a very high lipoprotein A, and I will tell you something, I have as patients some really, really famous people who have levels that are measured in 200, 300, 400. And, they're out there in the public arena and they want to continue to work. Some of them are politicians. And what I say to them is, eat the healthiest diet you can, take an 81 milligram aspirin a day or 75 milligrams or whatever you use in India, and do all these other things. Don't smoke. Get your LDL down to very low levels. And you may have an MI, but you're not going to have it probably in your 30s. You may have it in your 50s or 60s or 70s, and by then we're going to have an effective treatment for you. So what you're suggesting, doing the right thing for these people, is very, very important. You're just not going to lower their LPA levels, unfortunately.
Thank you. Amalia, the previous question was, should we be changing, should we be using nutrigenomic diets or nutrigenetics to understand these markers? And there's a follow-up question also that Indians have a high carbohydrate content. So what can be an indicator that we can use for the general population that could help us to guide diet if you suggest so?
Well, I just don't have any data. To our knowledge, high carb, high protein, low carb, that just doesn't seem to affect this because of its genetic nature. And so, I'm very skeptical that there is any diet out there that will alter these levels. A good diet may lower overall cardiovascular risk, but the incremental risk from lipoprotein A is genetically determined.
Thank you, Dr. Neeson. That question is from Dr. Vanisha Nambiar from Vadodara. And I want to make sure the message is we still all need to eat healthy and stay healthy and exercise. We just don't have data to show it may work otherwise. So there are still questions, but in the interest of time, if there's anybody on the panel who has any comments, Dr. Pratley, I see you're still there. Ralph, if you have any concluding remarks.
Yes, Steve, I have a question. Because actually we could answer this depending upon what you think. So in the ACT NOW study, we studied all these pre-diabetic people. They're all very insulin resistant, and we treated them with pioglitazone. Yes. If you might have some interest in measuring the Lp(a) levels, we have a pretty good measure of insulin resistance to look at the association. And also whether or not you may already know the answer to this question, is whether pioglitazone affects the levels.
I don't know the answer, and we would be really interested in finding out. And Ralph, let's talk offline about it. Maybe we'll make some new science here.
All right, I'll send you an email.
So let me just say
a comment and a question to Dr. Neeson. Sorry, please go ahead.
Well, I was just going to say that this has really been an excellent session. I was delighted to be part of it. I learned something from all of the lecturers, and I want to congratulate Dr. Mehta and the chairs on putting together a really great program.
Thank you so much.
Thank
And
you.
we've
Thank you,
enjoyed
Dr.
having
Bradley.
all of you here.
I just wanted to have a last question to Dr. Nissen. Can I? Dr. Nissen, I tell all my patients that if you have high Lp(a), reduce your other risk factors more diligently, more aggressively, because that may help you in reducing the overall risk, though we don't have any medicine for Lp(a).
Yes.
Having said that, once I tell them this, they are onto measuring Lp(a) serially. Even without my prescription, they would go and get the Lp(a) measured and then come back to me that it went up by 10 milligram and went down by 10 milligram, and does it really mean anything? Do you have any data on serial Lp(a) measurements?
We actually do, and we agree with you 100%. You get it once in your lifetime, and it just doesn't change. And the assays are a little bit different. And so if you go to a different hospital, you might get 10 milligrams higher or 10 milligrams lower. It relates to the ELISA antibodies that are being used. But we've got data on all those antibodies and what they actually do. But the level's not actually any different. It's genetically determined, and it's a waste of money to get it over and over again. I completely agree with you about that. I'm glad you made that point.
Thank you.
Great. And if there are no more questions or comments, then I think we will go ahead and I'll invite, I thank Dr. Nissen for this talk and the chairs of this session. Dr. DeFranco, that was an excellent introduction. We are going to keep on replaying it because we recorded it, and have a nice laugh at with the nice introduction. With this, I would like to invite Dr. Dani to offer the vote of thanks and close our Global Cardiometabolic Conclave, and I will just come back for a few seconds at the end.
Okay, I'm not supposed to speak much, but I don't think I cannot speak much. It has been quite an amazing journey over the last 2 days. We started with cardiometabolic syndrome and its reach, its genetics and drugs for prevention. Then we heard and discussed about origins of diabetes, pre-diabetes, and awe-inspiring insulin resistance talk and cardiometabolic risk in children. Then we heard about preserving renal function in diabetics, other diabetic complications, how to diagnose and treat diabetes, what interventions to offer in diabetic coronary patients, and we have discussed whether diabetics need a different stent and what should be the antiplatelet and antithrombotic strategy in them. We have heard about double diabetes, how to prevent and manage diabetic heart failure, whether half-PAF or half-REF, what drugs to be used to prevent and treat heart failure in them. To top it all, we heard about the reversal of diabetes, as well as little bit of hypertension and young coronary artery disease. Surprisingly, we didn't forget liver and its role also. Then we heard about cardiac complications of obesity, how to manage them, how to treat obesity medically and surgically. Then we had quite a bit of nutrition and culinary science going on side by side in other hall as well, exercise parading with them, and it was as interesting and as popular. COVID also silently slipped in, as the current affairs usually do. And then we had CV risk factors in women and lipids and other CV risk factors, comprehensive risk assessment, discussed threadbare, and this Lp(a) talk was an icing on the cake. You will all agree with me that this was an exciting, exhilarating, and liberating journey. I thank you all for being there with us and participating in this great journey through Galaxy of Science with the stars. I thank all the star speakers for giving the right direction to this journey. I would like to thank all our support staff at the back end, in the back room, RX Events for organizing all this, especially our friends on the advisory and executive committee who selflessly toiled as per our whims just because they are great friends. I have thanked everyone in particular without giving names, as I'm sure I will forget some important names, which I don't want to do. And my co-chair is a very particular person. So for names, I would give the mic back.
No, thank you, Dr. Dani. And I'm just going to play a short video. When the journey began yesterday, we actually played a little video that says the journey is starting. And I just have a little less than a 1-minute video we are going to play to show you what Dr. Dani just spoke about. So Hardik, can we just play this video and then we'll close the session and let everyone get dinner or lunch. So thank you very much. For those who are Star Wars fans, will know that I have stolen those lines from the latest Star Wars series. So the story, the saga ends, but the story lives forever. The lessons we have learned here today will live in our minds forever. And I certainly put a thank you to the delegates first, because without them, this conference would not be successful. Just so you know, even for this last conference at this late hour in India, it's been pouring and we've been holding our breath that technology does not fail us, because it was pouring over here. It's the monsoon season. We had 2,000 plus audience. So it has been amazing, lots of lessons. We've reached all over the globe. As you can see, we have all these people from all over the world. And so we are really, really thankful to all of you. Thank you. I'm not going to name any names. And with this, we will close our sessions for today. We have made an abstract book. We had a recipe contest and we've got close to 30 entries with healthy dietary entries. We are going to be mailing all these books to the delegates, and the abstracts and the articles we have received from all the faculties. Also, we have compiled a book. Now we can reveal that the videos will also be available for the next 30 days in case you did not get a chance to listen to any of the talks. So we have all this amazing science to look forward to. And with this, I will close our sessions. A big thank you to all of you. Thank you very much. Thank you. Thank you, everybody. Thank you. Bye, Amalia. Bye, Ralph.
Bye, everyone.
Bye-bye.
Bye, Bansi.
Bye, Dr. Ralph. Bye, Dr. Nisan. Thank you so much.
Bye,
Dr. Das, Dr. Das, thank you so much.
Yes, thank you very much, Dr.
Bye.
Dani. Congratulations to both of you.
Thank you so much.
Thank you. Hi, Dr.
This is the
Bansi.
after party.
Hi.
Hi, Praful.
Come over.
Virtual after party.
I know, you will not mind. Yes.
We should try that.
Yes.
Unfortunately, we are in Ahmedabad, you know.
It's being recorded, Praful, just so you know.
So,
Thank you, Dr. Pratap. There's Ramesh. Thank
you
you.
had a good sort of Reiki for the annual conference of CSI as well.
Let's go virtual.
Thank you.
Thank you, Hardik. Very
Hardik,
good.
thank you.
And Rucha should be involved in that also.
Oh my gosh, no, I think one conference per year is what I can handle.
Yeah, Dr. Das, you can
Thank you,
make
Dr.
her a
Das.
member of CSI, I think.
I already am cardiometabolic.
In the organizing teams, you can involve her.
I know, I don't think anybody will make the cardiologist work so much in the last few days. I'm more than happy, sir. I'm more than happy.
Bye-bye.
Thank you, Dr. Das. Wonderful questions.
Okay.
Goodbye, everybody. Thank you.
Bye-bye. Bye.
Bye, everyone.
Ramesh, we are waiting.
Yeah, I am waiting for virtual meal.
Okay.
Okay, great, everybody. Bye.
Thank you.
Bye-bye.
Bye.
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 the diabetologist knows only one international name, that is Steve Nissen. And they know the Ralph equally because of the
Thank you, Hardik sir. Can you hear us? कहाँ है पता नहीं कहाँ है
चलो बंद हो गया हार्दिक है तो सही
नहीं पर वीडियो नहीं दिख रहा है सर का आ गए अरे सर तो पार्टी करना स्टार्ट कर दिया सर ने
पार्टी कर रहा है
रिकॉर्ड हो रहा है
वेल हाउ कैन यू डू इट
हमारा वीडियो कहाँ है बट
हार्दिक मैं आ रहा हूँ ऑफिस देख
हमारा वीडियो एक्सेस जा चुका है बाय